We have faculty joining us from all over. It's been a great pleasure to bring all the nations together in this endeavor, and this is the second time with IOTA. We are trying this. Last time was during COVID times. Um, we have my great friend and president of IOTA, Ted McLeod. Ted, on to you. If you want to say something for the meeting, please.
It's good to be part of our big international education. For those who are listening or present and we're wondering what the International Orthopedic Trauma Association is, the Indian Trauma Society was one of the founding members of the organization 7 years ago. And we started with 12 organizations with the idea that we would create a society of societies that would participate with each other and collaborate such that their membership would benefit from international collaborations between these organizations. And this conference is an example of how that has functioned. The IOTA has now grown to 25 organizations representing 26 nations, including the Orthopaedic Trauma Association and the Indian Trauma Society, as well as many of the organizations that you will have people present to today. And so they're representatives from the United States, the United Kingdom, Colombia, South Korea, Germany, and it's really a great pleasure to have such a wonderful collection of talent that will share some very interesting presentations and case studies. Thank you again, Sushrut, and congratulations again to you and to Mandeep and the organizing committee.
Thanks, Ted. Let's kickstart. I know Paul has been waiting. Thanks, Paul, and we can start with your case. Thanks for joining again. Let's make it interactive as we did last time, Paul, and we can pause and play and we can discuss and we can interact more. Thank you. Over to you.
Okay, can you guys see? Can you see that okay?
Not yet. We see you now. Yes, perfect.
Okay, great. So I don't have a specific case the way we've done it in the past. And I'm happy to stop anywhere, but I thought I'd talk about, we talked about doing something different and some salvage stuff. And this is just a technique I've been using for, 8 or 10 years of using intracortical screws and open tibias. And I thought I'd talk a little bit about this. I've given talks on this in different areas of the country, and it seems to be something people have some interest in, and I know a lot of people have started to do. So I thought I'd just review that and ask you guys for your comments and thoughts around it. I don't have any specific disclaimers with respect to this particular talk. So, we use lag screws for every bone in the body. So, this is a non-union that I did, good lag fixation and then plating, and that goes on to do well. And intracortical screws are something that I've sort of stumbled on at a necessity, and I'll show you the index case. But these are some just representative CT cuts of a 40-year-old male and woman, and you can see the front of the tibia. You've got about 12 millimeters, and on the sides, maybe 4 to 6, depending on what side of the tibia you're on. And this lends itself to if you have fractures that are oblique or triangular, butterfly fragments, you can actually place screws. What I'm calling is intracortical, meaning not lag screws, but staying within the cortex and still lagging, and that allows you to place nails without impeding the progress of the nail. So this is the index case. This was, I don't know, about a decade ago or so. This is a 24-year-old, had a 3C, got an arterial repair in the operating room. And that big butterfly fragment was really free except for its attachments to the anterior compartment. And that made it hard to do initial management. It was going to need a flap. And I don't definitively fix anything and haven't for 20 years until the day of the flap fixation. So that night I had a lot of trouble keeping the soft tissue intact with my frame. So this is what nail, and that went on to do pretty well. Here you can see this is 4 months, and this is at a year out.
So, Paul, can I
This
stop
is
you there?
another example. This is a bit of an oblique fracture. So this was open, and here you can kind of get an example of that anterior cortical fragment that I'm talking about. I don't have a lot of clinical pictures of them, but this is a small piece. But you can imagine that if you nail this, it's really hard to get things covered. That piece is flopping around; it's not attached. So again, by
Can he
adding
hear
it,
us from our side?
I hear you now. Yes.
So, is this always a percutaneous procedure, Paul, or how
No,
difficult
this is.
it is to put in place a rotated or a tilted fragment, just in case?
Yeah. So this is only for open fractures. Only for open fractures. So I'm doing it only when I already have direct exposure. And I've not, if I have a closed fracture that has a similar butterfly, I just nail that with clamps that are percutaneously placed, and then I leave it sit. I don't try to do intracortical screws. Although a couple times I've been tempted. Most times in closed fractures, there's enough of a periosteal sleeve that you don't get that maximal displacement. Whereas with the open fractures, these anterior cortical fragments can be, 10 centimeters out of where they belong, and it's very difficult to get coverage over them. So I'm using them only in open fractures.
So, next question that comes to mind is open fracture where soft tissue is already kind of buggered up. Are we doing more harm to these devitalized fragments? I mean, I'm sure you have looked at it, but is there any data to suggest that these many fragments stay viable, they heal well, and these many fragments, percentage-wise, go avascular further because of this additional procedure?
Yeah. So I'm not making any additional incisions. I'm basically using what I was using to do the irrigation and the debridement. And the fragments that I'm putting in are attached to soft tissue. So if one of these anterior fragments was completely devoid of soft tissue, I remove that and I place an antibiotic spacer. But I think that can be argued. There's some data in children that you can replace, non-viable fragments and have them heal. And I think adults, if it's not a contaminated piece, and you can probably put it back, or if you sterilize it with, articular cartilage, we can do chlorhexidine and Ancef serial dilution. You can probably do that with some cortical fragments if you get rid of the gross contamination. But I've not yet been that brave. So in my hands, these are all viable fragments that I'm putting back to help gain bony stability, and also keep the sort of osteocyte jumping distance to a minimum, so that they go on to heal.
Sure. Okay. Yeah. Thanks. Let's go on.
Okay. So this is that same patient. This is an example of an oblique fracture. This is actually one of my partner's cases from earlier this summer. And we use a lot of this was obviously a floating knee, and here you see a temporary plate was used to place the nail, and then that was you can see on the lower left hand slide there's an intracortical screw. You can see it nicely like within the cortex that's holding that oblique fracture together, and then once the nail is in, that plate is removed, but we leave the intracortical screw to help with that fixation. And that's the knee. Now you do have to be careful of these. This was a gunshot fracture. I'm not thrilled about nailing those. I've been able to get almost every gunshot fracture I've ever seen that I nail infected, so I don't do it anymore. I put frames on these. So here I did a mini frag plate, and if you look closely at this, you see this intracortical screw. And this was early on. I think this was my third case. And what I discovered there was that you have to tap. So my first two were not the youngest, strongest bone. This guy had very strong bone. So you can see on the lateral that screw doesn't look quite as good because I popped the head right off. So when I do these now, I'm very careful. And you can see on this one also, I went all the way across to the back of the cortex. So, after this case, I modified that technique to just going across by about 5 or 6 millimeters at most, and always tapping these for the lag screws. And that's that patient who went on to heal. I also use a lot of mini plates in conjunction with this in the OR. I'll just give you one little example of that. So this is a patient who came in about a month and a half after an open fracture. Unfortunately, the AP and the lateral were on the exact same image. So this is what it looked like clinically. We had to take away a lot of the tissue, but here you can see a plate being used to hold that reduction while we're doing the case. And then went on to nail it. I remove plates, but I leave the intracortical screws in. That patient didn't come back. I always like to show a recent case as well. So this is a case that I finished the definitive fixation just last Wednesday. So he came in about 2.5 weeks ago. High-grade open fracture of the tibia. Here you can see it was a contaminated, kind of a bad wound. My partner, Dr. Oshevsky, who's an all-star, took that to the operating room the first night, did a debridement, which, we did 5 other debridements before we ended up doing the definitive fixation. But this was the initial debridement and temporary plating. So we do this a lot. We don't like to put in nails initially, and we can talk about that. He also had an unstable ankle fracture that we dealt with later. But here you can see the wound with the temporary plates on. And we cover these with Vanco paste. So this is a vancomycin that's combined with, each gram of Vanco powder gets 1.1 cc's of normal saline. So this would have been about 2 grams. And we actually cover the entire plate with it. We do this a lot with our plateaus and our pylons as well. And we do that temporarily. And this went on to get several other further debridements. And then here you can see on the day of the flap coverage, so this was a free flap, I went back and I did the definitive fixation. You can see a lot of lag screws here. Now this top one's not intracortical, but the ones underneath it are. And you can see some multiple temporary plates on the top of that to hold us in place while we placed our nail, as well as clamps, and then distally a plate as well. And here you can see just keeping the lag screws away from our locking screws. And on the left-hand side of the image, you can see those unicortical screws up at the top that are helping to hold a tubercle fragment down. Obviously, this patient's still got a vac on, is still in the hospital, and I'm optimistic that they'll have a good outcome. So that's my little spiel. I think that, augmentation plates can oftentimes help, but I remove those. The intracortical screws are great for oblique fractures. I found them to be really, really helpful for butterfly fragments of the anterior cortex that are still attached to anterior compartment and are very difficult to cover because when you gap that, you lose all of that opening of the wound. And when you bring the bone back down and hold it with the intracortical screws, it actually tightens up what you have to cover. We've probably transformed a few free flaps into gastroc and soleus flaps by doing that. So it helps a lot with the closure and the coverage. And we've done enough now, and I've got a few other centers that we're gathering a series together that we'll probably submit soon. But none of this has gotten in the way of healing. So all these patients have gone on to unite, and typically they unite at the level of the intracortical screw first. So that's my little technique I thought I would share.
Thank you. Any questions from the audience? Yeah, Chetan.
Paul, can I ask you a question?
Yeah, sure.
Yeah, so I also do this a lot in femur as well as tibia. So when I have to nail them comminuted, I use a cerclage and then substitute that cerclage with intracortical screws. But quite often, when you have small fragments or small slivers, they shatter further. Any tips on how to do them? You said you tap till the end, but
so
I mean,
I use
ended up
everything
breaking
from
those fragments.
Yeah, I haven't broken any. I've tended to go to smaller screws, so probably 3/4 now are 2/0 screws. So I think the size, compared to the size of the fragment makes a bit of a difference. So all I would say is I place them always in lag mode, so I'm always over drilling proximally.
Okay.
I'm only drilling about 1/2 centimeter into the distal segment, so I'm not going far in anymore. And then I always countersink if I'm on a corner. And then with clamps placed to hold it, you don't have to apply a ton of pressure to make them work. So I've not had them crack though, doing it that way.
Thank you.
I also would have a question from the biomechanical point of view. You are combining absolute rigidity of the screws, intraosseous screws, with the relative stability of the lock nail systems. And you say you don't make any additional soft tissue damage, but how are you doing the compress the fragment? You must put there's a clamp or something. Some soft tissue damage is associated. And you're not afraid to make more damage than good?
Sure. I mean, those are both very good points. I'll answer the second one first. So again, I'd highlight that I'm not making incisions to do these cases, right? These are open fractures and I'm looking directly at this piece of bone. So I usually there's stripping in that area, and I've really not felt I've done any soft tissue damage by putting a point-to-point clamp on. I just don't think that's a realistic concern for that level of open fracture. As far as mixing messages, that's been looked at a bunch of times, and I think that we used to think, well, gee, if you put an X fix, you can't put a plate, and if you put a lag screw, you can't put a nail, and I don't think that those things are true. I don't think that you get absolutely rigid stability from these intracortical screws, nor from mini fragment plates. There's a number of series that include using mini fragment plates with nails that have all gone on to do well. It's been shown not to be a risk factor for infection in 2 series, although one of those series, they combined things in a way that was a little funny. But I don't think the intracortical screws are a big risk for infection, because all you have is a head that's really kind of sitting at the level of the top of the bone, since it's countersunk. And I have not had any issues with these fractures healing. In fact, I think it speeds it up, because I think you get a little bit of primary and probably some secondary bone healing around those triangular fragments. You can see that when they do heal, they have a little less callus than like a closed fracture would. But as an open fracture, we don't get a lot of callus anyway in a lot of those cases, right? They tend to resorb a bit, and a lot of them need secondary procedures. And I would estimate in my own hands, secondary procedures have been diminished by doing this, because instead of having a cortical fragment that's sitting 5 millimeters or 10 millimeters displaced and expecting callus to form, I've got bony contact. And if there's a little bit of instability in those mini fragment screws, that seems fine. It seems to function fine. So I don't worry about that anymore. I did when I first started doing it, but really been comforted over time by the fact that we've not had any issues.
Paul,
thanks for the
small comment by Rodrigo, who wants to let us know about a periprosthetic fracture where he used intracortical screws. Rodrigo, would you like to make a comment, please? Unmute yourself.
Oh, no, Mandeep, I just want to surprise Paul, because he presented this. I didn't know you were going to show that. I'm going to show a periprosthetic fracture that I use your technique that I have been using for a long time.
Okay, thank you.
Great minds.
But you will see.
Thanks,
We've been doing
Professor
it a long
Torretta.
time. We don't do it every week, right? So it takes a while to gather a series. I've been doing it, maybe a little over a decade or so. And I know there's a lot of people in the States now that have kind of picked it up, because we've talked about this at multiple conferences. But yeah, I mean, I think it's a great technique, and it's sort of the next logical evolution, right? So we all step into it at the same time.
Thanks for your presentation, Professor Torretta. I'm sure you have some controversy discussions on that. And you mentioned that you only use it in open fractures. And you also mentioned that there might be a risk of an enhanced risk of infection. How would you estimate this? Is there some science on it or some investigations?
Well, so what I was saying is that there's 2 papers out that look at the use of temporary plates with open fractures and mini plates in conjunction with open fractures and flaps. And while they're relatively underpowered, neither has shown a substantial increase in infection risk, and that's with a mini plate. I don't leave mini plates in my open fractures. I actually take them out. I use them for reduction and then remove them. But the screws, they're completely intracortical, and the only thing showing is a countersunk 2.0 screw head or 2.4 screw head. And again, I don't do any definitive fixation of open fractures until the day the flap is going to go on. So that's been
Okay.
something I've been doing for 30 years now, and now there's multiple papers that have shown that keeping the definitive implant in an open fracture for more than 2 days prior to definitive coverage probably increase infection risk. It's probably best to do it all at the same time, and that's our protocol here, is that we do the definitive fixation and the flap on the same day. So anything that's been in temporarily, like the plates you saw in the case I did last week, they're there only up until the time when we're doing the definitive fixation. They get swapped out, then we do the definitive fixation, and then we take out those plates, and then the flap is placed. So
Yes.
I think that, sort of logic would dictate that in the face of a clean wound that you're flapping, having a 2.4 screw head countersunk somewhere near the fracture is not a high risk. And I do cover them with Vanco paste, but we don't have enough to say that the risk of infection is any different, given the fact that these are all 3Bs. That would be we need a couple hundred.
To get it together, you should be careful. Screws are better than plates, and you should have a coverage soon.
Paul, last question.
I think temporarily plates are good, right? Temporarily plates are great. I don't like putting the nail in the first night. So we temporarily plate or X-fix everything. I think the plates are better. They're a little more stable. They're at the level of the fracture. And that's, again, for an open fracture that you're not doing any additional damage. You're just plating a surface that you have exposed, and then that plate will be removed later. But leaving it in, I'm personally a bit more comfortable with the screws than the plates.
Okay. So, last question from Dr. Mukhi. Quick.
Thank you. I use the kissing the nail technique. I pass the nail, then drill it. Once it touches the nail, I take out the drill, angulate, and go on to the cortex back.
Okay.
And
Okay.
cause
Thank you, Dr. Mukhi. Thanks, Paul,
kissing
for
nail
joining.
technique.
I know it's been late at night. Really appreciate you joining us, and Indian crowd is ever so grateful. Thank you very much.
No,
You can get back
I
to
love-
the bed. Thank you.
Thank you so much for having me.
Before we move on to the next case by Rodrigo, put on your boots. I see Georg Greil, past president of Kunstner Nail Society here. Unfortunately, he could not join because he had some injury which had to undergo surgery. So, George, do you want to address to all of us half a minute, please?
Yes, thank you, Sushrut, for the invitation and for having me in your wonderful congress, dear Sushrut, dear Professor Babhulkar, President of the Indian Trauma Society and the Society of the National Association for Interlocking Surgeons. We met in Hamburg this year, and you invited us to join your congress. Thank you very much for this invitation, and thank you, Wilhelm, for being there, and thank you, Peter, and dear fellow board members of the Kunstner Society. Please receive my warm regards. On the behalf of the Kunstner Society and me as the past president, thank you again, Sushrut, for this esteemed faculty that you put together. And I welcome everybody to this year TraumaCon and World TraumaCon in association with the International Orthopaedic Trauma Association. Yeah, I do look forward for most interesting cases like we saw with Paul Tornetta, and this is the main message for this morning for me. I now experienced a new technique that I will establish in my own clinic in the next weeks. Thank you very much, Paul, for your wonderful cases. And I wish everybody fruitful discussions and the scholarly cases like we saw now, and send my warm regards to the faculty from Germany.
Thank you very much, George. We wish you speedy recovery. And let's move on to Rodrigo, dear friend, all yours.
Okay, let me unmute myself. Mute, perfect.
Yep, can see you.
Okay. Can you see my screen?
Yes, we can.
Okay, perfect. So, Paul, this is for you. So this is a periprosthetic fracture that I treat. Those are my disclosures. I'm an orthopedic trauma surgeon in Bogota, and I'm the chair of trauma education. That's my conflict of interest, but there's nothing to do with this presentation. So this is a female, 85 years old, who fell at home. She is the mother-in-law of one of my partners, and she had a trauma to her left hip, a past medical history. She has a lumbar arthrodesis that was done 10 years ago, and a total hip arthroplasty that was done 8 years ago before this fall. So these are the X-rays. You see a hybrid total hip arthroplasty that with this spiral fracture that goes through the cement in this stem. She was completely asymptomatic and very happy with her hip. I talked to his surgeon, and he said, she's doing fantastic, please try to fix it. So we went ahead and we took some X-rays to look at the cement mantle and assess, as Paul mentioned in his lecture, the thickness of the cortex, so we can see if we can plan for having some intracortical screws and to measure the size of the screws that we need. So these are the CT images and the 3D reconstruction. So, and here you can see the reviews, and this is the patient was placed on the lateral position, and we did this small approach, direct reduction so I can get an anatomical reduction of a simple spiral fracture that you were discussing about absolute stability versus relative stability. We tried to get an absolute stability on this one, and this is the images from the CR before the reduction, and those are the 5 screws, 2.4 millimeter screws that I can put around the cement mantle and intracortical. And my partner actually was watching the surgery, and I told him, okay, closing down, we're leaving. And he looked at me and said, you gotta be bananas, putting just the screws in there. And I said, hold on, I'm going to slide a plate on it. So I slide a plate proximally distally using minimal invasive techniques to hold this. And those are the immediate postoperative X-rays of that patient. The advantage of this is I got some very good stability that can allow this person to put weight there as tolerated on day number 1.
So Rodrigo, can I stop you there?
Yes.
Can I stop you there and ask a question? So when you were putting the screws, did you hold the fracture with clamps as Paul was talking about?
Yes, sir. As you could see here, I was holding the fracture completely reduced and then putting the screws around it as is shown right there.
And you did not put any plate at all to...
At that time, no, Mandeep.
Yeah,
So those were my reduction screws. I hold the reduction. Now I have an anatomical reduction. And then I did a proximal incision that I slide that plate that you're seeing there, put it all the way down. You see, hold it with K wires to make sure that it was centered on the AP and lateral view and get a reconstruction of the joint, of the shaft. And then I finished my fixation proximal.
So again, this augmentation hook plate was part of the plan from first time, or
Correct.
You thought that these screws are not stable enough and that's why you ended up...
No. The original plan was doing the reduction using intracortical screws and then put it a plate, as we all do to these periprosthetic fractures that are B1 fractures.
So since Paul is still awake, Paul, what do you feel about this construct?
Yeah, I think it's great. I mean, it's at this point, it's functioning as a lag screw with a neutralization plate. Like it's following the basic principles for every other fracture. I love it.
Yeah. I see Dr. Tanna, who is fond of doing nail and plate, but this is screw and plate. Any opinion on this construct?
I would have a question. You put that's an angular stable plate, I suppose, and you at the end of the implant of the shaft, you have a single screw in displacement. We know that in angular stable plate, you have a need of long central parts which can have some bending. When you don't have this, the plate will break exactly at this point where you have the single screw angular stable in the middle of an angular stable plate is not a very good thing on my experience.
Yeah, but I think even on Indian shores, we are now using two different principles altogether. Like we were completely opposing screw and plate together or screw and nail together because we thought that these are two different principles at war with each other. But today, for these highly unstable fractures, even mixing of principles and overkilling is probably acceptable. Dr. Tanna?
I think here normally we do the circlage and putting the same sort of a plate, but this leg screw unicortical small screws, I think it has been there in the work for quite some time. We've been talking about it. This is so beautifully it is done. I think this is going to be absolutely perfect.
Okay, Rodrigo.
Dr. Tata. So let me go ahead on this. So this is the media postoperative X-rays. This is 1 year later. This is the other ones from 1 year. This is 2 years later. And this is 3 years later. And this was just a month ago that I saw her. And those are the hip X-rays and the femur X-rays. So in summary, this is a tribute to Paul because I learned this technique a long time ago. I heard a lecture from you and I thought it was fascinating. So in some fractures, in periprosthetic fractures, especially the stable stem that can be treated with open reduction and internal fixation, and intracortical screws are really a useful tool to lack simple fracture patterns and respect the cement mantle. And if you have also uncemented stems and you want to do the same thing, it's very, very easy to do. So I encourage you to do it because it's really a very useful technique. Thank you very much, Mandeep, Sushrut, Dr. Tata, for having me here. And Paul, it was really, I was surprised that you presented those. Thank you so much, guys.
Rodrigo, one small question by Dr. Chetan.
Hi, Rodrigo.
Yes.
Chetan from Pune.
Hey, Chetan, how are you doing?
I'm fine. How are you? So one question to you. When you're putting these screws through the cement intracortical, do you think you will crack the cement mantle around that stem? And it may cause loosening. I'm always afraid to put these screws in, multiple screws like this in the cement mantle around the periprosthetic area.
Very good question, Chita. Very, very good question. And there's some evidence that shows that the cements through the screws through the mantle doesn't increase the loosening of the stems. But one of the advantages of using these screws is actually you're avoiding the cement mantle because you're putting screws intracortical. That was the reason I took the CT scan so I can measure which size of screws I could use. I use some brand of screws that have screws from 20 to 27 in lengths up to 80 millimeters. So it's very nice that you could bypass the cement, Cheetah, basically putting the screws intracortical. That's the beauty of this technique to me.
Rodrigo, JK here.
Hey, JK.
Nice presentation. Yeah. I have a question. Seems like this fixation construct is a neutralization plate because you place the leg screw through the leg screws through the spiral or oblique spiral.
Spiral, JK.
Yeah, simple spiral fractures. So, and then you added a plate. It means it's a neutralization plate. So
Correct.
theoretically, it is healing by primary bone healing process without producing a callus. And then on the post-op X-ray, it's beautifully done on the lateral view. There is a little bit of gap there. So I was wondering whether this is going to heal by secondary healing or even with that gap, still somehow heal by primary, not contact, but gap healing type of primary healing. But in the end, it healed by secondary healing. So this whole construct acted as a bridge construct. So can you explain this situation? You think about it as a absolute stability or expecting it primary healing or relative stability healing like this?
You know, JK, is a great question. And I don't know if you remember the paper by Robinson, Esteves, and Cody Kojima on injury, talking about the different concept that is not absolute, nor relative stability, something in between, because these screws, despite I got an anatomical reduction, I was looking at the fracture site, then put the screws around it, but these screws are so small that are flexible enough, and I have enough bridge between the first cortical screws up on the top and the first cortical screws down, that I have some callus formation. And I'm glad that you pointed that out, because if you could see at the X-ray on the left-hand side, you could see the callus on the medial side of the fracture. But I don't have an explanation, JK. Maybe Paul can help me with that.
No, I agree. I think that, rigid and completely rigid and inflexible fixation really doesn't exist so much, right? I mean, how many lag screws does it take to make something never move at all? Even the humeral non-union that I showed at the beginning of my talk, right? I got good bone contact, I put 2 lag screws and a neutralization plate. There's still going to be some callus in that, right? And, if you do a pylon, a plateau, those areas in metaphysis don't generally form a lot of callus, but if you start to lag across a metadaphyseal extension and plate it, there's always a little bit of motion there. So I think you're seeing the same thing here, is that you're converting some of this to primary bone healing right at the level of the screw probably, but that's an apex, and there's a little bit of motion beyond, and all these plates have motion. If you take a big plate, stick it on a femur and try to bend the femur in the OR, you'll see it move. So even if it's a lag screw and neutralization plate, I think it's rarely that rigid that it's strictly primary bone healing, except right where the screw is.
Okay. Thank you very much, Paul, Rodrigo, and JK. JK, thanks for joining, man. So let's move on to the next case. Claudia, are you all set?
Ready?
Yep, yours.
Yeah. Let me share my screen.
Yes, please. Can't see your screen yet. Mukhi sir, please sit. We will give you a chance when to speak. Please do not disturb. I understand, but we are on international podium. कुछ तो इज्जत रखो यार इंडिया की.
I see it now. If you go to, there it is. We see it.
Can you see my screen?
Yeah, we can see you, Claudia. Go ahead.
Okay. Thank you very much for the invitation. It's an honor to be here with you. I'm Claudia Medina. I'm an orthopedic surgeon from Colombia, South America. This is my disclosure. I have not conflict of interest to declare. And today we are discussing a clinical case now about intracortical screws, which explore the complexities of managing multifocal tibial fractures, the increasing frequency of these injuries, the critical factors involved in their treatment, and the potential complications that must be considered. The case involving a man, 48 years old, who arrived to the emergency department with an isolated trauma to the left lower limb. Upon initial examination, a 1 centimeter wound was observed on the distal third of the left leg, indicative of an open fracture. Despite the severity of the injury, the patient was stable with no other associated injuries, and his medical history was unremarkable with no comorbidities or history of smoking. The initial diagnosis was a multifocal open fracture of the left tibia, classified as Agustilo 3A, and a patient stable. And what to do at that moment? Given the nature of the injury, the immediate priorities in management were to prevent infection and stabilize the fracture. The patient was promptly administered broad-spectrum antibiotics to mitigate the risk of infection, and it was followed by an urgent surgical debridement to remove any contaminated or devitalized tissues. Musculoskeletal temporary fixation was employed initially, providing stability while allowing a continuous assessment of the soft tissues before definitive fixation. And of course, the fracture pattern was classified into 3 components: a tibial diaphyseal fracture, 42A2, a distal tibia fracture, 43C2, and an associated fibular fracture, 43F3B. These classifications guided the surgical approach, emphasizing the need to address each component of the fracture while maintaining the overall alignment and length of the limb. At that moment, these are the patient's diagnoses. And over the following days, the patient's soft tissues healed well, except on the fibular side. Multifocal fractures, particularly in weight-bearing bones like the tibia, requires a careful planning. And the plan for this patient was open reduction and internal fixation using different plates, as you will see. Oops. Following the initial surgery, the patient's left lower limb showed signs of malalignment. And this misalignment likely result from the inherent challenges in achieving a perfect reduction and fixation in multifocal fractures, where multiple fracture sites complicate the alignment process. It's sad, right? And despite these early signs, the decision to address the malalignment was delayed by myself. And this delay stemmed first from the complexity of the case and the need to stabilize the soft tissues before considering further surgical intervention. And second, honestly, because I needed to get peace in my mind before to plan the next step. Finally, 10 days later, with the CT scan, I decided to make the next surgery. And this is how I was able to correct this varus limb in a convenient alignment extremity. The patient's recovery was closely monitored over the following months with regular follow-ups to assess the healing process. At the 3-month follow-up, the fractures in tibia and in fibula appear to be healing. However, 4 months after the definitive surgery, the patient went to the emergency room for signs of infection. and with these X-rays. And what to do. And at that moment, a reintervention was needed due to signs of infection and implant loosening. Cultures identified the causative agent as a low virulence germ, and the anterolateral plate was removed and a bone cement spacer was used at that moment. And 2 months later, that is 6 months after the first surgery, we made a maskelet removing the bone cement and using an aspirator irrigator system to get the bone graft and use it in the distal tibia. At the 8-month follow-up, the patient had made significant progress with successful management of the infection and stabilization of the fractures. And the patient is walking without using any external support. So, what went well with this case? I think to fix all fractures by overlapping plates. Fortunately for the patient and for me, the infection was caused by a germ with a low virulence. And the patient and his family always trust my work as a surgeon.
Okay.
And what would I do differently? For sure, make the decision to review the osteosynthesis more quickly because it took me almost 2 weeks to decide that. Grab the distal tibia after 6 to 8 weeks of surgery, avoiding leaving the dead space. And I will fix fibula to obtain length and stability on the entire system.
All right.
To take home, the multifocal fractures of the diaphysis are becoming more frequent. They must be resolved with several implants, respecting biomechanical principles. For sure, the best time to correct malalignment is during first surgery, and it's recommended to involve the patient and the family in the care process and in the decision-making. Thanks for having me here and for listening my case.
Thank you very much. Paul, I know you have a very strong point in terms of fixing the fibula to begin with. So do you want to say something, especially when tibia is comminuted and fibula is comminuted as well, Paul?
Yeah, I actually don't fix the fibula pretty much anytime. And even in pylon fractures, I don't fix them unless the initial deformity is, substantial valgus, because that'll help correct the deformity. But I otherwise don't fix the fibula unless there's an unstable ankle associated with it. I haven't found that to be particularly helpful for either tibia or plafond injuries. And there's some evidence that fixing the fibula in a distal tibia will help with alignment. But in those series, the malalignment is not something that develops over time. It's something that occurred, as Claudia, you showed, in the operating room, right? That's where it usually happens, and then it doesn't shift. So fixing the fibula, if one needs it to help with the reduction, I think it makes sense. I generally go right for the tibia and try to avoid the second incision and the soft tissue problems associated with it. I mean, that was a really tough case you showed, Claudia, and I think you did a wonderful job and made the really solid point of talking to the family and making sure you double down when something isn't going smoothly. And that's something I teach here too as well. And that's how people gain faith in you and transparency and honesty. And that's how you get to a good result. So that's really good work.
Thanks.
Yes,
Thanks,
maybe
Paul.
the ankle is stable. However, I think it would be better if I would fix the fibula to get the length of the fibula and to get more stability in all the system.
Yeah. Peter,
Yeah,
good morning. Thanks for joining.
Yeah, I could have done a short and then plated the pylon for that, but
Yeah. Peter, hi. Good morning. Thanks for joining. Early morning there. So Peter, Paul, and I have written complications in orthopedics, and we have looked at fibula cases. Peter, do you want to talk about that? Fibula and neglecting fibula and the cases that we included in our book? Can't hear you, Peter.
Yeah. Can you hear me now?
Yeah.
Yeah, good morning. Well, I don't know what is the time now, but never mind. I think everything has been discussed and well covered. If you are talking about are you talking about isolated fibula or in association with pillow
So
fractures?
it's comminuted tibia, comminuted fibula, and we want to pull out tibia to length. Should we fix the fibula is the question.
I think it normally, if it's quite distally and there is a smashed joint intra-articular, your first objective is to reconstruct the tibia because that's what will be the major issue, the pilon. And then, of course, restoring the fibular length, rotation, and the relationship to the distal tibiofibular joint, I think it's important. So normally I would try to restore the length of the fibula and provide as possible as I can the ideal relationship for a normal angle function. So this is my personal view.
Okay, thank you. Thanks, Claudia. Because of want of time, we are going to jump to the next case. JK, are you there? It's your case next.
Thank you. Let's see. Let me share my screen. Can you see my slide in the screen mode?
Yeah, we're
okay,
good.
Yeah. So I'm JK Ong from Seoul, Korea, working at the Korea University Kuro Hospital, mainly trauma, and now I'm dealing with a lot of infections and non-unions for the past 10 years. So here's the case that I'm going to discuss about. And 53-year-old lady, can I shift this around? Yes. Lady was transferred 2 weeks after injury with this ex-fixon, with this soft tissue condition, and obviously it's already infected. So it's safe to call it fracture-related infection there. And I just want to mention we have a Ortho-Plastic team approach here for the past 10 years. I have a great deal of respect to my plastic surgeon here. Without his help, I couldn't have done what we have done here. So this is the protocol we've been using here in KUGH. So it's rather complex. So we mentioned this a couple of times in the previous publications. So I'm going to explain what it is about. So when we do the setup, we do it like this. When sometimes we need it, we do the flap together at the same time. So I'm walking on this side, debriding it, and then the plastic surgeon walking on the other side of the leg, raising up the flap, something like that. And then point is, I place one layer of drape just like this as usual, and then here comes another layer of drape. So I put 2 layers of drape from the beginning, and then the second layer stops right here. So, and then we prepare 2 sets of instrument, the big one for the second, and we prepare a small set for the debridement. So this is how I pick up the specimen. I typically get a tissue cultures from 5 sites. When we have a segmental resection situation, I typically pick up from one from the center, 2 from the proximal end, 2 from the around the distal end. So it's called IMP, EMP, something like that. So 5 deep tissue cultures. And then once I done the debridement and get the tissue cultures done, I split up the first layer of drape like this. And then once you peel that off, now there is a clean layer prepared, and we change the gowns, and then we move to the second set, which is called post-debridement set. That's where we do get the second set of the tissue culture from the same site. So the first set is to get to know what is the causative organism, but the second set is to assess or evaluate the quality of my debridement. And this post-debridement culture will be my guideline, whether I go back to the debridement again or move to the next stage, which is the definitive fixation. So, that's the outline of this protocol. So this post-debridement culture is my guideline, whether I go for definitive fixation or go back to the stage 1 debridement again. So why 5 tissue cultures? It's been 10 years since I've been doing like this. Fortunately, I got a backup evidence published 2 years back. I'm not going to get into the detail. Please look up this paper published in JBJS. And then 5 is better than 3. That's the simple message. Please look it up. Because of the time's sake, I'm going to pass this. So let's move on with this case. So this is the stage 1 operation. First layer. I do the debridement. In this specific case, you can see this area is clearly devitalized. It has to be gone, but I temporarily kept that after cleaned up because once I resect it, it's really difficult to keep the alignment and length correct. So 2.0 plate temporarily, and then proximal fixation, and then femur, ipsilateral femur nailed like that. So that was my stage 1 operation. And then this is the culture results. So we get all 10 sites of the cultures are positive. So like I mentioned, all these 5 sites of post-debridement cultures are positive, meaning that my debridement is not good enough. So this is the next step. So next time, I want to go back and do the debridement again, not move to the definitive fixation next time. And then this is the...
So, JK, can I stop you there? JK, so how many days gap was there? So you did the debridement. After how many days did you receive the report? And when are you attacking?
7 days. 7 days.
Okay.
Yes, thank you. So once I got the result, and it probably was 10 days later, it looks like this. So I go back to the stage 1 to debride it again, hopefully more thoroughly. Oh, okay, thoroughly. So I'm sorry, there is a little bit of So after second debridement, the PD cultures came out negative. So sorry about the a little bit of misarrangement there. But after second debridement, the PD cultures came out negative. So I moved to the stage 2 next time. So I nailed it, and then like this. And then finally at this time, once I placed the nail, the fragment that was initially devitalized, kept in temporarily, now resected like that. And then I placed the cement spacer around, so the alignment is okay, I hope. And then my plastic surgeon did the flap on that very day. So stage 2, we did the internal fix and flap. But before I get there, I had to clean up and then make it sure that the cultures turned out to be negative. That's the rationale. So, and then I made a big mistake. there was a marrow alignment right there, but soft tissue coverage was nice. So, but there was a bacteria came out again. So I went for 6 weeks of IV antibiotics, and then came back to address this issue again. So I had another surgery to just solve this problem. And then there was a big surprise. Whenever I do the major surgery, I do the culture all the time. And to my surprise, even after previous culture negative, PD culture negative, so I moved to the definitive fixation and 6 weeks antibiotics, all that, now we have this situation. So this is a kind of a question I want to ask you all. So what would you do? So according to my protocol, I need to go back and remove everything and then redo everything, start all over. But we all know that when we do the stage 1, that was temporary fixation, and then PD culture is positive, it's easy to go back. We already explained it, but we came all the way here. Now it's kind of done. We have to move to the bone graft next time, but now we have this culture positive. What would you do? It's an emotionally really, really tough decision to make. And when I have a discussion with the patient, she doesn't want to go back and do all it over again. So I did a suppression strategy. So regardless of the protocol, second round of antibiotics for 6 weeks, and there was no clear plan for next step, honestly, at this point. And she was kind of doing okay. So time passed by for 8 months. The fibula healed, femur got healed. But we still have a cement spacer in. That's where I got PD cultures positive. At some point, I need to go back and replace that spacer with a bone graft. But 2 months later, ESL, CLP went up. I mean, it was a spike. And then with the fever, it was obviously the infection came back. So I had to go back and redo the debridement all again. It was like this. So you cannot keep the implants in this scenario. So I had to go back, and even after thorough debridement, there was one side of PD culture positive. What would you do next? I got only 1 out of 5 tissue cultures positive. You want to re-debride it or move on? So, but now I got this question multiple times, but even if one side positive, I go back and do the debridement again. That's my decision. I learned this lesson in a very hard way previously. So did the debridement again, and cultures came out negative. So then I moved to the second stage, which is a definitive fixation again and spacer replacement, like this. And then now it's okay. Now it's time to move on to the final stage, the bone graft, finally. So now this is the situation after debridement. She had a foot drop, and now this is the cement spacer in. So I need to take those out, and she got foot drop, and the size of the distal fragment is so small. And so I suggested her to fuse the ankle and get the bone healing. But she was very adamant about keeping her kind of joint motion mobile. So I had to do something to save her ankle joint without fusing it. So what I did was I cut the cement spacer right above the defect. As you can see here, there's only one interlocking screw, ASRS, bicortically, and the proximal interlocking screw you can see here is through the empty, there's no neocortex. But it was embedded within the previously placed cement mantle. So get kind of decent stability. And I placed a graft even over the cement spacer. And you can see this graft material, I'll tell you later. This is a BMP, RHBMP with the HA carrier granule. And I mixed with the autograft and half and half. And you can see here, with this fixation construct, I was able to allow weight bearing like this. This is 5 months out. 5 weeks out, I'm sorry, 5 weeks out, very, very early. And 3 months after bone graft, she walks in like this. I was really surprised. Just 3 months out. and wondering what it looks like on the X-ray. On the lateral side, it's bridging. It's really, really fast healing. And you can see the change, immediate post-op bone graft, and 5 weeks out, you can see very fine line of cortical lesion along the lateral side. In 12 months, it's completely healed. And this is the CT scan. So actually, we just published
JK, do you reckon weight bearing is triggering good consolidation? Is what you're looking at?
Yeah, absolutely. I believe it. I believe in biomechanics. So the nailing is the best, and then weight bearing is good for fracturing. We all know that. It's our kind of goal or responsibility to provide that environment. So it's a nailing. The biomechanical environment is good. The material, graft material I'm using, that's perfect. So I've done. This is a KFDA registered 25 small case series, but prospective case series. I did with, and then I got very fast healing for those 24 cases. But this is not the main focus of today's talk. I'm going to talk about the how do we manage the FRI, that challenging situation, without getting lost, I would say. So the RHBMP2 with HA carrier granule mixed with autograft, that's my working horse right now. So this is the 4-year follow-up. She is infection-free, but she walks quite well, even though she had a foot drop. So that's how I manage this. And then takeaways. This is not validated protocol. I don't want to say that this protocol will not solve the whole problem. But when I saw those cases referred from other centers, they got lost. So make a decision here and there, not knowing what to do. But because I have this protocol, I made a decision based upon the post-debridement culture. So it's nice to have this guideline when you have this long journey. Thank you very much.
Sure. Thank you. Thanks, JK. Any questions? John, yeah.
Hi, JK. So I've heard you before talking about the same BMP in a distal femur, which you really struggled with to get to heal. And it obviously seems to be doing a great amount of work. But in a case like this, for me, I would switch to bone transport much earlier. So by the second debridement, or whenever you went in for your second stage and you still got positive cultures and you had a gap, what about bone transport with something like an Ilizarov or some similar apparatus at that stage?
John, nice to hear that. And that's a great option as well as an alternative. So it's been 10 years for me, kind of moved on from transport to the mascule. And initially, because of, I kind of have some emotional issue keeping the X fix more than 2 weeks. It's disturbing emotionally to me. That's kind of emotional thing there. And we all know keeping the X-Fix more than 2 weeks creates a lot of problems. So I did all that kind of modification, transport over nail, transport under the plate, reducing the X-Fix time by 70%. But when we have these kind of issues, still we need to keep that X-Fix more than 2 weeks. And that's my emotional issue. So when I first moved from that transport to mascule, I kind of struggled a lot because the autograft alone didn't produce great response of healing, and for some big defect, I even have to compromise by mixing some DBM, which is not better than autograft at all. So, and through that period, I struggled with this healing issue with the mascule. But since the RHBMP2 that I'm using right now added up to that whole protocol, the healing became much faster and robust. Like in this case, if I have more time and talking about on that topic, there will be a whole lot more great cases.
Great, thanks.
JK, do you think this also adds to your fight against that refractory infection versus earlier bone transport days?
I cannot say that because I do not have evidence. I haven't done the randomized controlled study. So, and the paper I reported in scientific reports, we still have 15% recurrence rate. So, bone healing is much improved with the BMP,
Yeah.
but control the infection is still another issue. So
Sure.
I don't want to say that adding BMP will improve the recurrence rate of infection in this situation. We need to work on further on that aspect.
Yes, Peter.
Yeah. Thanks for this great presentation and your deep knowledge on bone growth and so on. I want to emphasize on bone transport. We had some talks these days. We now know, and there is some evidence, that bone transport not only causes new bone, it also causes enhancement of lots of growth factors, neoangiogenesis, and things like that. So I don't want to stress these old words from Elizarov, but my experience is that things heal with bone transport, which we thought they should not heal. So to me, the advantage of bone transport, especially in infected and complicated cases, is that we have an additional effect which we not really know entirely, but this effect exists in my more than 20 years experience.
Yeah, I remember I used to be a very big fan of Elizarov when I was young. And then in his textbook, he wrote, it goes like, by transport and by compressing the end fragment, it will burn the infection. He literally mentioned in his textbook, but
no, he
I'm not
never.
sure about that.
There is. I didn't find it in any this sentence. The infection is burned by the fire of distraction, osteogenesis.
Yeah,
I'm searching.
In his book, he wrote.
I didn't find it.
Very big textbook. Yeah.
I know it, but
I used to be a very big fan of Elizarov.
Did you find the sentence?
All right,
Yeah,
I'll get both of you photocopy of that. Parag.
Okay, Dr. Jayne, thank you. Wonderful case. I'm Parag Munshi from Bombay. I have one question. I'm intrigued by the number of samples you sent. Now tell me, when you send so many culture samples and when it shows mixed flora, which antibiotic protocols are you using? And when you get multiple antibiotic sensitivity results, how often are you changing your antibiotics?
Yeah, so honestly, I do not have an answer because I'm 100% dependent upon the infection specialist about antibiotics protocol. So sometimes they prescribe 3 mixtures of 5. In this case, because of multiple bacteria, and sometimes the bacteria turn over to some other organisms, so then they prescribe sometimes this antibiotics for 3 weeks and this one for 5 weeks, all the mixtures. So I don't have any idea about that, but I am completely dependent upon the specialist opinion.
Last question, Milind.
Sir, in the paper you have said that you add autologous graft to the RHBMP, while in the presentation you mentioned that you added allograft. So was it allograft added or autologous bone graft?
In this case, Auto 50, BMP 50. So the publication was about that. So
autographs.
Yeah, this
Okay.
case is, yeah,
Okay.
autograph, RHBMP2, bi-volume 50-50.
Thank you.
Thanks very much, JK.
Thank you.
Really appreciate joining you. And now we have another great friend, Karl-Heinz Frosch is the originator of approach that we very fondly use for proximal tibia. Over to you, Frosch. You have 2 cases, 2 slots, all yours.
Yes, thank you very much, Sushrut. Dear Dylan, thank you for inviting me to present 2 cases of tibial plateau fractures. The first case is a case which is I think, nice to discuss, and probably in this experienced audience pretty quick. And the second case, we made a video with different approaches of tibial plateau fractures, maybe better to understand also the first case, what we did. This is the first case. It was more than 10 years ago. It's a 62-year-old female. She has osteoporosis. She was still active and no prior knee pain. And it turned out that this is a lady in my neighborhood here. So my wife came with the pictures. Nevertheless, at that time, we were not in Hamburg, and she was treated in our hospital. I was not there at that time. So they asked me arthroplasty or open reduction. I think we don't have to. I think the answer is clear. For most of the guys are here. We did an open reduction, internal fixation. It was done in this way. And this was the time when I came back and I got these pictures. So it was directly post-operatively, 62 years old, and we have a couple of steps and gaps in the articular surface. It was treated by a posteromedial approach here with this plate on the posteromedial side and with an anterolateral approach. So the posterolateral fragments were completely left in place as they are, and they were not addressed with a plate. So in this case, I think the discussion is a little bit more interesting. What should be done? The steps and gaps were more than 2 millimeters, clearly. And so now, for me, what would you do? Maybe here also for the audience, what would be your preference? It's directly, she's living directly around the corner. I still see her, usually at the weekend when she's walking with her dog. So wait and see, revision and reosteocentesis, or send him to someone else to get an arthroplasty. Then I'm out of this problem because, again, she's directly here living in the neighborhood. So what would you do? Maybe a question to the audience or to the contributor.
Anyone want to take it up? Yeah. Karl-Heinz, can you show the X-ray, please, or the CT scan that you suggested? Yeah. One-liner, Muki-san, one-liner.
It was 10 years ago, so I don't have any further pictures.
So we are good. This is okay. This is okay.
I would use the cautious approach and elevate the posterolateral fragment.
Okay. Any other thought?
I think you have to have a talk with the patient, right? So she's 62. She's at an age where an arthroplasty is a very reasonable.
Now speak.
Medial condyle also needs to be addressed here.
Okay. So, Karl, everyone wants to revisit and refix.
Okay. I think Paul had also a comment. Paul, you would also go back to operation room?
Well, I don't know. I don't think it's my decision. So what I was going to say is I think this is a conversation with the patient. So she's got displacement. I can't tell from this if her metaphyseal alignment is good, but if her metaphyseal alignment is good and her joint doesn't look good, I would offer her, allowing her to go on and see how she does and get an arthroplasty as her salvage procedure rather than a refixation as her salvage procedure. And, I think at that point, you sort of have to estimate what are the chances, what are the timeframes. But I've seen some pretty ugly knees with good metaphyseal alignment get 10 to 15 years or, 8 years. So at 62, she could get 5 to 8 years out of this without reconstructing the joint if she's not subluxated and if her metaphyseal alignment is good. And I would have to, offer her that. To see, what her appetite was for a revision. And, then you have to estimate what are the chances that revision will get her more time. And with bad cartilage injury, I'm not positive that it would. So that's a really, it's a really hard decision. And thankfully, it's not my choice. It's her choice.
Yeah, absolutely. So completely right. What we did is we did a re-osteosynthesis. We went back to operation room. I told her that the chance that she will really do well the next years will be not too high, in my opinion, because yeah, we all know some cases who do well, even if they have steps and gaps in the articular surface, but most of them do not well, in my personal experience. So we went back to operation room. What we did was a revision in prone position. So we opened up the anterolateral approach, removed the plate from anterolateral, and then in prone position, we did a posteromedial. We opened up again the posteromedial approach, did a redo of the posteromedial side, and then we went in with the posterolateral approach as we described, and did a redo of the posterolateral corner, and also got a really nice reduction. I think it's almost anatomic reduction. And the patient, and this is now more than 10 years ago, she is doing completely fine. She has not much problem with her knee. She's still walking with her dog. I see her time by time. My wife is more close to her, so she's really doing well. And I think that anatomic reduction with the right approach in tibial plateau fractures is, from my experience, the key to success. Is there any further comment to this case?
So,
Otherwise, I would continue with the next case.
Till how long would you go in and kind of do this bravery? So 4 weeks, 6 weeks, you're okay to go, or even 3 months, you are okay to go and do an intra-articular osteotomy and rectify things. So what's your timeline you're looking at?
So if possible, I go in pretty quickly. So it was, I think, 4 or 5 days after primary surgery, I did the second surgery. And if possible, I do it as quickly as possible in the primary setting where the fracture has not healed. I think 6 weeks, it's not a good point to go in again, because 6 weeks, it's not completely stable, but it's healed. The knees usually has some stiffness, and we had a publication about revisions in tibial plateau fractures. We had 25 cases, and in average, we did the redo after 6 months, something around that, when the range of motion was good. And especially the worst results we had where the range of motion primarily was not very well. So some kind of range of motion, good movement of the knee plays a role also in the results. But if possible, in these cases, I would like to do not an osteotomy in any case. I would like to do a redo as quick as possible.
Okay, Paul, can I pick on you, and what's your cutoff time for such revision, fresh revision surgeries, and what do you expect?
I agree. I agree with the professor. I think, at 4 to 6 weeks, it gets really tough. But I think you also have to take into account, soft tissue and patient, right? So you're going to act differently in a 20-year-old than in a 60-year-old, right? So at 20 years old, I think an osteotomy, is a reasonable option. At 62, I would agree. I wouldn't go in past maybe 5 or 6 weeks when you're starting to potentially just cause more problems than you're going to resolve. When you have a good secondary alternative, as a salvage, right? So age matters as well as time.
Absolutely. I also fully agree. If this patient comes to me after malunited tibial plateau fracture 6 or 8 months postoperatively, I would not probably do a redo or an osteotomy. I would wait, take out the implants, and wait how she is doing, and then probably prefer arthroplasty.
Okay. Any more questions from the audience before we move on to Professor Frosch's next case? Okay, Karl-Heinz, let's move on.
Yeah. So this is a case where I made some videos for you because you already told me you want to see the approach and some nice videos. So this is not a real patient. It's a human cadaver. I think you know this technique. It's a human cadaver, pre-fractured bone, complete intact soft tissue envelope, and I did the surgery with my friend Kongfeng Liu. It's a bicondylar tibial plateau fracture, AO4133, medial coronal split. You will see pretty quick the CT scan. You see here it's a pretty comminuted fracture, especially in the axial views. You can see we have a medial coronal split, which is very often in bicondylar tibial plateau fracture, and a lateral comminution with at least 4 fragments. We also have some central fragments, which are probably difficult to address in these areas, and they get a nice reduction. I think what we did is, in this case, or we can, no, I show you what we did, and then I think further we can discuss the case. This is the patient in prone position. We do probably 80% of bicondylar tibial plateau fractures in prone position. What we have seen is that the infection rate is lower than in supine position when you use anterior approaches or medial or lateral approach. In prone position with posteromedial posterolateral approach, we have the feeling, or especially in our department with more than 600 tibial plateau fractures, we have seen that the infection rate is lower. So we do these fractures in prone position. You see the landmarks, condylus lateralis femoris, condylus medialis, and we do usually a skin incision for the posteromedial approach directly distally to the popliteal crease. Then we open up the fascia. It's not a big thing. And we expose the medial gastrocnemial head. The medial gastrocnemial head is retracted always to the contralateral side. In this case, it's a medial approach, so we retract it to the lateral side. This is usually the semitendinosus tendon. You can retract it to the medial or lateral side, whatever you want. And when you go to the depths, you see, or you come directly to the musculus popliteus. This is the popliteus muscle, directly underneath the gastrocnemial head. And at the medial edge of the popliteus, you will find the ligamentum collaterale mediale, as you see here, and directly at the posterior edge of the ligament, we open up the fascia, go directly to the bone, and expose the fracture. This is not a big deal. It's not a big or difficult approach. Then with a respiratory, we try to preserve the periosteum, but remove, as you see here, the muscle from the fracture, and then the fracture can be nicely exposed. Sometimes we need the scalpel. And now you see here directly the fracture already. Here's what you see down here is the fracture. It's the posteromedial fragment. And what we usually do is not too much reduction in this at this stage. Usually we start putting a plate on it. And you see with some traction at the lower leg, usually we get the reduction. This is the surgical setting with my friend Kongfeng Liu. And this is a 3D printed fracture. I like if the fractures are complex articular fracture, I like to have a 3D printing prior surgery. We also do it here at the university clinic and at the BG clinic. And in this case, usually I don't reduce too much the fracture. I just put a plate on it and do the reduction with the plate. As you have seen, the plate reduces usually the fracture, and if you do some distraction on the leg, you get a nice reduction. At least 80% of the cases, you don't have to do too much. This is the reduction of the fracture. You see it here nicely, and then we did the posterolateral approach, as you have seen. Here we start. It's the peroneal nerve, which is probably very important. Here's the fibula head, lateral collateral ligament. And the peroneal nerve usually crosses 3 centimeters distally to the tip of the fibula, tuberculum girdii. And this is usually our approach, is from the lateral epicondyle to directly in the line of the fibula head. First thing what we do is expose the peroneal nerve. This is not a big deal probably for most of you. It's a pretty quick operation. Here is the peroneal nerve directly down here. It's directly under the fascia, so you have to be careful when you open the fascia, you're already directly at the peroneal nerve. And usually it's not a big deal to expose the nerve. In revisions, that can be very demanding, but in primary operations, it's usually not a big deal. And then under the lateral gastrocnemial head, we go directly we go in under the lateral gastrocnemius. It's here on the popliteus or between popliteus and gastrocnemius. We go, we preparate in the depth. This is the approach we usually use, or we start with. And what you see underneath the lateral gastrocnemial head is the popliteus. Popliteus muscle. This is the popliteus. And at the lateral edge of the popliteus, we go down. We also can expose here the neurovascular bundle, which is usually not necessary. This is the neurovascular bundle. It's on the popliteus and goes underneath the soleus. And on the, here in this case, on the lateral edge, on the medial edge of the fibula head, lateral to the popliteus, we go in to the tibial plateau. The popliteus tendon is retracted a little bit, and usually in this area, this is already the posterolateral tibial plateau. This small window allows to put a plate on it. On the posterolateral tibial plateau, a short plate should be not too long. You should not go down too far distally. And now you can see the posterolateral tibial plateau, but you only see 20 to 30% of the posterolateral tibial plateau, as you see here. This is the posterolateral tibial plateau. You can put a plate again on it or screws, whatever you want to do. And we see now this fragment on the 3D printed tibial plateau fracture. And then we use the anterolateral window. It's exactly what you probably all do every day in your tibial plateau fractures. It's anterior to the biceps tendon, and this is a lateral collateral ligament. This is a structure you have to really preserve. It's very often cut in AO courses. I did really the last 10 years a lot of AO knee courses, and I would say 20% of the participants cut the lateral collateral ligament. If you cut it, you get a really nice view to the tibial plateau, but then it's cut, and it leads to instabilities, and very often it needs additional surgery to refix it or to stabilize it again. Then it's a submeniscal approach, and this is a very good case because in this is an anterolateral window or a lateral window, and you see that in this, yes, you can dissect until to the lateral collateral ligament, submeniscal approach, and you see that you don't see too much. You see the lateral aspect of the tibial plateau, but it's very difficult to see the central area or the central segment. So in such a case, we do usually an osteotomy of the lateral epicondyle. You see the popliteus tendon and the lateral collateral ligament at the lateral side. They are exposed here, and then we do at least a 2 times 2 centimeters big cube. We chisel out of the femur to extend the approach. You see here, we prefer to have a big cube, a big bony cube, and then You can incise a little bit the posterior capsule. You get a really great view on the lateral condyle of the femur. And then you get a really good view to the tibial plateau. If you want to subluxate the lateral meniscus, this is also possible in the way you see it here with some sutures pulled out to the contralateral side percutaneously. And you get a subluxation of the lateral meniscus and you get a really, really huge view. Usually we don't open up too much the tibialis anterior compartment. And with this two-window technique, with the posterior window and the lateral window, you can do a nice reduction of the plateau. And especially in this case, the central segment was really difficult to reduce. And but if you have a great view and a good chance to visualize, especially the central segments, you have the chance to get a good reduction under full visual control. And even if you have full visual control, sometimes it remains difficult to get it nicely reduced and also fixed, especially in this cadaver knees. These are usually old people with soft tissue. And now you see here the refixation with usually 2 screws. And the meniscus especially has to be refixated to the capsule. That is very important in this case, but we never had any subluxation of the meniscus. These are the postoperative x-rays. I think it's a really complete anatomic reduction of the fracture, and it's doing, and I think it was really completely without any steps and gaps. And what might be also interesting just quickly is a finite element analysis post-operatively. So this is the post-operative scan, and it's possible to do a finite element analysis. So it's a kind of a virtual biomechanics is from this supporter custom search, and Thomas Sumbrum has made that for me. And you see with this finite element analysis, you can simulate instabilities. And I think everybody will agree that this was probably a nice reduction of the fracture. But if you take a look at the finite element analysis, the posterolateral fragment is probably it's okay, but maybe a small plate would have been also good. And on the medial side, as you see here, you see that the plate on the left, in the left picture, that was the plate we used. We did it a little bit more to the medial side, or directly medial side, not too much posteromedial. And this screw, the anterior screw of the plate, is in the anteromedial fragment, and that helps really a lot to get a complete different biomechanics than if you put the screw like on the right side from posterior. So the anteromedial fragment here is red, though that means there is still probably under partial weight bearing more movement than 2 millimeters. Okay, so this is a kind of a virtual biomechanics. Where should we put the plate on? And it might be innovation for the future. I think that can be very helpful for us to really understand exactly pre and post-operative where we should the plates. Just one more slide, or one last slide, to the clinical results after complex lateral or bicondyle tibial plateau fracture with this posterolateral approach with extension of the in the way of osteotomy of the lateral epicondyle. 65 patients, in average 47-year-old. And again, usually complex fracture. As you see here in the picture, it's a B3 fracture, but it's really a difficult fracture to treat. So in these cases, we do usually an extended approach. In most cases, in prone position, posterolateral, expose the whole plateau by osteotomy of the epicondyle. It's submitted to injury and it's under revision at the moment. And we have really good results. I was astonished. They were examined in average after 4 years. These patients, I did it not by myself. It was a colleague who examined. So there's no bias. It's also not a a colleague of my team. This was out of our team, so it was an independent examination of a colleague, and he found really good results in this kind of really difficult fractures, especially for me. Thank you very much, and I'm very open for questions.
Thanks, Karl-Heinz. This was great. I know our dear friend Kufri he swears by that femoral osteotomy. So is this part of your plan as well, right from the beginning, to do femoral, medial femoral condylar osteotomy to accentuate visibility, or when required, only then you would take that step?
Only when required. You know, I always start with in this case, is lateral or posterolateral. It depends on the fracture, but with the approach. And then my concept is always direct approach to the fracture and extension as needed stepwise. So if I have a problem, I do an extension. And to be honest, I would say in at least 80% of the cases where the central fragments are involved, where it's not only a depression, but multiple fragments, we expose the tibial plateau with an osteotomy. And we became more generous in the last 2 years because we saw that we don't have much problems with the osteotomy. The osteotomy usually heals well if it's a big piece of bone. We had 2 complications, 10 years. We started already 10 years ago with these osteotomies, and we had 2 complications, and in both complications we had only a small osseous flip of the lateral condyle, because we were a little bit anxious at the beginning, but then we chiseled really out big cubes, osseous cubes, and fix it just with 2 screws, and that usually heals well and does not cause too much problems. So we are a little bit more generous, but nevertheless, we never expose an approach if not necessary. Sometimes we have hyperlux people where you can, or especially young ladies, you can open the joint without any osteotomy and get a great view. So it's not necessary to expose this in the primary setting. So only if we have not a good visualization of the fracture, then we stepwise extend the approach.
Thanks.
Professor Frosch, it's fantastic, your anatomical study. I just didn't get it exactly what you're doing with the popliteal tendon. Often it is disturbing me, the view there. You make also a bone chip to take it away, or no? And the second, do you have some traction? I'm always a little bit in this posterolateral area, afraid about peroneal nerve damages. Do you have traction damages? Some assistant had a Langbeck hook around it. I would look all the time to the resident.
Absolutely. To the last part of the question, absolutely. You have to be very careful with the peroneal nerve. It's a very sensitive nerve, and you have pretty quickly a palsy. So be very careful, and especially the hook for the peroneal nerve, where you retract it, if really necessary, should not be a student. That's number 1. Number 2, to your first question, the popliteus tendon, the femoral footprint of the popliteus tendon is included in the osteotomy. So we chisel out the osseous cube with the lateral collateral ligament and the popliteus tendon, and then you get a good view to the tibial plateau. To be honest, we did up to now more than 200 osteotomies of the lateral epicondyle. We did not have any, not even one problem with the peroneal nerve. Especially if you don't cut, or if you don't cut the iliotibial band perpendicular, we open the iliotibial band, which is usually gets some lateral stabilization. So we don't open it in an S-shaped way or in a perpendicular manner. We open it in a longitudinal manner. So some stability for the joint is still there. So you will not be able to open the joint more than 5, 6, 7 millimeters. but that's enough to get a great view, and it's not enough to get an peroneal nerve palsy, I think.
So, Dr. Frosch, I didn't understand the last bit of your finite element analysis. Did you say that the posterior plate was better or the slightly more anterior plate was better in the finite element analysis?
Yes, thank you for that question. It was pretty quick, unfortunately. Sorry. The medial side was a medial split, and unfortunately, it was not only a posterolateral fragment; it was also a posteromedial, anteromedial fragment. So we had two fragments out of the not contact with the shaft. So we had to close these fragments, and with just a posterior plate, the anteromedial fragment was not stable enough, especially in this virtual biomechanics or in this finite element analysis. This is not evaluated, you know, it's an innovation. I think it may help the surgeon to better plan the surgery, because it can also be done prior surgery. But when the plate was not only from posterior, when the plate was put a little bit more to the medial side and just with the anterior screw, when in the anteromedial fragment, then it was much more stable.
Okay, that's interesting, because we usually try to put the plate more posterior so that we get a good buttressing of the posteromedial fragment.
We published it because we had the feeling that's the right way, but this virtual biomechanics unfortunately showed that it's probably better to put it a little bit more to the anterior part. If the anteromedial plateau is really fractured and not in contact anymore, in a stable contact anymore with the shaft.
Thank you.
Nice presentation, Dr. Mukhi over here. If there is an ACL and a PCL avulsion, wouldn't you tackle it at the same time?
Yes, we always try to do everything in the same time. If there is an ACL or PCL avulsion, we fix it with screw or usually with a wire. The bony fragment. In many cases in bicondylar fracture, you have the chance, if you compress the tibial plateau, to compress the central fragments, especially the ACL fragments, ACL fragment, if it's a bony avulsion of the ACL, you very often have the chance to compress it between medial and lateral plateau and don't have to fix it. I would say this is 70% of the cases. And in the other cases, we usually use a wire to fix it or very seldom a screw. But yes, we fix it. And if it's just a tear of the ACL, we also fix it, we do a suture. We have the experience that in tibial plateau fractures, ACLs heal much better than if you have an isolated ACL in a sports injured person. That heal not very well if you suture it, but in a tibial plateau fracture, we have the feeling that it even heals. So yes, we address all the ligaments.
Thank you.
In this approach that you have described, if you have a type 3 posterolateral condyle, which are rim avulsions, especially around the fibular head or above that, then there is a limitation that you cannot take that plate more laterally because the fibular head obstructs it. So how do you fix those? In those cases, do you do an osteotomy of the fibula, or how do you approach those fragments or that depression through this approach?
Very good question, yes. Especially in this case, it sometimes can happen that we do a fibular osteotomy. But, you know, we came to the femoral condyle osteotomy because we saw that the fibular osteotomy has, I would say, at least 10% of the cases, a problem with healing. And we saw some pseudarthrosis, we saw some dislocation. The softest bone in the body, in my feeling, it's just a personal feeling, but I think the softest bone in the body is the fibular head. And so we had some problems with the fibular head, and so I tried to avoid an osteotomy of the fibular head. I would say, so we have around 250 tibial plateau fractures a year, and I would say every third year we do an osteotomy of the fibular head. And if you have such rim fractures, you also can put a small plate, a small rim plate with this approach, you can put it directly to the posterolateral tibial plateau, not go down, just a small rim plate.
Yeah.
It was published by JKO, by the way.
Yes. Hoop plate.
Yeah, for example, exactly. Yeah.
Thank you.
JK, you want to say something?
We don't hear you, JKO.
Unmute yourself, JK.
Karl is wonderful, as usual. I really enjoyed it.
Thank you. Thank you very much.
So this is a question for Dr. Frosch and for Dr. Paul, if he's still with us. Now, when we are faced with these complex bicondylar proximal tibial plateau fractures, we often fix them and we get the horizontal joint line looking pretty good. If you take a post-operative X-ray and compare it with the opposite normal side, you often find that we increase the width of the proximal tibia. Now, most of us at this stage would accept it, saying we've done all the hard work and this is okay. So the question is this fine to leave it? And is there any data to show that long-term, is there any increase on the wear rates and early arthritis?
So can I had some acoustic problems, so you asked if you have postoperatively and a valgus or a valgus. In most cases, we have a valgus, yeah, right? Postoperatively. Is that the question? What do we do if we have postoperatively a valgus?
He's asking about condylar widening.
Oh, widening. Oh, sorry. Okay. Yeah, please, Paul. Yeah.
Yeah, I mean, I think you want a congruent joint, and if the condyle is wide, you by definition don't have a perfectly congruent joint. So I tend to when you compress these, they don't tend to be wide. In my experience, it's hard to keep them at their proper width because as those screws go in from the lateral side, they can keep compressing, particularly if you have comminution in the center point in softer bone. So I've not really seen a lot of condylar widening. In fact, in bicondylar fractures, the ones I've seen that are apparent condylar widening are typically a malreduction of the medial side.
Yeah, I think there is, what you have to know in condylar widening is, number one, the medial condyle of the tibial plateau is directly in line with the medial condyle of the femur. On the lateral side, the lateral condyle of the tibial plateau is usually 4 millimeters in average wider than the lateral condyle, or the lateral condyle of the tibial plateau is usually in line with the lateral epicondyle. So the normal plateau on the lateral side is always, one has the feeling, always a little bit wider. That is number one. Number two is what Paul already mentioned. If you use some leg screw or a clamp to reduce it, it's very seldom that you get a wide tibial plateau. If you don't do that and start directly with the angular stable plate, which does not allow maybe to put any compression on the tibial plateau, you end up with widening. So if you really have a widened tibial plateau, you have to really exactly analyze what is the problem. And if the patient is, if it's more, I would say, than 3, 4, 5 millimeters, I probably would strongly recommend to do a revision. If it's less, sometimes difficult to decide, but if there is no step, just some small gaps, I think it might be tolerable.
Okay. Thank you very much. So, thanks, Karl-Heinz, and I'm sure you heard the claps from Indian shores for you. As I promised over the beer last time we met. So the World TraumaCon now moves from, we started with North Americas, Mexico, went to JKO in Korea, Europe, and now the last bit over to UK. So, Peter, yours.
So, let me see where I can share my screen.
What time is it, Peter? 6 o'clock in the morning?
Actually, I just arrived in Greece earlier this morning, so it's about 7 o'clock here.
All right.
But let me see whether I can get the right presentation. Just give me 1 second.
Yeah. Do you want Jayne to do first?
No, it's okay. I just want to make sure that I've got the right slides.
All right. So it's been difficult for all of us to sit down and adjust the world clock. So we decided Paul Tornetta from Boston goes first because for him, I'm sure it's midnight now, over midnight actually. And then Mexico, so Rodrigo and Claudia, and then JK, we came to Asia Pacific, and then, Colombia, so South Americas. And then we started with Europe.
Okay, just bear with me. Can you hear them? Can you see my screen now?
I can see, yes, we can now. Start
You're not in
slideshow.
presenter mode though, Peter.
Yeah, you're
There
good.
it is. That's perfect.
Okay. Can you see it now?
Yes, we are good.
Oh,
Okay. So I would like to present the femoral case. So this is a case, 26-year-old male, open femoral fracture. It was managed originally as shown and was referred to my clinic with this picture, as you can see, the non-union, 9 months down the line with ongoing pain. Now you may all say, well, this is a typical femoral non-union, etc. I can tell you that the biochemical investigation was normal in terms of screening for infection, the CRP, the white blood counts, the ESR, etc. However, on clinical examination, assessing for deformity and leg length discrepancy, it was obvious that this patient had a leg length discrepancy of about 2.2 centimeters on the affected side, as you can see here, from the long leg views and the clinical picture. And the question now is, how do we manage this case? We've got obviously a previous open fracture. I can tell you that it was open at the fracture site, debrided and then nailed. And we've got this picture on the X-ray. You can see that there is inertia. Of course, the first thing that goes into mind is infection, maybe low-grade infection. Biochemical profile normal, and we've got also this shortening. Sushrut, any ideas how you would approach this problem?
So considering that there is no infection or it's been ruled out, probably I will just put a plate there. The cause of non-union is instability at the fracture site. So put in a plate and add some medial grafts. That's what I would do and hope for union.
I would renail it because the entrance point is much too ventral. The proximal fragment is a flexion. We need an intermedullary screw or wire for blocking this wrong pad of the nail and renail it. With a plate, we cannot reduce this. It is the wrong entrance point and the wrong direction. And when you have a short articular fragment, you never can reduce this with a plate, on my view.
Okay, fair points. What about the shortening?
It is due to the flexion position and the oblique fracture. They are compressed. So a complete new nailing with correct entrance point, correct reduction. Take out the flexion of the proximal fragment. By the psoas traction, it was in the flexion position, and it was not corrected. It was not correct entrance point. It's very, very ventral entrance point, so all is shortened. Also, the flexion gives some shortening, but mainly it is slipping the oblique plane of the fracture, one fragment to the other. So it must be corrected completely.
And would you bone graft this?
Not necessary. I would ream it and then I have an internal bone grafting.
Okay, okay, fair enough.
Hi,
So in the
Peter.
interest of time, sorry.
Hi, Peter. This is Peter. We are
Hi.
we are now running a study, a multi-center study, compression distraction with motorized magnetic-driven nails, and I have first results in one patient. He has a very similar constellation. We just we didn't open the sutarthrosis. We just compressed it very strongly, and after 6 weeks we distracted it, and we see callus formation. But this is only first evidence. I would not recommend it as a standard procedure.
Okay, so yeah, there are different options, I guess, depending on your expertise, what devices you've got in house. But the point here is, if we stick with the principles, we've got a non-union, a previous open fracture. There is always at the back of our mind the possibility of infection. And if you all have read the work from Leeds, that in the presence of a normal biochemical examination in terms of screening for infection, we've shown from Leeds that the possibility of infection looking into the cultures afterwards is as high as 30%, despite the fact that you've got normal CRP and white blood count and ESR. So the distal screw was broken, as you can see, it was removed. The case was renailed, as you said. And when the non-union site was exposed, the bone edges were found to be necrotic avascular. I was concerned about infection, and indeed, the bone tissues that I sent came back as Staphylococcus with Staphylococcus aureus infection. And after debriding that bone edges to what I thought to be a healthy vascular bone margin, we ended up having a defect of about 2.1 centimeters. And here you see the defect. And if you think about it, that there was also another, a shortening of 2.2 centimeters, then from this position here now, which was after the nailing, we need to compute and see that there was a defect that we need to give a length of about 4.3 centimeters. And this is what I want to share with you, that in these situations, you put the nail, you don't lock the nail distally, and by using a laminar spreader, a big one, you can restore the length that you would like to achieve. On this occasion, 4.3 centimeters gradually. Another option to do that, it would be a unicortical femoral distractor to get down to the correcting the discrepancy which is present. And obviously afterwards, you can see here that the length now, the required length has been restored to address the problem that the patient was complaining as well. Due to the defect now, the 4.3 centimeters defect, a cement spacer was introduced. At this point, obviously, I wasn't sure whether it was infected, but eventually, as I said, it came out to be infected. But that was the best option to address the possibility of infection by releasing locally antibiotics with the spacer loaded with vancomycin, but also to induce the membrane and obviously come back and graft the defect that was created. You can see the postoperative films that restoration of the defect was achieved, of the leg length discrepancy was achieved. And here is at the second stage, 8 weeks later, the defect area now with the membrane, which has been induced. I do use in my practice, as well as J.O. reported previously in his case, I use quite frequently with my grafting bone morphogenetic protein 2. I think it enhances the rapid vascularization of the graft material there and the overall osteogenesis process and the mineralization process. So I think the defects heal faster, as we reported from my unit. This is again the graft that has been the PMP graft. Then we go to the next one. And this is the rear graft that I harvested from the contralateral side. And then you close the membrane. You can see here the postoperative radiographs after the second stage with the bone graft in situ. And that was the evolution of healing with restoration of the discrepancy that was present 9 months down the line. So the take-home message is that the leg length discrepancy can also be corrected during the musculate membrane technique application, using either a laminar spreader or a femoral distractor. And in my hands, at least defects up to 3 centimeters can be restored without any issues in terms of creating nerve lesions, nerve damage, or any issues with the vessels in the acute setting. And I think these also should be considered when we utilize this technique to assess, to treat bone defects, as previously this technique has been criticized that unless you use bone transport, you cannot restore leg length discrepancy with a muscular technique. Thank you very much for listening.
So Peter, did you have culture positive at any point in time? When you took this step of, removing the piece of bone and creating the defect, was the culture positive?
Yeah, it was positive afterwards.
Yeah.
And the patient was treated, as I said, with antibiotics for a period of 6 weeks.
Okay. Any questions?
One of the distal screws was broken. So you think that when grafting it, adding an augmentation plate would have helped?
Well, yes, the fracture was dynamized, it was broken, but it wasn't really a major issue and it didn't affect the leg length discrepancy. That can happen. I do not normally add augmentation plating unless there is a bigger defect and I'm concerned and it's close to, particularly for the tibias, but on this occasion I was not. But it's a well-described technique as well to consider when you've got these difficult cases.
So you said big defect. So what is the cutoff like? It was almost 4.3. So what is big for you? When you
For me, big defects is more than 6 centimeters, 8, 10, 12, 14 centimeters.
Thank you.
Peter, we get a little skeptical that there was no demonstrable pus. So we, as of now, are thinking in terms of aseptic non-union because of instability, and the first kind of go-to surgery would have been just a plate and graft and maybe take a culture and hope for this to heal and consider limb length discrepancy correction at a later date after achieving fracture union. So what's your take on that?
Well, first of all, this being an open fracture and looking at the X-ray, despite the bad nailing and the flexion deformity of the proximal segment, and in my practice, as I said, when you see this picture, completely inertia, and also despite the fact that you've got normal biochemical investigation, the CRP and the white blood count and the ESR, etc., as I said, based on 110 cases from my unit, the risk of having low-grade infection without being detected by the blood investigation is about 30%. So I was skeptical about the bone being necrotic, possibly being infected, and I was right. And when you do that, unless you debride this bone edge, the possibility of union, in my opinion, is low. So this is why I debrided the edges. And then at the same time, since I created a defect, I felt it was the right timing as well to restore the length. And there was no need to come back for a second stage or use bone transport at a later stage or whatever. So, and this is why I thought I'll share this with you, because with one-step surgery, you can address all these issues without having to come back again.
Sure. Sure.
But in your 2 centimeter shortening in the initial X-ray was because of the flexion of the proximal fragment. If we are doing the revision and correcting that flexion, I think that shortening will be corrected with that revision only.
Yes, but what I said is,
what you said,
he removed the osteonecrotic ends of the bone, and the defect was more. That's what happened, despite of that correction. Yeah, next question.
Do you use the cement spacer in this case? Because the masculate membrane will develop better if you use cement in between.
He used it.
You agree? Okay.
Yeah. Okay.
Have you encountered any neurovascular damage during this using laminar spreader and making that gap?
He says till 6 centimeter it doesn't happen. That's what he just said.
No, I said up to 3 centimeters. I think you can use a technique or a femoral distractor.
Okay. Okay, sir. Thank you.
Thank you. All right. So thanks, Peter. Thank you for joining, and we move on to the next slot and the last slot of World TraumaCon. Over to you, Jayne. All yours.
Hi, very, very good morning for us over in England. Let me just put it back to the beginning here. And I shall ask that awful question that can you all see my slides okay?
Perfect. Looks good.
Perfect. Okay, so we were given the title of Thinking Beyond. So what I thought I'd do is spend the next few minutes looking at a completely different side and sort of different salvage techniques that may be gaining increasing popularity over here in the UK. So this is our first case. I'm very excited when I get this. It's an easy day in the OR or the theatre for me. There's no fracture at all. It's just an extruded talus. Yes, it looks a bit dirty, but plastic surgeons can easily flap that. All we need to do is give it a quick clean and we're on to a winner. Unfortunately, one of my colleagues sends me a photo of this with the talus actually in the bin. And now I am left with this defect. So we go back to principles. And first of all, obviously, we want to get really good soft tissue coverage and we want to get rid of infection. And I think whenever we're talking about infection, external fixation, certainly as a temporary device with local delivery of antibiotics in whatever shape that may be, is a good thing. But the question is now, what do we do with the talus? And these are the things that I could come up with to start with. Okay, amputation, it's very predictable, but he's only 44. And of course, you can do a tibiocalcaneal fusion. Doesn't matter really what implant you're going to do that with, plus or minus your lengthening at the top. But getting the tibia to fit onto the calcaneum is a bit less than ideal. And I'm a bit like JK, when I hear the word frames, I get a little bit prickly as well. So I thought, well, is there anything out there in this young guy that can maybe address both things at the same time, which is essentially going to be the limb length discrepancy and the lack of the talus? And then I'd heard that you can actually now do some 3D printed implants, and Ortho-Plastic are obviously doing this all the time, and this is what I plan to do. So this is my first case, and I'd be very interested to know if the speakers have got any top tips or whether they've had any experience with these implants for trauma. You can obviously design the implant exactly how you want it, and you can put that in conjunction with either nails or plates. And the bearing you can see on the talionavicular joint is different, so hopefully trying to keep that articulation. All the surgery went very well. My one take-home message from this is that you, with this particular company, can get 3 different sizes of implants. So I went for what I thought would fit based on preoperative CTs, a bigger one and a smaller one. I mean, it's common sense really, but everything in trauma gets tighter and tighter and tighter. And certainly when I've gone on to do this again in the future, I've gone for the implant, I think, the smaller size and the smaller size than that, because it's very difficult to get it in. Anyway, he's several years down the line, and I thought this is quite an elegant strategy, really a 2-stage procedure in order to keep his length and stop him having a frame. So case 2 now, we'll move on to similar type of thing, but for a whole different indication altogether. So this is a gunshot. So fortunately, we don't see a huge amount of these in the UK. I think Paul mentioned earlier on, he gets a bit averse to nailing in gunshots. And certainly my experience has been that they often have a very high risk of infection too. So this is a Schatzker 6 3C with a completely transected popliteal artery. And I have to admit, when I embarked on this case, I was pretty much 99% sure that this would end up with an above knee amputation. But we never know how patients are going to do, so we're just going to follow principles. So he has a joint ortho-plastic procedure with the vascular surgeons for a temporary shunt, first of all, to reperfuse the leg. Obviously then goes on to get a debridement and temporary stabilization. Long saphenous bypass, which is tunneled underneath soleus, and a mascule procedure to try and sort out his bone defect. Bilateral gastrocs eventually to cover the defect. And throughout the whole process, I was very much, at one point he's obviously going to get infected, or maybe the vascular graft won't work. But actually, lo and behold, he goes on with his 2nd stage mascule to have a posterior approach to the knee where his soft tissues are good. You can see I've taken his fibula and I've bivalved that to put it into the defect. Regrows almost a new fibula. He's got great healing potential, and he's got a union of his tibia with only 1 screw that's broken. I'm very happy at this stage. He comes back to see me and says, look, Jayne, can you sort out my limb length discrepancy? And I really had only one answer for him. That was, no, I can't, mate. You have to quit while you're ahead. Anyhow, he's very, very adamant that he can't live with this imbalance in his leg. And can I do something about it? So I thought about it, and I really, really wanted to do nothing. I actually had listed him to shorten the other leg. And when it came up to the surgery, which is around COVID time, actually it got cancelled. I was really glad about that. I felt personally he had 1 really good leg. I still don't think his other leg's going to last him his lifetime. And I thought, if I shorten the other leg and it goes wrong, I've really done him harm. I've done him a disservice. He would not consent to have a frame. He'd had a frame, albeit spanning his knee for a short period of time, and he wouldn't have a frame. And obviously I'd have to do a distal lengthening because I'm not going to go anywhere near his vascular graft at the top. Thought about lengthening his femur, but then that would leave him with inequality in his legs when he sits down. So he said that he would consent for a frame for a very short period of time. So over 4 weeks, distracted him out very acutely. If I was doing this again, his Achilles got really, really tight, and I really should have included the foot. And then I'm left with a bone defect, really. And I thought what I would do to save him time in his frame, remembering his ankle joint is already pretty fused anyway, is we would 3D print him some metal to decrease his frame time. And this was, as far as I know, sort of the only use for acute lengthening for a 3D implant. And you can see, I think because I've put it in his regenerate as I've distracted him, he's actually grown a whole tibia around his 3D implant, and he's very, very happy with that. So certainly he's got some of his leg length back. I appreciate it's not as much as the other side, but it definitely means that he didn't have to have a frame for a very long period of time. So my very last case, I didn't want you to think all things were rosy, and these are very, very high risk procedures. So this is a 36-year-old chap. He's had an open fracture. He's a type C host, and he has a horrible patient journey, including infix, a combined ortho-plastic procedure with an ORIF and a free tissue transfer in form of an ART. His plate gets infected, his medial metalwork then fails. He has a frame, and another ORIF, and ultimately ends up with a hindfoot nail. Disappears off for quite some period of time, which I'm delighted about. Unfortunately, comes back with a painful non-union. Looking at this, his leg is okay, his soft tissues are fairly tight, but you can see he's got a huge amount of deformity and a foot that's really not shearable. For me, I felt that probably an amputation would be in his best interest. He'd certainly be able to rehabilitate quicker, but he didn't give his consent for that. So we could excise and transport and bone graft him, but he's been through so much. Again, he really just wants one more procedure. So with a huge amount of counselling, I decided I've tried everything to get this bone to heal. It clearly is not going to heal. So I will try and excise the non-union and 3D print him something to go in. What I've probably failed to appreciate that he's now got a single vessel leg, and he's had so many surgeries that you only have to sort of just nibble away a tiny little bone, and I managed to cut his anterior tibial artery. Very grateful to my plastic surgeons to come and bail me out. Again, a 2-stage procedure like all my others have been, with a cement spacer and samples taken at this stage, because obviously, as we just heard from Pete, the risk of infection in someone who's had so many surgeries is incredibly high. This is what I wanted to try and achieve. And I have to admit, I was pretty pleased. I managed to cut the anterior tibial artery again, and it was repaired again, but I really did what I wanted to do. Unfortunately, though, despite being in hospital for a little while, as soon as he goes home and starts doing his normal recreation, he ends up with a sinus. And really, at this point, there's no salvage, and he has an amputation, which you could argue maybe should have been much, much earlier on in his patient journey. But I would say by the time he came to the amputation, it was the right thing for him, and his head was in the right place to really accept this. So my take-home message is that 3D custom implants is a pretty new technology in terms of trauma. We're lagging behind our arthroplasty colleagues who have, of course, been doing it for a long time. It does require a huge amount of planning and discussion, and I'm grateful to especially the foot and ankle consultants in the UK. You've done a lot more of these. It's probably a good time to have a colleague or a friend with you. It's a long surgery. And really what we're finding as a user group is we really are suggesting that these are done in 2 stages. So you absolutely have to have your minimum of 5 samples to make sure things aren't infected. You probably need some sort of temporary external fixation with delivery of local antibiotics, and you must of course have robust soft tissue coverage. So I guess the question is watch this space in case we end up doing more and more and more. Okay, thank you.
Thanks, Jen. I think JK and Jen, we seem to have stuck with that magic number of 5 samples. Any questions? Sampath, Mandeep, sir?
Hi, Jayne. This is Mandeep Dhillon, and sitting right in front of me is Sampath. We just published an injury about a year ago about these extruded talus. And we also looked at some of our cases, and we published. We were able to wash them and put them back. So many of them survived. Some of them collapsed, and 1 or 2 of them got infected. Even those guys never wanted an amputation. May I ask Sampath to stand up and also add to it? What was the one reason why you never put that talus back there? Was it contaminated, or what was the reason?
Sorry, maybe I didn't explain very well. No, I completely agree. It's much, much better to have your own bone. You don't know what's going to happen to it. Unfortunately, I say it was a colleague of mine who had debrided it and literally had put it in the bin. And I just got a photo of it out. So it wouldn't have been my choice. But that's the nature of trauma, is you can't change what's happened. You're going to deal with what's presented in front of you. But definitely, I would have left it and see what would have happened.
But let me just tell you, Sampath and me have experienced that people bring the talus in a sock. And then you have to clean it up and put it. Sampath, can you take it up?
Yeah. Hi, Jayne. We have a series of more than 22 patients. We have looked at the complications. There is avian arthritis, but that is not the end of the story because still they have reasonable function. So both Mandeep sir and I believe that putting it back at least gives a valuable chance. And with these talar implants, we have done in India as well, but we have yet to see the long-term results. So at present, we are happy with replantation for now.
And Sampath, can I ask, did you, with the ones you've done, had you just printed the talus itself, or had you printed it with a nail to go inside?
Yeah, 3D printing, again, 3 sizes only, and we choose the nearest size. And but it is pretty recent, hardly 1 or 2 years of follow-up. Yeah, so when we replanted, we just went for very simple fixation. 1 Stillman pin across tibia talus to tibia calcaneus, and another from navicular talus. That is simple fixation, which may added with the external fixator.
I have a question. Maybe I'm not into that topic. Are these cages which are augmented with bone graft? Are they titanium? Are they polylactite? Can you explain, please?
So they're trabecular metal, and I say you can have them in different coatings. They're designed as that mesh so that if you wanted to put your bone graft inside them, you easily can do. I have to admit that I haven't done with mine. You could also mix them with Cerament as well. Sometimes for mine, my soft tissue envelope hasn't quite been good enough in order for me to pack a whole lot of bone graft in. And certainly with the one that I distracted with the frame, there was no bone graft in there.
Maybe you know the works of Kevin Tetsworth with his titanium cages augmented, which have a very nice osseointegration.
So,
Okay,
Jayne,
so that brings us to the end of World TraumaCon. In an endeavor to make the entire world one, this is Trauma Society of India's attempt to make sure we are all on the same page. I deeply appreciate America's contribution, Professor Paul Tornetta. Paul, thank you very much. Seriously. And from South America's Rodrigo and Claudia, thank you. JKO, thank you very much. Europe, Professor Frosch, Karl-Heinz, thank you very much. Again, appreciate a lot. And from UK, Peter and my dear friend Jayne. I appreciate also my mentor here sitting, Professor Mandeep Dhillon, to give me company on the dais, and of course Wilhelm Friedl and Peter Thaler. George, you have been represented well. You want to say something, George?
Yeah, thanks again, Sushrut, for having us here as a combined congress for the Quintra Society annual meeting and the TraumaCon. It was a great pleasure for us to be invited and to be part of your team here. Thank you very much.
Thank you.
Maybe one word for the Quintra Society.
Sure.
I'm now actual vice president only, but I would be very happy if we would get more spread in the world, and we were very happy that Sushrut came to Hamburg, and we want to intensify our cooperation. When somebody would like to become a member of the society, we would have also application forms. We would happy to cooperate and exchange experiences. I think we saw today we can learn from all over the world together. Thank you very much.
Sure, thank you. Okay, over to the next program. Thank you.
Okay, thank you. Bye.
Bye-bye. Tanna sir, Baba, Professor's take.
We are going to answer all the questions.
Mandeep? Where is Mandeep? And Sangeet? Yeah, Peter Thaler? Yeah, this is a typical professor's take, which we used to call it a dig the professor in past. In order to get maximum from the learned faculty in coming 3/4 of an hour, we would appreciate a cooperation of the audience by not insisting on opining unless requested. We all may not agree on some of the views, but those are the views of the accomplished experts, and they are going to enlighten us today. We have the solutions to all problems when they are not ours. Now, here is the case in infrasyndesmotic fractured fibula and still instability. Vivek, you want to take it? We talk about the syndesmotic injury when the fractured fibula is 3 to 4 inches above the syndesmotic injury, and then only you get a syndesmotic injury. Here you can see the instability and the fracture of the fibula at that same level.
It is the anterior tibiofibular ligament and the bony fragment along with that, which is also broken, which can be seen on.
No, I'll show you the CT. I don't want to hide anything.
These are, yeah, you can see here in that anterior fragment which is there. So
It's
that
of the fibula, no? It's of the fibula.
So it is giving you attachment and stability for the tibia as well as the fibula.
So if you fix that fractured fibula, you will be able to stabilize the syndesmosis.
That is also contributing, yes, that is also contributing to the stability of your ankle joint. And just because it's an infrasyndesmotic or
जरा mic ऊपर रखना.
it is not at the level of joint or below the joint level of the fibula, it will not contribute. It is a part of the joint stability. It should and needs to be fixed. And besides that, we will have to look at the other ligaments as well.
Yes.
So it's not a true infrasyndesmotic fracture. It actually extends to the joint level. So I would put it as a type B rather than type A fracture.
But instability here, it's come due to what, you think?
It's due to the anterior talofibular ligament. So the syndesmosis is gone. And you need to also check the medial side once you've fixed it to make sure that there's no medial ligament injury. There's the widening of the space, but more often than not, once you fix the fibula and the syndesmosis, that should come into position. But if it doesn't, you need to check the medial side.
So once you fix the fibula, do you think it is going to stabilize? Because you said if that piece has come from
you have to fix that piece also. I mean, obviously.
This is the instability you can see very well. Anterior, posterior also. You can see it here. And this is what is the actually things which is there in the patient.
Medial side also.
So medial side.
So both the things have to be opened. Medial exploration as well as anterior lateral exploration. Number one is medially I will try and trace the ligament, pull out sutures but not repair it at that stage. Go on the lateral side, open, the fragment is flipped probably, that small anterior lateral piece which has to be put back. It is probably in the fibula. I'm not too sure whether it is the anterior lateral part of tibia, but wherever it is, it has to be put back, and then fibula needs to be fixed. Medial malleolar sutures or anchor, whatever it is, has to be tied only after lateral side is fixed.
So you
It
want
is
to add
quite
something?
likely.
John, sorry,
Okay.
you want to say something? Yes, Sujay.
I would still go lateral first, and because I don't like the skin on the medial side, I would try to avoid doing something on the medial side unless it's grossly unstable.
For me, there's a set protocol for me that I start from lateral, look at the fibula, look at the syndesmosis, look at the anterior.
Look at the syndesmosis.
Look at the syndesmosis means whether it is unstable or not. Look at the anterior fragments which are there, which are usually missed many a times, and you are not able to fix that. Once I am able to stabilize this, then you look at the medial thing, whether it has come back to its place, and then you think whether it is still opening under stress and how much, then you decide to fix it. That's a sequence in which I'm going to go. In a
But
proper
Vivek, you would always require on the medial side after fixing
No.
them?
Because for me, if I am fixing the lateral, all the three components which are there, and I find that the ankle remains stable for me and it looks at a normal mortis view is there, with just stabilization in a splint or something for the next 3 to 4 weeks also can suffice, even if there is a deltoid ligament.
Yeah, what I mean on the table after fixing the lateral side and syndesmotic injury, would you test for the instability and explore the medial side?
So that's a controversial thing for me, because even if it is broken, if the ankle lateral stability is giving me the ankle mortis to be stable, I'll let it remain like that and not going specifically looking for the deltoid and trying to fix it. Fixing the deltoid, whether I have to do it or not, will purely depend on whether there is on the gross instability. If I can just put it on a stress view in the intraoperative place, if it is still opening up, then only I'll do it. Otherwise,
on
no.
table you will see the
Yes,
instability.
I'll do that, but I'll not insist on pushing it like that and trying to find out minimal amount of 1 or 2 millimeters and fix the delta. That's what.
Again, I'm reminding Dr. Sangeet and Dr. Peter, are they here? Chetan, can I invite you on the stage, please?
Every medial ligament injury in the ankle does not need to be
fixed. Up till now, we have never thought of fixing up the
So a
medial
lot of them.
ligament.
So I mean, we do occasionally do it, but in this case,
That also off late, comparatively.
True. And something like this, where the skin on the
There,
medials.
there. Chetan,
Chetan, you're not
there.
allowed to go there. Sorry.
Yeah, that is our territory. Okay, here is it. There's the first stage I felt I'll fix up the fibula. Sangeet, can you come on the stage, please? You forgot. I fix up the fibula first, and still you can see the instability which is existing, and the syndesmosis is opening it out. The medially is opening. So here, that piece which was here, you can see this was the piece. So it was lagged, neutralized, and the fibula plate was put. Now you see what is happening.
Why didn't you put a syndesmotic screw?
आएगा ना छोड़ेगा थोड़ा. Chetan, you want to add up something?
No, the syndesmosis is unstable. Need to fix it.
So what will you fix?
Additional screw
in the syndesmotic.
in the syndesmosis.
So in the syndesmotic screw, how will you put it? A leg screw or a neutralizing screw?
So you hold the syndesmosis and pass a positional screw, which is a fully threaded. I use 4 mm fully threaded 2 screws going about 15 to 20 degrees anterior from
That's right. That is what all of us do it.
out of the plate.
So I started ahead. As you can see, I held it with the clamp. And once you hold it with the clamp, then only it got reduced. So I put an ordinary screw, it won't hold it.
Through the plate. Then replacing the 1, 2, 3, third screw from bottom with a longer screw.
The oblong hole.
Would that be with that
Longer screw inside the tibia, you mean?
into the tibia?
Into the tibia, like a syndesmotic screw.
Yes.
Suprasponding screw, third screw.
Sorry.
Third screw from bottom to be removed and then drill it. Use that hole of that screw as a hole for your syndesmotic screw and put a longer screw.
Yes, what you say
Because that
something,
would-
Vivek?
Something to critically comment upon the image.
Hey, about the timer, I got only 8 minutes
Each.
for the.
Philip.
Is it?
One thing, sir. Sorry, but I'm not happy with your reduction clamp, which has been.
Clamp.
No.
Fine.
This is not the way I would try to reduce the syndesmosis.
The clamp comes from posteriorly onto the fibula and slightly anteriorly onto the
Sir,
tibia.
this clamp of a Weber's reduction clamp is not giving us the exact way. That's what it invariably tends to come anteriorly, and the tines of it invariably push the fibula or the tibia.
So how would you like to do that?
You require some sort of a C or an articular clamp which is there, which is pushing the things not from anterior but from medial to lateral.
Anybody wants to add, Sangeet? You want to add something?
No. If you have to do a clamp reduction, it is at the level of syndesmosis. This is above the syndesmosis. And fibula is posterior. So the tine, the medial tine has to be in the anterior third
Anterior thing.
and the posterior over the supramalleolar ridge. We cannot pass the screw with the plate here because the direction is 30 degrees from posterior to anterior. And the plate is probably an anti-glide or it's resting on the posterior surface.
Okay, here it was.
If you pass a syndesmotic screw through the plate, you will displace the syndesmosis. It has to be out of the plate or behind the plate if your plate is dead
This is what was happening. I passed the screw. On the table, I felt that when I passed the ordinary screw, I couldn't really compress the syndesmosis. So I passed the leg screw, and then I could get the reduction of the syndesmosis. And on the medial side, as you can see, it has come. Now it has come. Do you need a medial suturing?
So I think under normal circumstances, I would still test it at this stage. But in this patient, I would try to avoid a medial incision.
Why?
Because of the skin.
So you think it will heal up just like with the syndesmotic screw, indirectly reducing the medial ligament?
So that's what we all practiced for so many years, sir.
But now today, people are talking about trying to really get the medial ligaments sutured.
I agree that some cases you do need to, but not all.
Anybody wants to add up anything?
The question that normally one would not use a lag screw is the general principle.
Exactly. Here I felt at the end of my ordinary screw that is not good enough.
With the clamp, you passed a position screw?
Yeah.
And it wasn't holding? Or?
It wasn't holding.
So go across the other cortex then.
Here it is the CT scan of that.
John.
And here is the CT scan of the other patient, not the same patient. As you can see, if you pass the plate posteriorly and you try to pass screw outside the plate, then it goes anteriorly like this. This is what all I am trying to just demonstrate.
In the past, we had done fixation and tried to confirm by CT scan. It was almost 30 to 40% of time it was not holding on the fragment.
Yeah, but here you can actually see the syndesmosis and reduce it under vision because you have a flap of the ligament out. So it actually helps you in your reduction of the syndesmosis.
Best way is if you have an intraoperative CT scan.
Yeah, but we don't.
We don't. Many centers have it.
Very few, I think, in India.
Now I go ahead. Is it enough or you need a deltoid suturing here? By today's standard. Skin, I understand, John, what your apprehension for the skin is all right. But supposing the skin was normal or it was operable, would you, by choice, go and suture the deltoid or you will do this indirect reduction of the deltoid?
So if it was opening out?
No, like this, you got it at the end of the...
No, but at valgus, with valgus, if it was opening out...
No, it wasn't opening at all.
I'd leave it.
Sir, can I say? The time to do a medial exploration would not be at this stage. It will be much earlier because if at all you want to do a medial exploration, then you would need some movement there. It is quite likely that there is some invagination of the ligament into the joint. It is also likely that some chondral fragment is there. So if at all you are thinking of a medial exploration, it has to be before you fix the lateral side. If you are reasonably sure.
I understand your question. Once having got the syndesmotic screw and everything is reduced, would you still additionally, with the with the current thought processes, would you think that the medial ligament needs the stitching?
One question to you, sir. If
Hey, I am supposed to ask you question.
Okay. So you can ask it back to other people. Let's say that this ligament was, you have done the fixation and now all the lateral stable, lateral part and the middle column are all stable. If there was any deltoid injury right now, isolated, would you have gone in and fixed it?
I'm asking you, that's what exactly I'm asking
Anybody
you.
of us would have fixed it. Wouldn't.
Sangeet, you want to answer that?
Yeah. See, what you have done is a surrogate fixation, where instead of repairing the deltoid, you have fixed the syndesmosis.
That is what we have
and
been
taken
doing it
care
all
of.
throughout.
Yeah. So at this stage, even if you cut, nothing is going to happen. It will heal up the deltoid ligament.
So for me, what Vikas sir is saying, that if at the time of reduction of your lateral side, you have a consistent and persistent opening of your medial
side
clear space, then you have a chondral fragment or a ligament which has invaginated inside. And that is the reason why I'll have to go medially and remove it. Otherwise, if I am, as you have, Sangeet has said, surrogately, we have done that.
No, but here it is worse now because syndesmosis is not reduced.
No, this one, that's the,
that is not his.
that's his
Syndesmosis is already reduced.
No, he was confusing with the lower.
Yeah, I know it. That's why I went back.
So once it has been fixed, it is.
Now here, these are the types of syndesmotic injuries. This comes probably in this coronal instability. Now here is this case. This is Dr. Sangeet's case. This was the fracture. 2 months it was conserved. And this is what was the injury. So Dr. Sangeet went after 2 months. Sangeet, can you talk about it?
So she was a fat lady who presented at 2 months. She was conserved in a plaster. Earlier, the X-ray was, it was an undisplaced lateral malleolus fracture, simple lateral malleolus, that was at the level of syndesmosis. And the X-ray on your right, where we did osteotomy, fixed it with the interfrag, and then...
You come here afterwards. Yes, sorry, Sangeet.
So we did an interfrag to get a compression after doing an oblique osteotomy and neutralize with a plate. At this stage, we still have an opening of the medial clear space. That is, it's unstable.
But you have not put any screws or anything into the, or you haven't put a clamp also there?
No. At this stage, this is still an intra-op picture.
Yeah. No, I know the whole picture. You know it well.
So there's also a talar tilt. So
There's a medial, the deltoid ligament is defunct.
Is it tailor?
So now at this stage, only the screw is enough, or you will have to put the deltoid stitch? I'm
Sangeet.
asking one of you.
This is your patient.
Huh?
Sangeet's patient.
This is Sangeet's patient which he is talking about. Still, we have not completed the whole thing, whole
After
story.
fixing the fibula, it looks still the.
He has fixed, yes, sorry.
And tilted talus,
So
indicating medial side.
So for me, it would be a situation where I would go in and repair the medial side as well.
Yes, Dumra, you want to opine anything?
Yes, sir.
He's an ankle surgeon, foot and ankle surgeon.
Sir, this is what exactly I meant in last case also. After fixing lateral side, talus will not displace, but there will be rotational tilting. So even in last case, if you see rotational tilting, no harm in exploring medial side, because as you expect lateral column when you stabilize, you don't expect it to displace, but there will be definitely a rotational opening. Gap will be unequal on medial and superior side. So that is a valid indication for you to explore. So in this case also, it is worth exploring it. And second thing, when you find such low fibula fractures showing so much of instability, never forget to see proximal fibula, because that is what we miss. And Masonry injury along with that intraosseous is underestimated, and which you have indirectly taken care by that last screw. So that point should not be missed. When small fibula fracture giving such an instability, please don't forget
See the
to
method of
see
fracture.
No, but you also
Thank you
need
very
to
much.
look at the obliquity of the fracture, because if you look at that, it's an oblique fracture which goes well above the almost above the syndesmosis on the lateral view.
And in this case, if you are revising, please see the
You need to
posterior-
get it down to length and do it.
posterior
And
macular-
here is the case where Dr. Sangeet fixed up the deltoid with the yes.
So
Sangeet?
unless the talus will not reduce anatomically unless you open medially. At 2 months, usually there is a fibrous tissue at the crural angle. And unless you take out that, the talus is not going to shift, even if you have fixed the fibula anatomically. Patient still had open medial clear space. And at this stage, will the syndesmosis is normal here. So how a syndesmotic screw will help in this situation?
I'm
It will
asking
not.
you now, it's
It
your
will
baby.
not. It will not.
It will not.
Sir,
Okay.
can I interrupt? Can I ask?
Yes, yes.
Sir, especially in this case, when there is a clear medial and medial space to start with, the injury is 2 months old. One must explore on the medial side, preempt that there is something, and not explore after you have fixed the fibula. Because you will not be able to clear all that fibrous tissue from the medial side. So the time to do that is both incisions together, clear the medial space, and then fix the lateral side.
Okay. We proceed further. Deltoid ligament we have discussed already. Here. Can I request the timekeeper to please keep 45 minutes here, so whatever is time is gone, just let us see how much time is remaining. Don't put this every case things. Put it total 45, whatever we have consumed, so you put it now the time there. Now, how will you treat 64-year-old, 4 surgeries, nailing, plating, grafting, non-union, walking with non-union for 20 years, no sinus, no infection? How do you handle this? John?
So I think you can see that when you look at the X-rays, you're getting almost a.
He was walking on the fibula, as you can see.
And so you're going to need to do a fibula osteotomy to help you straighten, and then on open reduction, and probably for me this would be a nail fixation. Take out a wedge, almost a chunk of fibula, and then get the.
Anybody else have any other value addition?
Maybe here I'll go in for a dual construct.
Sorry?
Dual construct of
Dual
a nail and a
construct.
plate.
A nail and a
with
plate.
Fibular osteotomy.
Anybody wants to give any other?
Ilizarov is not a bad option.
Sorry?
Ilizarov is not a bad option. It is a very valid option.
Skin to be seen first on the
Sorry.
medial side. Medial soft tissues to be seen first, because you have a virus which is long standing. And once you correct that virus, that skin is going to be stretched. With multiple surgeries, that skin is very likely to be adherent. And that is something that has to be addressed. It has to be kept in mind. So a clinical photograph, especially showing the medial.
There was no issue. This was my case.
Then I would go with John. A big wedge of fibula to be taken out, because once you put it
Here
into
it is.
virus,
Here it is. Same thing what I have done. Here it is. Nailing, grafting, plating, fibular osteotomy, and everything has been done there. There is no plate. No. He said advise the double plating. Vivek. Okay. Here. Agashe, I want you to start here. Because the dense sclerosis, again, this is the one which is a 25-year-old, 4 surgeries, 8 years now. Now what?
so as I said,
Why I'm asking you is, you and me have been arguing all the time that dense sclerosis has to be excised.
yes.
And here, how will you? You will excise and do Alizarao?
I will excite.
And do Alizarao?
Not necessarily. I'll probably put in a nail and put grafts. If I feel that it is still not very stable, I might add a medial plate. I might add a plate.
So if I am repeating you properly, all the sclerotic bone you will excise.
Sir, can I mark?
Yeah, but please. Can you give him a pointer? Here is the pointer I put. Go ahead. Thank you, Mukhi sir. Please, I have requested you, please do not interrupt. I'm sorry.
So my thought process will be, this fibula comes out. This fibula comes out, which seems to be at the deformity. Then I will excise like this. Not this, sir. Not this whole thing. I will start like this, and then every cut, I will see whether it is reasonably all right. I'll make it a point to open the medullary canal and see if it is bleeding inside. I mean, I don't mean to say that I'll excise all this.
Still there will be a sclerosed bone.
There will be some sclerosed bone somewhere here.
Because we have been arguing every time, so I'm starting with him.
Yes. So I'm not going to excise all this, but I will.
So what is the logic of excising a little and not all?
I will definitely excise the fracture site on either side like this. Number one is I have to get a reduction. That is number one. Number two, I have to have a living bone. I would not like a
No, you made your point.
bone. Yeah.
You made your point. Perfectly right. So you will excise a part of the bone and try to see whether it is live.
Yes.
Thank
How
you.
are you going to see it live? By bleeding or from freshening of the thing and bleeding
Can
from the
you
bones?
speak a little?
How are we going to see that the bone which we are remaining is live?
First, Vivek, sorry. No.
मुझे भी तो सीखने का है.
No, my question is, first he is talking about excising the sclerosed bone. Do you agree to that or you don't agree to that? Then you start ahead.
Yes, I'll do, because you have to create a wedge anyway to remove and get that correction of that.
No, that is for the correction.
Yes.
But for osteosynthesis?
Not completely. I'm not going to remove. That's what I want to know. I'm just removing a wedge from there to get
To have a bone correction.
Yeah, alignment. But if we are going to remove the dead sclerotic bone and to till the live portion of the bone, how are we going to see it intraoperatively that this is live bone?
So very often the cortex per se, upper cortex may be avascular. So I will try and take out the superficial layer of the cortex. I will also see the inner side, the medulla, after I make holes.
And
then
it goes ahead with this?
Part by part. I mean, I'm not
Goes
going to excise everything all together. It would be in layers
going one
with
after
thin osteotomes.
Because
For
if
me,
you go
this
with
is
this
not
idea
a
of
true
excising the
atrophic
sclerotic bone,
non-union. So I'll
it
do
might
as
end up-
much as
it
is
might end
needed
up
to
with a
correct.
big loss,
Yes.
bone loss.
Sorry, he is asking something.
I am not all that concerned about a big loss as long as I have a good vascular bone. Loss, I think, an inch of loss
This
is not a
case I have
problem.
brought mainly for Agashya because again and again and again and again we have been discussing this.
So I
Sorry,
think-
sorry, John.
So I think I'll do as much as is necessary to correct the deformity. So because it is throwing bone at the back, so it's not dead bone. Okay, so I would correct the deformity and get, again, probably a nail into it. If I'm worried about any instability, I might add a small plate.
Anything? Anybody wants to add up anything? Value addition is.
Sir, the sclerosis is he's walking on that leg.
Sorry.
The sclerosis because he's walking on that leg. So it is a stress which is giving that sclerosis. It's attempt to heal.
Attempt to, sorry?
Heal.
Heal, yeah, sorry. Yes, Chetan, you want to add something?
So all sclerotic bone is not dead. Only the edges need to be freshened, and a slot needs to be, the triangle needs to be removed as much as to correct
So
the deformity.
basically, as these people have said,
Yeah.
the bone will be cut to only correct the angulation.
Absolutely.
After a fibular osteotomy.
Correct.
You want to say something?
Obviously, we start layer by layer, shingling first. So when you are shingling, you get an idea whether it is sclerosed or not. Then you open the medullary canal with the reamers. Then also you get an idea whether it is bleeding or not. And then last, the punctate bleeding, as Dr. Agashe has said.
Medullary cavity, once you start opening and you start opening the normal medullary cavity, it will bleed, no? So you,
At the non-union site.
that will never bleed, no?
Now, when you open it, the endosteum, like when you clear the endosteal membrane, the fibrous tissue, you will get to see the bleeding from inside as well. Like when we do shingling on the outer side, similarly, you will see that when you are reaming the medullary canal.
Anybody wants to add up anything before I go ahead?
Sangeet, excising the sclerotic bone, to look for the punctate bleeding, you will have to excise so much that it will end up with a big bone loss.
What I mean is that alone should not be considered. You have to see how are the soft tissues over that, the periosteum over that, and what is inside, and then take a last decision to excise a limited amount of bone.
Okay, here we go. Nothing excised except to correct. Fibular osteotomy, obviously a small gap of fibula had to be created higher up. Nail with the polar screws, axis, got it. That bone graft, I have put it on the side.
That additional bone graft or local?
Local.
Local.
It is local.
There are many roads coming to Powai.
This was brought for you. Still you can see the sclerosis around. And now, the whole thing is revascularized.
Sir, as I said, as we have always been saying, I have a different point of view. I know.
Here it is, again see, the deformity corrected.
One thing which I would like to highlight out here is the use of polar screws is very important if you are using an isolated implant. It's a very distal fracture which has remained in varus for a very, very long time. And until and unless you would have put these polar screws which has added the stability, many a times this alone, a nail may not have sufficed to get you this.
I think honestly, I couldn't really get the nail in the center. And you can see the skin, so I was hesitant to put in a plate along with it. And that's the reason, since I could handle with the polar screw, I just stopped there.
But if people do not put in a polar screw, this might again start loosening in the lower part and again toggle.
It doesn't become stable enough. Yes.
So, reaming this, could you ream from the top? Or
No.
also
The
ream
reaming
from the
here, it has to be done from the fracture site. There is no way you can ream it from the top. Because from the fracture site, it's a standard, the drill, the bigger drill, the hand drill, and then the whole thing goes further. Sorry, Sangeet, you're saying something?
There is already a polar screw I've used.
2 polar screws.
You mean one more anteriorly? Because the nail has, no.
No,
From the
he is appreciating that the polar screw was necessary. It has done 2 things. One, it has reduced the fracture properly to get the nail in the center, and it has also given the stability of the nail so that it doesn't wobble. So
And
you want to add up something.
Yeah, also it has not allowed the nail to drift laterally.
Yeah, that's right. Yes, Mukhi, you want to say something for a second?
I may be little analytical.
Again, to just tell me orthopedics.
You are in Varas still.
Thank you very much. Thank you.
Tell us
Here it
something.
is. Thank you very much. Here it is. Again, a virus. Sclerotic. Correct, not correct, do what?
Okay. Now this time I can see a decent bone on the lateral side. So that means I am on a reasonably good wicket. I will not excise the entire thing. This is very, very likely to be an initial stress fracture. Was it a stress fracture?
I don't know.
going
This is
into-
how I inherited.
Okay.
I don't know. I think I was told that it's the injury malunion.
Okay. So
Now he has to change. He has to change after that.
I don't
In
think
the next meeting, we won't have to be arguing so vehemently now.
Okay, again, the fibula excision, and I would definitely open the fracture site.
Open किधर है या तो heal हो गया?
Good old fracture site. Open means do an osteotomy. Use a laminar spreader and open that, the osteotomy, and then try and put part of that fibula initially so that I get maintain that correction at the fracture, at the osteotomy site, and then put tricortical structural grafts and add a plate.
Anything extra?
Yeah, so I may not do a fibula osteotomy here because it's an opening wedge and very often it will correct without having to do a fibula osteotomy. If you do need to do it, yes, you would do it, yeah.
Any addition?
Do a fibula osteotomy.
Patient has a hyperextension. We need a lateral view.
नहीं है दोस्त, बहुत साल हो गए, बहुत साल हो गए. This is 2 years. My observation was if it is sclerotic like this, probably it will need a extra bone graft. You cannot just remain without the bone graft. So autograft was put in here in order to do whatever it is. So that's why.
Did a lateral closing wedge, not
Yeah,
a medial.
yeah.
Lateral closing.
You can see that it is a lateral closing wedge which
So
is
if
fibula
you're doing a
osteotomy.
lateral closing wedge, you have to do a fibula osteotomy.
Yeah,
They have no choice.
Sorry, you want to add up something, Naveen? Thank you.
The osteotomy was done at a higher level than the exact level of hypertrophic non.
Sorry.
Osteotomy was done at a higher level than the area of malunion.
No, but I think I did the osteotomy at the core. Because I already, all the things have been drawn there and that is the level I did the osteotomy. Okay. Here is the fracture which is not in varus. Yeah, now it has become in varus. And this is the lymph which she has got. I've been talking about in the meeting that we only show the fracture, but we don't show the limp. Once there is a limp, abductor limp like this, the walking can, this is the one which I have seen operated by XYZ. All what she was, the problem is I can walk about, but I can hardly go for a longer distance. This is what we expect. Now, obviously, such a bad fracture which was there, could it have been improved upon?
So I think there was, even in the first thing, a bit of varus because the bolt is a bit high. Spiral blade is a little high. So if it is fully into valgus, then probably you'll be in the center rather than on the superior side of it. because your entry is more or less okay.
Yes, Chetan, you want to add something?
Sir, the entry is lateral.
Lateral.
So it has already started drifting in varus. What could have been done is to lock that, because this is a TFNA. So you lock without allowing any collapse. Now, if you see it has collapsed, the reduction also is not positive. So it has allowed a varus collapse. Intraoperatively, you could have taken some steps to prevent that by completely locking it, not allowing any collapse.
And this sort of a fracture, would you feel that you will be able to avoid a varus all the time?
So attempt has been, they have reconstructed the lateral wall. In that setting, when you tighten that wire loop, you tend to get a negative reduction. So you have to actually look at that when you're tightening and see that the beak is outside and not going
inside.
So for that wire to really work as a tension band, it has to include the trochanter. Then only it will work as a tension
It is
band.
only the outside.
Yeah.
It in relation with the locking screw, distal locking screw. It is a dynamic screw. Now in the recent SICOT journal, there is a study between, in a short fractures like this, the locking, static and dynamic. So it is said that if you do a dynamic locking, there is a chance that the fracture will go higher up and varus collapse will happen. This is in the recent.
If you do the dynamic locking, then?
Yes, in this such type of a fracture. So dynamization only in the subtrochanteric, not in the intertrochanteric. It should be a stable fixation and locking should be a static locking.
Anyway, I go ahead. This is with the elevation also, the limp is not gone. Could that be corrected by now doing a varus or valgus osteotomy? It would be.
John,
I would recommend it. It would be up to her to have it or not.
John,
Sorry?
is this going to be only coxa vera or any injury to the gluteal nerve?
So that is something that you
Which
need
we are
to,
coming further.
Yeah.
Again, the same things, badly done, marked deformity, marked virus. Again, long-term walking is affected. So we pass by. This was the one which was a minimal virus is there. And this is a high society lady, obviously complaining of, I can't go to my kitty party. Would you have been able to avoid this? This is how I got the X-ray. There is no pre-op X-ray. There is hardly much virus. There is some.
it's almost a piriformis entry. So I think you need to look at that. It's not designed for a piriformis entry, this nail.
Come again now.
So this
Ek
nail
second. Let me take John on that.
Yeah.
Bombay teaching becomes that all intertrochanteric fractures and subtrochanteric fractures, you must have a piriform point of entry.
So I don't.
Ek minute. That's why I've been taking you, and I'm not. Genuinely, I want to learn from you. We all want to learn from you because having your wide experience, do you feel that in an intertrochanteric and a subtrochanteric fracture, piriform entry is not indicated?
I strongly feel that you do not need to do a piriformis fossa entry. You make it medial to the tip of the greater trochanter. So it's not into the piriformis fossa. Okay, so, and then you have to keep it there during your reaming. That is the more difficult
Do
part.
not break the bridge which is there between the GT and the piriformis.
Yeah.
Because that bridge, as I think Negi has been talking about, he puts a chisel and he takes it out.
No, you can break that bridge because it tends
But
to go.
if you break the bridge, then the whole thing will go on to the
It
medial
doesn't.
side.
It always tends to go lateral. So you
if
have to prevent it going lateral.
If you go anything medial to the greater trochanter,
Because the hard bone is
then with about 17 millimeters or 18 millimeters of that reaming, it invariably will be the piriform fossa. So you are essentially taking a piriformis entry only.
No,
As a matter of fact, piriform entry has been recommended to you. Have it on the tip of the thing and you ream medially so that you will break that with that good, powerful reamer.
So I think the piriformis entry is slightly different because the line of entry is different. Okay, so here you're, yeah, so here you're actually slightly anterior. And if you can keep it there through your reaming process, it will not go into the piriformis fossa, not dead center in the piriformis fossa.
Sir, here in this case, probably it is the shortening of the neck. Again, a negative reduction and a neck shortening, which is giving rise to that lurch. Though it looks that it is not in varus, so it has collapsed.
Has collapsed.
Yes, Naveen, you have done quite a lot of work on IT.
All the cases, there is a varus. And the reason for the varus, there was nothing to support laterally of the lateral tension band.
So if there was a lateral plate, it would not have happened.
It would have not happened, probably. Because
Amit-
if you
Amit
look
is
at
here?
The lateral tension band.
Amit is here.
Here,
Amit talks about every fracture intertrochanteric will go into a collapse, not varus necessarily, the collapse, which all of us have observed off and on.
Sir, the answer lies in lateral view. Unless you get a good anterior bone to bone contact, anterior medial, it is very, very likely to collapse. And that is prevented by the nail. Excessive is prevented by nail. But the anterior cortex is pretty thick, medially as well as laterally, and it prevents collapse.
So do I understand that you may not get a varus at all in an IT fracture which is comminuted?
Yes. If you are able to get a good anterior to anterior reduction, then you are very, very less likely to get a varus collapse.
Yes,
Rather, I would say no.
Even that is not enough. We need a positive anterior reduction and a positive medial reduction with no gap on the table. Then only your fracture
Then
is
there
stable.
will be no collapse at all.
No, unlikely to be collapse.
So the positive,
Unlikely.
This is what we are talking about.
So you cannot say that there will never be collapse. There can be some collapse and
Controlled.
shortening of the neck, but at least if you
Varus
have
will
it may prevent it.
So the so-called positive reduction that we all talk about is nothing other than the Wayne County reduction, which was talked about 50 years ago. It's exactly the same thing where you have the bit of the part of the calcar which is against the femur. And so it's the same thing as the Wayne County reduction, which was described 50 years ago. And everyone talks about positive reduction today.
So the
Just a
point
minute. Just a minute. You said something, no? Whatever you wanted to say. Yeah, you said that.
Part of that, which you described, that the medial thick cortical bone.
You think it's a lateral instability.
Half of the diameter of the nail on the medial side should get the entry right. Otherwise, it will cause intraoperative varus itself.
Yes, Govind Sahib, senior most person of the group.
To prevent varus,
Youngest.
we at the end of surgery we put a Powell screw. The Powell screw goes crosses, and therefore it prevents the collapse.
In an intertrochanteric also, in an intertrochanteric also you think?
Required. So cross screws prevents the to some extent. Perhaps.
Okay.
Sir,
Time is running
one
out.
minute, 1 minute. I would definitely like to give a message that we must spend more time in watching the lateral view on C-arm. That is generally not done.
No, your point is done.
That's all
Point
I'm
is
trying to
taken.
say.
Okay, we proceed further. No virus. Now what? Young girl, no virus.
Touching on both sides. He's probably got some kind of dystrophy or something.
Sorry?
He's lurching on both sides.
No. She was perfectly normal before the fracture.
So this is where I think EMG may help. Will help.
EMG study says left supragluteal nerve injury. Superior gluteal nerve injury is a part of the injury which occurs. Whole nerve doesn't get things. It has been, this is what it is. And here, all these are the ones. You can see these are the nerves which are passing by. When we pass by the guide wire once, twice, thrice, some of these nerves get injured. Do we have a control on that?
John,
The piriform, John, I think I'll come back to you now. So the intramedullary nailing through the piriform fossa results in some cases in loss of abduction strength and persistent pain. Nail insertion at the tip of the greater trochanter is favorable. So now we come back to the whole cycle again. That if you put the tip of the trochanter without doing anything to the abductors, then you have a positive reduction and you have a good anterior reduction. Would that avoid valgus, a virus?
So I think one of the issues is before you put in your lag screw into the joint, and when you put in your nail, before you put that, add your traction. Very often that corrects the slight varus that you have, and then your screw will go in the right place instead of going too high. And the moment you're in center, you have much less chance of it collapsing into varus. I think that is one of the issues which people forget.
You want to add up something? Yes, Vivek.
Just reiterate few things which Dr. Vikas and Dr. John have said. Anteromedial contact and the reduction is paramount. We are not giving correct emphasis on that. Lateral view reduction
My
is also
question
there.
now, last question passed on was anterior good reduction, lateral have a positive reduction. Now point of entry in GT only and no piriformis, would you get varus? That is my question. So we agree about what you are talking about?
Yes, you can still get varus because of the bone quality which you cannot, we can only control things which are in our.
So I think you have to go, your entry point has to be governed by the nail design. You go slightly medial.
All these nail designs which are there, they are all for the design for the point of entry from GT.
But you go.
We go in the piriform fossa.
No, you don't go in the piriform fossa. You go to the medial tip of the trochanter.
John, medial tip of the trochanter will always end up in the piriform fossa.
Doesn't, sir. I mean,
Anyway, we leave that. We have already discussed.
The only time I can feel the piriformis fossa when I'm doing a nailing for subtroch or a femur nailing. Or intertrochanteric, I don't know how John palpates the piriformis fossa because your fracture is through it. It's only medial, only the trochanter if it is intact, what we can palpate.
Anyway,
and imagine where is a piriformis fossa.
So at the moment we are not certain
Sir, your
how
case,
to avoid a, sorry, yes.
Your case, if you can go back, she has a wedge effect. The cause why she is limping is...
This is not my case. I inherited this.
Yeah.
Not inherited. Somebody has sent me.
You can
I
see
think,
there is a wedge
I
effect
think
superiorly. And if you see what has happened at the entry point, again, it is not a medial entry point, it is a trochanteric entry point. And probably it is a rotation of the proximal fragment, which is giving an appearance that some part of the trochanter is still attached and it is posterior.
But it is not in varus.
So what happens here is your reaming tends to go more
laterally
rather than medial because the medial bone is hard. And especially when you start many of these reamers are side cutting reamers. They tend to go more lateral rather than medial because the medial bone is hard.
Sangeet,
This case is, sorry.
the nail is to the fracture side, point of entry, yeah.
Part of the trochanter is still medial.
Yeah.
So
it's not in the piriformis. It is from the tip of the trochanter is been tried.
So entry should have been more medial.
In the piriformis.
So here in this case, sir.
Then what do you recommend now? For IT fracture, piriformis fossa or tip of the trochanter?
Anyway, the whole case was this. You want to say something?
Here the proximal fragment is not in varus, but proximal fragment is externally rotated. You see the
Is that the reason for the deformity?
Yes, that could be.
No. The EMG has shown whatever we have shown. Anyway, this was put in for
Can I make a comment?
potential neural damage during the piriform point of entry.
Can I make a comment?
Yes, follow Rajat.
The X-ray which you have shown, the nail has gone through the fracture site. For proximal femoral fractures, you have to go in piriformis fossa. There's no question about it. You have to go in piriformis fossa and you will not get varus. You go through the fracture site, you're going to get varus. You go medial to the GT is for the shaft fracture. Piriformis fossa is for every proximal femoral fracture. Whether it's subtroch, whether it's intertroch, you have to go in piriformis fossa.
Thank you, Rajat.
One
I-
minute.
before
Have
we
they
go
suggested how to prevent injury to that in that paper? Have they
I think there is no, because it is a hit and a miss situation. Because if you go through the muscle, whether you put in, as he is mentioning, you could put once and put in a tube, but during that time you will injure that. It is a hit and a miss thing. Okay, we proceed further. Today the red hot topic, Philos, multilock. शैलेश है क्या इधर? है शैलेश? इधर आ जा, आगे आ जा, बोलो क्या करेगा इधर? सीटी
Do what is best in your hands. There is nothing like.
नहीं, in your hand what is best?
नहीं, कोई नहीं चक्कर sir. Do best in your hands, whatever is the best. In my hands, Philos is the best, so I will do a
Shailesh.
Philos. If Shailesh is there, in his hands, he will do a multi-lock. We know that. Our aim is not to say what we or what. Our aim ultimately is a good outcome for the patient in whichever way we can. Let's not get into. There are specific areas and points when we can do.
I have
a
presented
plate.
it. I have presented it. Yes, anyway, John.
For me, this is a plate. So,
Akashe.
Plate, Philos, and one thing, this doesn't have any sclerosis. Still, I'll do.
how old is this patient?
Age, I'll tell you. She is a doctor, not yet joined as a consultant, so around 30.
So young. So,
Definitely.
Around 30.
Definitely plate.
Anybody wants to add up anything? Sangeet, if you know, you don't add up.
No, I don't.
This.
So,
Come, Shailesh, on the mic.
so we have the lesser tuberosity, which is medial to the bicipital groove. Then we have two fragments of greater tuberosity, which is one is more posterior, and then we have an anatomical neck. So we have to suture the subscap and the teres major and minor as well.
Yes, last few minutes.
So in this particular fracture scenario, I don't think there will be much difference between a nail or a plate. Mostly extra-articular, but some fracture lines going into the GT. But like rightly pointed out, suturing of the tuberosities and both the implants should work well.
Sorry. You're doing quite a lot of shoulders, I understand.
So for me, this is going to be a plate. I would keep bone graft standby as well. She's a young lady.
Okay, we agree. Reduction X-ray. Small thing here. K-wires, J-wire. Doctor, she couldn't get a new X-ray only because she is pregnant. And this is herself. I got the X-ray. You cannot make it out which shoulder is affected.
Plan does not matter.
Any tips about passing those bent wires? How will you do that?
Is he here? Chandak is here. This is Dr. Chandak. Aja. Dr. Chandak has familiarized this with there's a J wire. And all of us have been doing it. Please.
So the entry point is very specific. As you pass your hand below the deltoid, at the insertion of deltoid, you have to drill two very oblique holes. Oblique holes as oblique and as parallel to humerus, so that you get an intramedullary J wires. And these J wires are typically, they are known J because they are terminally bent. And then you gently hammer this wire. The main advantage is, as compared to percutaneous pinning, they do not back out. Since they have multi-point fixation inside, they do not back out. Healing is very good, and they throw very early callus, and then there is usually no virus. These are the main advantages.
But you have to be able to get closed reduction for this.
That is most important. You can't do it in a fracture dislocation.
And you leave them out of the skin or you bury them or what?
They are cut, bury, bend. So they are cut, bend to a 90 degree, and then cut. So they are just lying beneath the skin, and usually there are 3 J nails, and at the end of healing, you can just remove them.
So you do that in the OPD or in OT?
No, no, OT. It's a complete OPD, complete OT procedure.
If ever I was rude, please pardon.
If you're not rude, if you're not rude, we'll be worried.
Thank you. Thank you.
I'll be talking on what's new in fracture neck of femur. I'm not talking of my new implants, but I'm taking a few of the current trends from the ocean of articles.
Come here.
I have selected a few articles which are
Same.
useful, practical, and you can use it from tomorrow.
Analyst.
There is a 26 level 1 trauma centers in USA. They have formed young adult fracture neck femur study group, and I will show you some of the cases. Their articles. This is a medial buttress plate on the femoral neck. It's a very interesting technique. Anything? They have studied 565 cases in different ways, treated with multiple cancellous screws, MCS. Only 55% have, failed in 55% of the cases. MCS plus buttress plate, 46% of the cases. And DHS only 36% of the cases. DHS plus derotation screw plus buttress plate on the neck, 11% of the cases. Buttress plate resists shearing force and prevents varus collapse. Another study, multicentric buttress plate on the neck, 478 cases. 427 were treated with multiple cancellous screws or DHS, failed in 49% of the cases. When buttress plate was added in 51 cases, failed only 29% of the cases. However, it depends upon the type of plate and the placement of plate. 2.7 millimeter plate were used in 26 cases, failed in 42% of the cases, whereas if it is 3.5 millimeter plate is used, 25 cases failed in only 5% of the cases. So the message, the placement of place is important. Now, anteriorly placed plate, see the anteriorly placed plate, 75% of the cases have failed. When it is placed anteromedially, failed in 33% of the cases. In direct medial plate, failed in only 9% of the cases. So, the message is use 3.5 millimeter plate if you are going to use a plate on the neck. You use 3.5 millimeter plate and place it medially.
However, the concern is that all cases open reduction and there is a chance of infection, especially in civil hospitals and peripheral hospitals. And the inferior retinacular artery, which is an important artery, is just posterior to the plate. These are the two concerns. Another multicentric study in USA, 642 cases treated by DHS and 3 cancer screws, 50% of the cases had complications and 45% needed reoperation. However, complications increase greatly by decades. This is August 2024. Study of 565 cases treated by DHS 260 cases, MCS by 305 cases. In the third decade, that is less than 30 years of age, 36% failed. Fourth decade, 40%. Fifth decade, 48%. Sixth decade, 50 to 60 years of age, 57% failure question. Whatever implant you use, age is an important factor. In our institute, our protocol is we fix below the age of 50. 50 to 60 is a gray zone. That is depends upon the osteoporosis and patient has delayed and presentation and so on. After the age of 60, arthroplasty. Why DHS and MCS fail? Poor reduction, shearing force may be the main cause, implant, choice of implant and placement, osteoporosis, implant holding capacity is much reduced, and compromised vascularity. These are the 5 causes. How fracture neck femur is different from all other fractures in the body. It is a unique fracture because the only fracture which experiences greatest shearing force. Physiological healing problems are there, precarious blood supply. Why shearing force at the fracture neck femur is more? Because femur is a cantilever and fracture neck femur is the only fracture in the body which is subjected to tremendous shearing forces. 2 long levers, body weight and the leg which represents the ground reaction. Every fracture neck femur has an element of shearing force. Body weight, shearing force depends on the Powell's angle. In this case, Powell's type 1, 0 to 30 degrees of Powell's angle, least shearing force and more compressive force. This is Powell type 2, 30 to 50 degrees angle, more shearing force. This is Powell type 3, more than 50 degrees angle, maximum shearing force and less compressive force. Shearing force is probably the most important cause of non-union and avian. Evidence, robust evidence is vascular valgus anatomy for non-union. See this young patient, a medical representative, had 1-year-old non-union of fracture neck femur with lot of fibrous tissue in between absorption, gaps, sclerosis. Still, the non-union united because of valgus osteotomy. How? Because the shearing forces were converted into compressive forces. Compression increases the ratio of compressive forces versus shearing forces. This appears to be important to me. See this figure 1 is a transverse fracture, 100% compressive forces and 0% shearing forces, Powell type 1. In figure 2, there is a vertical fracture, 100% shearing forces, zero compressive forces, Powell type 3. And figure 3 is oblique fracture, combination of compressive and shearing forces, Powell type 2. This can be represented in a graphically. When the Powell's angle is 16 degrees, there is 100% compressive forces and 0% shearing forces. When the angle is 106 degrees, there is 0% compressive forces and 100% shearing forces. If compressive forces are more than shearing forces, fracture unite. This is my opinion. If the shearing forces are more than compressive forces, non-union occurs. How to reduce shearing force in fracture neck femur? Is a valgus reduction or valgus osteotomy. As I told you, it may be 3.5 medial buttress plate. If you put a screw in the head, it becomes a plate, and this acts as a compressive method. Screw in the head becomes a protection plate. This is a new bionial construct. This is a new implant. And this is a triangle corset. And locking DHS is my implant. And this is a Powell screw, which is very, very important. And Shailesh Pai has published this in the injury. And the second problem is physiological problems, healing problems, MEDA. Cambium layer of the periosteum supplies pluripotent cells which forms callus, and secondary healing occurs in a shaft femur. But in the neck femur, it's a different ballgame. Fracture neck femur is intrasynovial. Periosteum has no cambium layer. The hematoma is continuously washed by the synovial fluid, and therefore secondary healing is not promoted. It is not possible. Direct healing by osteonal remodeling is possible, needs anatomical reduction. This is proved by MEDA. Third problem is compromised vascularity. Neoleiton vascularity is normally there is abundant vascularity of the head because of the dome of anastomosis of the epiphyseal arteries. Inferior retinacular artery is protected in vertebrate ligament, and the inferior retinacular artery is 1.6 millimeters away from the cortex. All other retinacular arteries are adherent to the bone, and inferior retinaculum revascularizes the head after fractionectomy. There are several articles on this. Sliding of implant is very important but controversial. Allow sliding, it is associated with complications. Controlled sliding indicated in osteoporotic bones, FNS, and controlled sliding DHS. No sliding, rigid fixation, absolute stability, good bone strong, triangle construct, and locking DHS. Valgus osteotomy. Smaller correction 20 to 30 degrees is excellent rate of union while preserving the more native femoral anatomy for future arthroplasty. This is by Jan in all our difficult cases. The final answer is primary valgus osteotomy. So I call this panacea of fracture neck femur. Now I'll show you a case. This is a case 40-year-old, 2 weeks fracture neck femur. Note the large pieces of fragments outside the head of the femur, and there is comminution. Till the fracture was treated by primary valgus, and the pieces are getting resolved. no AVN, good function, 3 years after the fracture. Last June he came to us. There's another case, Depusintis FNS, good implant but mixed results. Filippo method is a very biomechanically a sound method. I'll show you one more last case and a case of triangle construct. This patient was treated by my friend. He is 35 years old and elsewhere treated. He called me and said, can you send? Finished. Last. And this was treated by him, and this is united nicely. We have published this, and in conclusion, still no standard implant for fracture neck femur. Trauma Society of India needs to form an Indian femoral neck study group because we have huge clinical material, but I am sure an Indian scientific multicentric study will find the final answer to this most difficult problem. All other fractures to some extent have been solved, but except femoral neck femur. Thank you very much.
Thank you. Any questions to Govind?
Shailesh.
Shailesh and Dr. Munshi, can you come on the stage, please? Samarth Mittal.
Ashok.
Ashok Gavaskar is there?
Sir, one
Asim.
question to you. Do you, at this point of time, recommend a primary osteotomy in Powell's 3? Fresh fracture.
I do recommend Powell's osteotomy for primary session, especially in Powell's type 3.
So you would always do it in a vertical fracture?
Yeah, vertical fractures. And we decide
Vivek,
on
come.
what is the Powell's angle, what is the dislocation.
You are a panelist.
And Gardens index is also.
Okay.
He has a talk.
Sir,
Samarth Mittal.
sir,
Sorry.
sir, here I am.
Last question. Yes.
Sir, you added DHS. The whole idea is to collapse the fracture. Then on top of it, yeah, DHS dynamic hip screw is to collapse the fracture. Neck. DHS dynamic hip screw is used so that the fracture will slightly collapse and unite. On top of it, you are using, yeah, and on top of it, you are adding 2 fully threaded screw and a medial buttress fluid, which you will not allow to compress. How does it compromise?
See, the collapse is a big problem in fracture neck femur and trochanter. So to prevent that, we must have a anatomical perfect reduction. That is very important. Number 2, you put one screw in the derotation screw first. And after the derotation screw, and when you put the DHS, there is a great chance that the forces will redislocate or there is a change in the reduction. So we have to put either we put 2 screws, anterior and posterior, or you can put 1 or 2 pins above and hold it so that the reduction is not deformed. And when you use this, the collapse will not occur. And then we put a Powell screw at the end of surgery. So all these things will prevent the collapse.
Thank you,
Thank
Dr.
you, Govind.
Kulkarni.
Thank you, Govind.
Asim, please go
Yes,
ahead with
sir.
your talk.
My patient is around 48. He is 120 kg. Initially, he was treated in a metro city. They tried to take him for surgery and then refused, did not proceed with the surgery and said, "तुम ऐसे ही अच्छा हो जाएगा." So around 3.5 weeks down the line, he is with me. So this is the X-ray. Vivek sir, we always get a CT scan for even simple neck humerus, or it's sometimes done, sometimes not done. Neck humerus.
Yes, Parag.
Yeah.
You want to open anything?
Sir, he's a young chap. You want to really try and save this head. So I agree in principle, we would try to relocate it and then fix it. CT scan, I would do this. It's a 3-week-old, he said, no? So I would do a pre-op 3D CT.
Here is the CT. This is 2D. This is my 3D. This is the video.
Okay, Ashok, you want to commit anything?
So I thought this was a video session. So cases. Okay.
Good morning.
Okay. So yeah, I think a complex 3 or 4 part. I'm not very sure about it here. No 8 components. So what's the age, sir?
48.
Yeah, I'll fix it. I don't think even if this was 60 or 70, I think it's amenable.
What will be your cutoff point for start thinking about?
Not just age. I think I think this fracture personality is fixable unless it is grossly osteoporotic.
Relieve surgery.
No, what is your cutoff, Parag and Ashok? When do you start thinking that I will not fix it because of the age?
No, I think like probably.
If it's 70, there is no debate.
Yeah,
so what is the gray area?
Yeah, probably beyond 50. Like if it's too
If
bad,
I can suggest, Asim and all of you, this is a video session, so a small discussion and you'll have to carry on. If there is time permitting, we'll discuss further.
Fine.
Because otherwise you won't get the time to complete your thing.
This is my setup, semi-beach chair position. I prefer to get this C-arm from the opposite side. That's more surgeon friendly for me. And semi-beach chair position, I check X-ray visibility even before I start my case. And these are the 2 approaches. Any preference for any approach in this particular patient?
I can do this through a split deltoid, anterolateral split, but a delta pectoral is brilliant as well. I can't do a fracture dislocation or edge split pattern through a anterolateral deltoid split. So apart from that, any other pattern, depending on your experience, you can do it through a deltoid split.
You can see that I have marked both the incisions, and here I was about to, I started actually infiltrating the deltopectoral incision, and then my friend suggested that this particular patient, at least with his 120 kg weight and this type of X-ray and all those things, you will never be able to reach the head fragment which is facing laterally. You should do it by split deltoid or anterolateral because you are doing other cases also. So this is most suitable for anterolateral approach. So last minute we changed to anterolateral. So this is the theory part of it that now crosses at 5 to 7 centimeter from the acromion, but not always. In at least 15% of the cases, it can be as close as 3 centimeters. So that's not sacrosanct. Repeatedly check 5 centimeter after taking the incision. And here is my refe just after this, opening the skin and the subcutaneous tissue. You can see this plane, which is fairly avascular. We are opening that plane, and now head is looking at you with this approach. In a very hefty patient going through deltopectoral, I don't know how I would have reached here. Sometimes in those situations.
Sir, if I make a comment.
Yeah.
If it's valgus impacted, I would agree with your point. The deltoid split is like, here it's like completely displaced. So I think if you are looking at the more complex fracture pattern, then it should fall probably to the delta pec than the deltoid split.
You can go through deltopectoral the way you go for a posterior greater tuberosity anywhere, any place.
Sometimes in those situations,
Asim, you yourself said that you changed at the last moment.
Yeah.
That means you were more comfortable with the deltopectoral.
That is what I want to
Let's
make
not
the
get
point, that I feel that we should have an open mind and you should be comfortable with both the approaches.
That is the way to present rather than saying
yes.
deltoid is the
And in the past, when I wasn't doing anterolateral that often, I went by deltopectoral, but I had to make a separate window for catching the GT fragment.
My question to you is that
2 windows.
Is 5 centimeter statement and the limit valid for a very hefty patient as well, which is 120 kilos and a huge deltoid and everything? 5 centimeter from acromion is valid there also? That's what.
Probably no. It's sometimes even less, actually, less. So,
Because when he was there about 10-year-old, he wasn't so fat. 20-year also is the same thing. It is going to be 2 inches.
Because your incision as such, if you're giving a skin, you will have to be.
It's
You can
fairly
always extend the incision.
You start looking for the axillary now in this dissection here. This is the only transverse tough structure. You don't really isolate the nerve. You just feel for the cord-like structure along with the soft tissue and the vessel which is seen there. But this is the only thing which is going transversely across. What I do is that I expose the first subdeltoid bursa here about an inch or so area, and then I go down way below 7 centimeters in the distal part on the shaft. I don't dissect the nerve, have enough soft tissue around it, and as shown in every single book, there is a loop. I never put a loop around the CPN or this axillary nerve. I just bypass it. While expanding the approach in the distal part, distally, the commonest mistake in the early cases was that I tended to go posteriorly to the humeral shaft. So now I just take a K-wire, feel the anterior cortex of the humerus in the distal part here, posterior cortex, and expose in between those 2 points. So I don't make an error.
Just a comment.
Yeah.
I believe your skin incision is probably a little bit too lateral.
Yeah.
I think like it can be a lot more anterior actually. So we tend to we do this common mistake, like tend to err more on the posterior side. It's actually much more.
Commonest error is going posterior. So try to aim your skin incision and dissection towards the lateral epicondyle. That's the point to learn. And then I inserted 2 strategically placed K-wires in the humeral head, which will allow me to de-rotate it and send it back to its socket. That was the idea of using these 2.5 millimeter K-wires. Don't use 2 or 1.8. They will bend. And then these were used as joystick. And this Verbrugge is holding that shaft. It was all proximally migrated in this area lying against the glenoid. So this is pulling it down. Somebody is giving traction also. And the K-wires, they are allowing me to maneuver the head and get some semblance of reduction, as you can see here. It's extremely difficult in a 4.5, 5 hour surgery to catch that exact moment when it happens. It just zup karke, it improves. So there is a lot of struggle there. You reduce the shaft on the head with a blunt periosteum. Every trick in the book you will have to use. This is a blunt periosteum which is going there, and bhai ye video chalega. So this was extremely useful to stretch the soft tissues after so many days and allowed me to gain length and reduce head to shaft. You can see that we have restored the Shenton's line. Then we started looking after supraspinatus and infra and teres minor, and we did a double suturing for each one. There were ethibond sutures as a color code and a fiber wire suture. So there were 2 sutures in the supra, 2 similar sutures in the infra, and 2 in the teres minor. So 6 for these group of muscles. Then you reduce the shaft to head and fix it with 2 K-wires. This shaft to head reduction and the GT to 1 wire going from the GT into the head and another in the metaphysis down below. And these wires are placed such that they will not hamper my plate positioning in the right position. And then you check in at least 4 or 5 views without really changing the position of the arm. You rotate the C-arm. Now, another problem, my shaft and head are reduced. GT can come back in position, but I can't push back the reduced head in the glenoid because LT is lying against the anterior inferior glenoid here and it's blocking the reduction. So we hunted for the subscapularis with a pull-out suture. First suture we used as a device to bring out the LT piece and then took proper subscap sutures. Again, double sutures, ethibond and the fiber wire. So everything was nicely tied there at osteotendinous junction. And then these are the steps somewhere in between, before reduction and after reduction. So once we pulled out the LT and the subscape which was interfering with the reduction, we could get the head into the socket here. This is before reduction on your here. This is after reduction. Then we checked that our LT is fitting into that cavity there. So we had nice reduction of the LT and the GT congruous along with the head to shaft reduction. So things looked okay. Then we again opened this window here. We allowed it to go away, and through that window, almost an entire femoral head of 10 grams was gently packed into that void which was there. And then we had ample number of sutures, almost 8 in total. So ethibond sutures I tied on the bone before putting the plate, and the fiber wire sutures I used pass through the plate. And I have not, I pass my sutures before inserting the plate. And then you pass the plate beneath the axillary nerve along with the vessel and lot of muscle tissue there. You already made a tunnel with a blunt periosteum. And somebody is abducting. There is a distance of almost 13 millimeter you can find out between the bone and the axillary nerve. If you abduct and you are little careful, then that gap is enough to shove in the plate through that window. So it's slided in. You have to make sure that your height of the plate, top of the plate is 8 millimeter below the top of the articular surface. And I routinely pass this thin K wire as a guide there. So if my calcar screw is going at the right place and my plate is 8 millimeter from the top of the head, I think my overall position and the reduction is good. And the Shenton's line is slightly creepy here. It's not too bad, but it's not perfect. So let's see what we can do about that. So check the alignment, especially on this lateral view, sagittal view. It may look pretty good on this and your plate may be slanting like this. So don't make that mistake. Check it on the lateral also. You can still correct everything. Nothing is lost. You can change the position. And then I use this cortical reduction screw. This is placed under image intensifier, tightened under image intensifier control. You could see that small breach in the Shenton's line there, and I tightened it enough just to restore that line. Don't over reduce. So this is my final suture construct, and these are the pictures. 1 month, there is a sublux. Head is inferiorly sublux, but I think that's because of the deltoid inefficiency. 2 months, he was doing pretty well. And that was, he stays far away, so we had to find out the appropriate physio for him there. And this is his 10-month X-ray. This is my range.
Good. The comments from the experts. Samarth, you have not opened your mouth.
I would still say that deltopectoral approach would have been better. He was struggling with the medial piece of the LT. A. B, when you have comminuted fracture patterns, and God forbid if they go into AVN, then to do a shoulder replacement, again, you've got to go through that. So now if this head had not healed and if it would have collapsed and if you had to do an arthroplasty, which approach you would have used?
I have taken out 2 plates because of the infection which were put after this deltopectoral. So it's possible. Patient will be referred to Parag.
Yes, Samarth.
Sir, I think the first question that you asked me was CT or not. So I think my answer would be CT in all periarticular fractures and articular fractures, whether it is fresh, whether it is 2 weeks or 3 weeks down the line. That is my first answer. Second, about the approach that you asked. I think between the 2 approaches, the approach that is the workhorse approach of the surgeon and he or she is more comfortable, I think that should be the right approach.
Approach should be the one you are familiar with and is required for that patient.
Thank you, Asim. Shailesh.
Thank you, respected moderators and panelists.
Can I ask one question, please?
In such kind of cases, proximal humerus, when there is a lot of medial combination, how do you judge the rotation of the head? Because if your sentence line is not being accurately reduced, how do you judge the rotation of the head?
Negi sir, there's a question for you. How do you judge the rotation of the head?
If your sentence line, if you have a lot of medial combination and you cannot reconstruct the sentence line, absolutely anatomical.
Medial comminution, I will seriously consider a fibular graft. And then is lot of eyeballing, seeing the reduction, what looks good.
Yes, Doc, you want to ask something?
Just a doubt regarding that approach only, sir. So it is not like the head has come out of the deltoid. So I think, so did the deltoid split make any difference in accessing the head? That is my only question.
It was looking at me after I just exposed the subdeltoid bursa. The nerve was just below that. It wasn't 5 centimeter. And the head was staring at us. That was the reason we chose. I agreed to change this approach.
One comment, the gentleman who asked the question earlier.
Please.
Thank you, sir. So I'll be showing a...
I'm sorry. I thought somebody from audience is talking.
It's just a comment to the question, the gentleman asked earlier. So when we talk of medial comminution, you're gauging the height of the head. You're not gauging the version or the rotation. Now this sometimes you have to see on table and you have to see the best match. If you really have to be scientific, you need a CT pre-op of the opposite side to see what is the anteversion and what is the retroversion. So here what you have to do is get the head onto the glenoid as the best match and pin it with a thin K-wire and then work around it. If you've got everything floating around, you have nothing to start building on. So medial comminution will give you the idea of the height and you have the parabola matching or the eclipse matching in the end. But version you have to decide on table. No.
Thank you very much. Thank you.
Unfortunately not. There are no landmarks as such for rotation of the head.
Yeah. So I'll be discussing regarding multi-lock nailing in proximal humerus, showing a video. So this was a 42-year-old gentleman who had a 4-part fracture proximal humerus. It was an isolated injury. CT we always get. If I'm going to fix it, I will have a CT to understand. So proper 4-part, as we can see and appreciate on the CT. The approach would be an anterolateral approach, the traditional anterolateral approach, which starts on the anterior border of the acromion coming down. I have marked the nerve, but we don't need to go till the nerve for a nailing in most cases. There will be enough bridge, and to answer the question, if in case he requires a revision, there is still enough bridge to go with the deltopectoral in case the patient requires an orthoplasty. So there should not be much of an issue for that, because we have done deltopectoral approaches, failures, and revised the anterolateral approach. There is enough bridge. 2 to 3 centimeters proximal to the tip of acromion, along the anterior border of the acromion, coming down about 3 to 4 centimeters is what should be good enough in most cases. So the skin is incised, subcutaneous tissue is incised and directly or on the muscles. Then what we see is a beautiful raphe between the anterior and the middle fibers of the deltoid, which was again shown by Dr. Asim. And we need to be in line with that. So if you can split that in line, even the bleeding is much lesser. So once you split it in line and separated the anterior and the middle fibers of the deltoid, you're straight off in the joint. So it's a very quick in surgical approach, as most of us know. So with this approach, we will be able to deal with almost all types of fracture proximal humerus. The next is similar to what we do with a plate. You take a ethibond or a fiber wire and take a couple of bites at the tendon bone junction and see that you have a good hold of this particular fragment with the tendon. So this will be very critical to be able to put it back to where it belongs. So in most cases, GT would have gone slightly posterior and superior. So we need to go and fetch it from there and get it under our control. So this is for the GT. Similar thing is done for the LT with subscapularis at the junction. This is a fiber wire being used. Now that's the LT being fetched. The LT usually goes inferior and slightly medial, so that can be fetched and similar stitch taken. Now both of these are under the surgeon's control. The difference between a nail and a plate starts from now on. In the sense, we saw the previous video where Dr. Asim put everything's back, put in a lot of K wires, and he told he was very meticulous in seeing to it that it doesn't come in the way of the plate. But it's, I mean, for most of less experienced surgeons like us, it's going to be very difficult because I'm pretty sure we have all gone through it where we have seen that 1 or 2 K wires will come in the way of the plate and that needs to be changed. Whereas with the nail, this needs to be under control. We don't need to put it back at this stage. What we need to concentrate on is the head and the shaft. So the head is reduced, head mostly goes into varus, so it is reduced with a joystick. We could use K wires like shown before, or we could use a periosteal elevator and reduce it. And once it is reduced onto the glenoid and we have a good neck shaft angle, we can transfix a 1 K wire very anteriorly from the head of the humerus onto the glenoid. That is the only K wire in the entire surgery that we are going to use. Now, the advantage of this particular K wire is dual. One is the neck shaft angle that we have got is maintained throughout the surgery. Number two, when you are going to use a reamer onto the head, especially if the bone stock is not that great, there is high chance that the head will spin, and that itself can cause an avascular necrosis. So to avoid any spinning of the head, you can put a transglenoid K wire very anteriorly into the head, into the glenoid. So this is again now it's chucked under the C-arm. Yeah, that's how we began with at the beginning of surgery. That's the reduction getting achieved. And that's, oh, sorry. Yeah. And that's the after reduction when you're putting in a K wire onto the glenoid. So throughout this stage, the GT and the LT have not been put back, and we are only concentrating on the head. So once we are happy with the reduction of the head onto the glenoid and a good neck shaft angle, then we proceed with identifying your entry point. The entry point is going to be 1 centimeter medial to your fracture line, wherever that is. Usually, in most cases, fracture goes through the sulcus, so we can go at the head, top of the head of the humerus, just in front of the acromion. Again, this entry point is confirmed under a C-arm. So that's the entry into the head. So we don't need to concentrate anything to the shaft. The shaft will align itself once the nail is passed. That's again the huge advantage that we have with the nail. So get a good entry point into the head at the top of the head of the humerus. Use a 10 millimeter core reamer which is being provided in the set. This is a very, very crucial reamer. We cannot use any other reamers because we can have a chance of blowout of the head. This is the core reamer which only chooses from inside. So once that is done, we have an entry in the head. If required, we can ream the shaft if there is any doubt that it's a tight canal. But in most cases, that won't be required. The short proximal humerus nails don't cross the isthmus. So we should be able to put it without reaming the shaft, but that can be done. Now that's the nail which is being inserted from the entry point that we have just created. Again, do not use hammer to put the nail in. With jiggling forces, it should be able to go, because if we hammer, we can communicate the entry with the fracture. That again will be a disaster in drop. So use just twisting movements and it should easily slide in. So now as we can see, the nail is gone in. There are markings on the jig to know how deep to insert. Do not keep the nail proud. The nail has to be flush or at least 2 millimeter buried. So that's the top of the nail. Here we have buried it.
We are more expert.
And now at this stage, once we have the 2 of the 4 components taken care of, that is the head and the shaft, which are aligned itself, and now it's stable with the passing of the nail. Now you can put back the GT. Since the head and the shaft have aligned itself, there is enough room for the GT and LT to fall back in place because they always belong there. So it's much more easier to pull it back now. And after pulling it back with the fiber wire or earthy bond sutures that we had taken prior, so get it pulled. So GT pull it more anterior and more inferiorly, then pass in the bolts through this nail through the jig. So there are 4 proximal locking options, all in different directions. This is a true lateral to medial bolt, which is the one which is usually put first, or we can put in the calcar first, but prefer to put this first. And everything is marked and color coded, so we know where, how much deep to go. There's a marking on the screwdriver, so at which point we can stop putting in. So that tells us that we are going to be flush. The bolt is going to be flush and not proud, because we do not want the head of the screw to be proud and cause subacromial impingement later on. And there is this option of a screw-in screw, which the arrow of which is again predetermined. We can, as a surgeon, decide where you want to end it in, and use it for our advantage if need be. Similarly, other screws are put in different directions. So one goes lateral to medial, one goes anterolateral to posteromedial, the third one goes posterolateral to anteromedial, the fourth one goes true anterior to posterior. Most Asian surgeons, I may say, do not prefer to put that, which is this screw, because it's too big compared to the profile of the lesser tuberosity that most of us have. So chances of iatrogenic rupture or blowout of that is quite high. So we would prefer to suture it to the bolt rather than putting a bolt in the anterior to posterior screw. So this is how it is. The calcar screw and the other screws put. The distal locking also is done through the jig for all proximal humerus nails. And then most critical step, similar to what we do with the plate, that we need to be able to suture the tuberosities onto each other and onto the implant. So this particular implant has a feature where the bolts have this holes within the bolt head, so we can suture it to that, plus suture it onto each other, the LT to GT. So that way we are totally giving a very stable fixation, so that there is no secondary displacement of the tuberosities happening postoperatively. And again, this is mandatory in all the patients, no matter what age. The bolts, even though they look too good and you get a good feel that there is a good purchase, but do not only depend on that. The suturing of the tuberosities is mandatory, similar to a philos. So it is sutured, and at the end, take it through a complete range of motions vigorously, then and there, and see if there is anything which is giving way. If that is, you can supplement it at that stage. So complete rotations and abductions need to be done in trop to satisfy that all things have been sutured well and there is no stitch which is loose. In case, we can reinforce. So that's how it's done. Just to show a couple of few case examples of when all we can do it. We can do it in any type of a fracture proximal humerus. As long as a surgeon we can reduce it, the implant will definitely be possible to be put in. So this is a 4-part fracture in a young gentleman, mid-40s. So this is his immediate post-op. All you require is a good reduction or a valgus reduction and burying of the nail and the screws and suturing of the tuberosities. So this is his 1.5 months follow-up X-ray, and that's the range of movements. So these patients can be rehabilitated very early, unlike what is recommended for a plate, I may say. So they get back their range of movements also pretty early. So this is a 4-part fracture posterior dislocation in a 70-year-old gentleman. It is a neglected fracture dislocation. He was 6 weeks old. The steps remain the same. We need to reduce it back to the joint, get a good neck shaft angle, get a good valgus angle, and suture in the tuberosities. And the implant should hold its ground until it unites, and that's his range of movements at 3 to 4 months post surgery. Head split fracture is a very challenging scenario, I may say, in treating proximal humerus fractures. So this was a mid-30s gentleman, a software engineer by profession, who had a true coronal split of his head. The only difference when you do a nail for this would be that each of the head part has to be transfixed onto the glenoid, one anterior and one posterior, leaving enough space for the nail to come. That's the only difference. Otherwise, everything remains same. We can add on an additional lag screw between the head parts if required, but that is not required since we have the screw-in-screw technology. As we can see in here, the two screw-in screws are holding different parts of the head. So that's his immediate post-op. That's his union. This is his 2 years follow-up X-ray. That's his range of movements. We were always concerned that he might end up in avian, but luckily for him and for us, it did not. That's his range of movements. I do have his consent to show his face in the video. Segmental fractures becomes a very simple entity to treat if you are thinking of a nail, because if you are thinking of a nail, the distal fracture becomes immaterial it aligns itself in almost all cases. So we need to only concentrate on the proximal fracture now, 4-part fracture, proximal humerus in this case. So CT done and reduce it, similar steps, and pass a nail, and it should hold on to the reduction that we have achieved. That's the reduction. So one other fracture that almost all of us are worried of to treat is this anatomical neck fracture, which has a very, very small shell of bone of the head. Many times we just come out and we think that there is absolutely nothing which we could have held it on. But if you start thinking of a nail is a beautiful thing to be thinking of in these particular conditions, where if you see on the lateral view, the fracture is right there. So it's just a shell of a bone with hardly any bone stock. Principles remain the same: reduce it well, transfix it onto glenoid, get a good valgus reduction, and pass in the nail and bury the tuberosities. So it heals well. And this is what I would like to highlight, that what we ended up in the post-op period remains the same until you. So there is no secondary change in alignment happening in these patients, which many times we see with the plates, which causes the loss of reduction in the patients. So more communicated the scenario, more easier it is to do if you are thinking of a nail rather than a plate. Again, just get the valgus angle and pass in the nail, and it will do the job. Thank you very much.
Thank you, Shailesh. Any questions? Yes, Any
Shailesh,
questions?
I have a question. So the only concern with like nailing it unreduced. Okay, so how sure are you, like when you kind of like get the head aligned to the shaft, and then go through reaming everything, and then how sure are you that you have restored the height, that your tuberoses are going to fit snugly in where you want it to?
So the nailing is unreduced in the sense we do not need to get the calcar angle like what you got in the pillows. Get a good entry point. Now that gives us a good valgus of the head. After you are trying to match the shaft to the medial border. Now in some scenarios like a medial comminution, so you don't need to get back to that. You can slightly distract it, get the tuberosities on, and then try to force the shaft in. It all depends on how much comminution it is there globally.
So, fantastic collection of cases, Shailesh. Just one question. Have you encountered any avascular necrosis post-surgery, and how easy is it to get the nail off? See, the way you are demonstrating your entry point, there is some degree of collateral damage primarily to the cartilage and to the rotator cuff. So, to take this out, how easy is it, and converting it down the line?
Okay, so I got the second part. What is the first question? Sorry, avian. Okay. In our series, there is no avian because of the surgery per se. There is only one patient who had avian, who had a bad open fracture of his proximal humerus. Now it is proved beyond doubt that avian is not necessarily because of surgery. It is because of the trauma that the patient had at the time of injury. Coming to the second part of the question, how easy is it to remove the implant? It's pretty easy as long as we have the proper instrumentation. It's not much difficult. Again, you can put back the guide pin if the cartilage, there is some fibrous tissue on the top of the nail which is developed if you want to remove. It's pretty easy to remove that. And the third part, whether we are going through a virgin humeral head and whether that is going to cause cartilage damage leading, it does cause cartilage damage, I agree, but that doesn't translate to a functional problem, because that part of the shoulder, that part of the proximal humerus rather, will articulate with the glenoid only beyond 150-degree abduction with an internal rotation. So I don't think any patient of ours will be doing that movements really to be complaining of that. So that's why they do not complain of that.
Shailesh, Joe, when removing the nail, those empty holes the bone has already formed. I removed 2 in last 8 months, and it's hell of a job, because the empty holes which were not filled up with the locking bolts in the proximal fragment, by 1 year, bone has formed, and it's extremely difficult to get rid of that bone at that stage.
I mean, I really do not have much experience of
You are
removing the
filling up
implant.
all the holes, so it's easy.
Okay.
Thank you.
Thank you, Dr. Shailesh. I think amazing cases that you have, and I would plate most of those, and I think most of us would, but you showed us a new technique, and I think that's brilliant. Before I start, I just want to have a show of hands of how many of us do a tibia nail. Tibia nail. All of us. And how many of us would have more than 90% suprapatellar nails in our practice? More than 90%. I think then that makes a point for my talk. I'll be talking about
100% semi-extended nailing, but not necessarily suprapatellar.
Okay. So, anyone else other than Dr. Ashok who agrees with that approach? We have 3 more like you, Dr. Ashok. Okay. So, I'll directly jump on to this simple case I had two different videos. In case 90% of you would have raised hands, I would have gone on to ask how many of you would do it in intra-articular fractures, and then I have a separate video. But with the response that I got, I'll play the simple video. It's a simple shaft tibia fracture, I think, which is amenable to both infrapatellar nail, semi-extended nail, or a suprapatellar nail. And as I run the video, I'll just talk through the case. The advantage that a semi-extended nail or a suprapatellar nail has is the positioning of the patient. When you position this patient on the table, the leg is straight on a Jackson table or a radiolucent table. You can keep 2 or 3 pillows under the leg so that it lifts up from the other leg, so that when you see a lateral view, the other leg doesn't come in the way. You could use multiple gowns, but all you need is something to lift the leg up from the other leg for a good lateral view. AP view is anyways really easy. And then I've marked out the patella, I've marked out the tibial tuberosity. Image to the left is the top and image to the bottom is the distal part of the leg. So the incision is around 2 to 3 centimeters above the superior pole of patella. It's a vertical incision that is most commonly done. Some people do tend to give a horizontal incision, but the workhorse is a vertical incision. So that's 3 to 4 centimeters above the patella, superior pole of patella, and some people do use a horizontal incision as well. There's nothing wrong. So once you do the incision of the skin and the subcutaneous tissues, and if you do encounter a bleeder, take care of the bleeding. Dr. Ashok, something we were talking about, I do use self-retaining forceps, so I don't need an extra assistant for that. And then I just go on to the cautery, look at the quadriceps, cut the quadriceps. In the interval, you look at the various planes of the muscle. I try to go as avascular as possible. You see there is no bleeding happening there. But if there is bleeding as well, you can easily take care of the bleeding. The only thing I do is I don't go direct deep to the bone. I just cut the quadriceps, and the small articularis genu muscle, which is right next to the bone, I preserve that. Because then I think the chances of the quadriceps sticking to the bare femoral bone decreases, and then the chances of stiffness of the knee decreases. This is, I'm showing, I've used a certain nail, but the technique is not dependent on the certain technique. It has, compared to the infrapatellar nail, it has a slightly longer sleeve, and this particular sleeve has a honeycomb sort of a structure. So if you put in one wire and if you're not happy, anterior, posterior, medial, lateral, you can just keep the jig sleeve there and use one of the other holes to shift your entry 4 or 5 millimeters here and there. The good thing in that sleeve is it has a silicone sleeve on top of the metal sleeve. So when you put it under the patella and over the trochlea, the metal doesn't touch any of the part of the cartilage. This is the silicone soft sleeve which compresses a little, that touches on that surface. So it doesn't cause pressure on the articular cartilage. Once you try to put it in, because of the shape of the patella and the trochlea, it almost glides into the right path. Sometimes it can go a little medial or a little lateral, but with experience it almost glides into the perfect path, and you don't need to alter your entry point. And then you put this sleeve in, it locks in place with this jig. And then like a infrapatellar nail, and this jig has this suction tubing connected to it. So all the reaming material, everything directly goes into the suction. It doesn't go into the knee joint.
But do you not infiltrate or insufflate the knee with saline?
No, sir. So I don't. Yes, initially when suprapatellar nailing started or semi-extended nailing started, a lot of people used to put 100 milliliters of saline into the knee joint and see how much they could inflate the knee joint, how much the patella could come over the trochlea, making way for that sleeve. I think that was what used to be done, but now I haven't had any problem for the last few hundred tibia nails that we have done, and I don't think there is any much importance to that. But yes, traditionally that was the thing. Thank you for asking me that. People used to inflate the joint with 100 milliliters of saline to see how much the patella would come up and would make way for the sleeve. But I've done it in a lot of arthritic old patients, and If you find the joint to be really, really tight, then like Dr. Ashok Sunil Gavaskar has said, you could slightly release, slightly go more distal on the patella, do a lateral parapatellar, do a slightly medial parapatellar approach, release the patella and lift the patella slightly off, but that's usually not required.
Dr. Kadigur, you have any opinion on this? You have done quite a lot of suprapatellars.
It is always better to see the bilaterally by putting a saline at least 30 ml and see it, otherwise you may get a contral injury.
Thank you, sir. So that's usually in the first go, because the trochlea guides you to the entry, the guide wire usually goes into the center, but if there's anything wrong with that sleeve, same sleeve in place, you could just with the honeycomb move medial or lateral. So that's the AP view. And then taking a lateral view is really easy. You don't need to do anything. One thing you should be really concerned about is how you look at that sleeve in the lateral view. Here. So at this point, you should be really careful that your sleeve is touching the bone, because if some part of the sleeve comes off the bone, then you can damage the joint with the wire or the reamer that you're putting in. This is a very important lateral view, that you are sitting on the bone when you're doing that. You're not damaging the cartilage at all. And then you take the sleeve out, the internal sleeve out, the outer sleeve remains in place, and then there is this proximal reamer. This is slightly more longer.
If I can, so one thing that you can do is like when you can go with the sleeve with the guide wire, and once you reach that, you can actually like remove the sleeve, because the sleeve will actually bias your guide wire to a free. So once you remove the sleeve, okay, then you can kind of manipulate the guide wire to get a more anterior trajectory, unlike what I got there. Okay, because your sleeve will kind of dictate where the guide wire goes. So go with the sleeve so that the guide wire doesn't damage anything, and then you can retract the sleeve and then.
So that is something I think that can really be done in very tight knees. It helps a lot, or when you want to change the trajectory. And then once the guide wire is in, you can, the proximal entry is made, just put in the guide wire like a normal lane through the sleeve. The sleeve stays in all the time. Just ensure you push it in and keep it close to the knee all through the procedure. If you want any manipulation, I think all of us are taught that the best way to reduce fractures is traction. And giving traction in suprapatellar nail or semi-extended nailing is really, really easy. This is supine position. One person has to just hold the traction and the guide wire goes in. Once the guide wire goes in, there are these systems with fancy sleeves. It directly measures off the length of the nail that is required. But otherwise, you could use the normal system of a radiographic ruler or a scale to measure the length that it is giving the length. Once it gives the length, then ream. While reaming, the sleeve has this suction tubing connected to it, and you see that all the reaming material is going out. So in a way, it decreases the chance of probably fat embolism, doesn't pressurize the cavity at all. It is sucking at the same time. And once the reaming is done, it is like any intrapatellar nail or the traditional nail. You put it in, this is a special, this is a certain nail that has a very small jig. This is a very small footprint. This jig, you load the nail. The good thing is all the screws, the proximal screws in the nail are locked onto the nail. So the nail has threads in it, and when you put the screw, it doesn't go straight. It rotates and goes, and it locks onto the nail. So in very osteoporotic bone, the screws don't come out. And out of the 3 distal screws that this particular nail that I'm using has, the distal most 2 are also locking screws. They have threads in them, and the screws will lock those. And this part of a interlocking nail really comes in handy when you're using these nails to handle intra-articular fractures and hold them like a plate. It is my habit, when whatever nail I'm using, maybe the best of companies, but I always check the jig before I put it in, because I don't know who's used that jig before I have and in what way that it has been handled. This jig is really simple. It has a very small footprint. You can move it medial, lateral, anterior, posterior, and you check each hole. The wire goes in, and then I check the next hole. Just push a button at the top and it rotates. Just push this button and it rotates to another position. Put the sleeve in that position and check. So when I'm taking my AP view, I move the sleeve out. I get a very good OP view. And when I'm taking a lateral view, I move the sleeve to an AP view. So the jig never comes into the way, even though most of it is radiolucent. So once the nail is checked, it goes over the guide wire, which is already put in. You see everything under C-arm. There is no doubt. You don't need to flex the knee. No one has to sit on the floor. There is no risk of infection from you touching the floor, nail touching the floor, guide wire touching the floor. You can visualize the reduction, hold the reduction in traction, put the nail in the same position. I think that is the best advantage of this technique. You see everything. The radiographic C-arm imaging becomes really convenient. You don't need a lot of assistants. You don't need manipulation. The manipulation to put the nail in, which might move your fracture or lose the reduction. So once the nail is in and you are satisfied, you see the jig is in AP view, but now if I have to take an AP view, I will just rotate the jig and move it out of that view so that I get a good AP view. That's the distal part we are seeing. I'm hammering at the top to get it more distal. And then you come, so see how the jig has moved out from its AP view, and when I go to the lateral view, I'll just rotate it back to a AP so that it doesn't come into the way of the view. So the big helmets that we get with the traditional, so that's the jig in the way, but if you move it away, then you get, so it's moved out now. And then you do a freehand distal lock. Once the freehand distal lock is done, it also has a jig for distal lock, but I tend not to use it. This particular system has screws that lock onto the screwdriver, so it's very easy to put them in, and they thread onto the nail, so they lock onto the nail, so they don't come out even in very osteoporotic patients. So once these screws are locked, then this jig, I've connected suction at the top to decompress the canal, and you can put a dynamic screw at the top. Once that screw is put, it gives you the option of this compression mechanism sleeve. So this is a long sleeve which goes on through the jig to put pressure on the proximal dynamic screw. The nail is locked distally. The moment you put pressure on that, it pulls the whole nail up with the dynamic screw as the lever arm, so that compresses the fracture. I'm looking at the fracture, how the fracture is compressing and compressing it, converting the dynamic screw into a static screw intraoperatively. So you get the dynamization of the nail intraop. Once that's done, you have 3-4 more locking options at the top, and those can be locked. So, and you see the movement of the C-arm, there is no struggle. Just one person can keep moving the C-arm in both AP and lateral view at the same time. I think that's what makes this technique really easy. You see your reduction, you maintain your reduction, and you nail it in reduction without worrying for anything else. Once the jig comes out, you give a good wash to the knee joint, which is very important, and then there is a end cap which threads onto a screwdriver so that you don't lose the end cap in the knee joint. You go into the knee joint through the same path, lock the end cap onto the nail if you do with the normal nails, and then you give it a good wash. All it needs to be done is then close the quadriceps mechanism or the extensor mechanism, and then a subcute and a cutaneous closure in these patients. Thank you.
Samarth, here the fracture was fairly distal, so nail reduced the fracture and guided your reamer. In the upper third, how do you position that guide wire? It was going and kissing the posterior cortex. So how do you position it parallel to the anterior cortex?
Sir, 2
Where
o'clock.
we want it to be.
2 o'clock, Hall B. Hall C. I think I have that talk, so I'll request you to come.
Samarth, one question. Through the entire procedure, you're maintaining a sleeve inside, okay, protecting the trochlea and the patella. So, but when the nail goes in, okay, everything is removed. So, how are you sure that you are not causing any abrasive damage, especially at the nail jig junction? Okay, and also during when you are doing distal locking, okay, like you are at full extension.
So, thank you, Dr. Ashok. Wonderful question. So, there are multiple techniques. So, the sleeve can take a 8 mm nail through the sleeve if you want, or some people use the same silicone sleeve freehand on top, keep the sleeve there, put the nail in, and in the end, take the jig out and the sleeve of the silicone sleeve comes out. I think, biologically speaking, it is the duration of time that you take to put the nail in without any compression, because I feel even a slight compression of the articular cartilage with the nail for a long period of time can cause some vascular changes in the cartilage. So when I'm putting the nail in, I'm usually very fast because I want to decrease that time. But for your concern about the cartilage, I think you can keep the silicone sleeve in. I have not kept that in here, but I try to do it really fast.
One suggestion is like when you do distal locking as well, like I don't think you need to be in full extension actually. Okay, that can decrease the pressure on the trochlea.
The pressure on the trochlea, but I just maintain the same position throughout the procedure. I just don't change the position at all. I think that's the advantage of this nail, that once you make a position, it stays in the position.
Thank you.
Thank you, sir.
Great presentation of the supra new technique of nailing of how to do in tibia. This is a video on glenoid. I think many people would have seen it, but just it's a scapular fracture video, not a glenoid, if I can say that. Yes. Chalu kaise we are talking of a case of a 34-year-old male who had an RTA. We are not talking of the indications out here of how exactly and when. It is a video for an approach to scapula and how do we fix that, right? So let's not be involved in the indication wise. It's a controversial thing here, whether I should be fixing it or not. A lateral view, a lateral position of the patient, and you can see that the incision out here, jaldi chal raha hai, ruk sakte hai. So here I'll just take a pointer and say that you take the patient in a lateral view, you can a lateral position, or you can also take him in prone position. Prone position is difficult because many of your scapular fractures will have associated rib fractures, and because then to them prone position might not be a right place. In a lateral, you need to ensure that your upper limb is fully draped and you can freely move it here and there. Don't put it too abduction, and don't make sure that you are keeping it in very high overhead flexion, because there have been incidents and reports of people having some ulnar nerve and some stretching of the things because your positioning is not accordingly, you are giving excessive stresses on that. Most of your anesthetists don't want it to be higher abduction. Remember that here in lateral, when you are doing it and freely draped, they do not have control. And we normally lose control when we are inside the surgeries. So that's why remember that. The incision is on the lateral border of the scapula, which you have identified, and you gave first an incision to know where exactly you are. We are going to go in between the infraspinatus and the teres minor. And that's the thing in the top portion, which is the proximal part. Here is your deltoid, which is coming, the posterior division of deltoid, which is attaching to the spine of scapula. And beneath it is going to be the infraspinatus. And from the lateral border, you are going to be having the teres minor and then subsequently the teres major coming. So that's the orientation of this position. And then you are going. The first thing to note is how to make sure a good plane between the skin, subcutaneous, and the muscle. That's the critical thing I would say for most of these fractures. It's somehow not very easy to do it. You need to ensure, because some of our muscular people, the fibers and everything are associated and very closely linked to each other. I'll stop it again here. My retractors in the top, the Lengenbeck as well as one of the other two Lengenbecks in the proximal portion, are lifting up the posterior part of the deltoid. In the initial times, when you are having issues with exposure, you can very well split off and cut the deltoid from the posterior part and the spine, leaving a small tendinous or aponeurotic portion of 2 to 3 millimeter, where you can suture it back. In thin patients or in the fractures which are lower down, involving mostly the extra-articular part, you can leave the deltoid there itself, and you can just lift it up and do your entire surgery without cutting any of the muscles, purely a muscle sparing approach, which is on this part. So this is the deltoid which has been lifted up, not yet cut. This area is involving the teres minor and infraspinatus, which we need to find the plane between, which is the crucial thing. The fibers of infraspinatus and teres minor are going in different positions. One is going in this fashion and the other is coming here. So to find the plane, you need a proper exposure. You may have to extend your longitudinal and vertical incision. Try to see that the fascia is not coming in between your way and try to look at the fibers where exactly. It's not an easy thing to say and do, but with experience, it comes in time that we are at the right place between the teres minor and the infraspinatus. So the fibers are going, remember, both the teres minor and infraspinatus, they are all going, forming and converging to form the rotator cuff and on the posterior part of the glenoid. This is the infraspinatus, the top portion is the deltoid, and the portion which I just pinpointed would have been somewhere there, the teres minor, which we need to see. Here, because your lateral border of your scapula has displaced tremendously, sometimes to find out your teres minor becomes difficult. So the tip is look out for your bony position of the lateral border of the scapula. Try to bring it back to its position, and then the muscles which are originating there, try to find the plane in between that and the proximal muscles of the infraspinatus. I'll have to extend my incision here and so that I can find that plane between the infraspinatus and teres minor. And when you are recording it, most of the time you are not going to find that plane. So now that thing I have taken, I have found the bony part of the lateral border, and from there now I am going back and trying to see where my infraspinatus and teres minor is lying. As you saw in the previous CT scan, it was the lateral border of the scapula, the extraarticular portion, which was way distended. I have reduced it back, just giving you a brief right now, how exactly it is. The incision has been extended. This is the deltoid, which I am reflecting up, not yet cut, just going below the deltoid on the posterior division. This is the lifted up deltoid. This is your infraspinatus lower down, which you can see where my forceps is telling you the direction of the infraspinatus going towards the glenoid on the posterior part and attaching to your rotator cuff in the GT. And that part is one of the teres which is coming from the inferior thing. Below it is the teres major also coming, but it is not forming a part of that, and it is going and attaching towards the humerus lower. Now, once you have done that, you might find a branch of medial circumflex, a part of scapular artery, which you can ligate out here. That's one vessel which you can ligate. And then follow your lateral border up to the glenoid, go proximally higher up and start following it up. Once you do that, and you are reflected the infraspinatus also from the base of the spine and the body of the scapula. Now you can see that this portion of the scapula is being retracted. What happens is scapula is having 18 muscles. It just converges it as it breaks. So you want to bring back the length of scapula and then push back your lateral border. Otherwise, it won't come down. You can use K-wires as joysticks on the big thick portions on the edges of the scapula to distract it and then push in your portions of the bone which you want to do. If it would have been a glenoid, my incision would have been slightly more higher and the dissection would have been slightly more proximal to this place. These are the K-wires which just to hold it. This K-wire is holding the lateral border to the glenoid of the scapula now. And then subsequently, once it has been reduced, you can go in and fix in your plates. Now coming to the good, big, thick portions of your scapula where you can put in the plates. Most of the muscles are arising from the sides of the scapula, be it rhomboids on the medial side, teres on the lateral side. So you take the thicker lateral border of scapula and that will be having a thickness of around 12 millimeters to 10 to 12 millimeters, not more than that. You require a plate which is 2.7 or 3.5 long plates. You can have a foot plates. Now you have some anatomically plates for scapula as well. But you can use foot plates, volar Bartons or the dorsal Barton plates of the distal radius, metacarpal plates, locking plates if you want. But make sure that your screw sizes are at least 8 to 12, at least 4 to 5 screws are there each. You will not be able to put 14 or 16. You will have to cut them and then bring them, because otherwise the scapula and the ribs, which are posterior part of them, they may have some problems and irritation. Here I have used a simple 1/3 tubular plates which was available, and where we can put in the screws which are of 8 to 10 or 12 maximum. The even just, it's a very thin portion, just going medial to it also, or just going away from the border of the crest of the scapula will not allow you to have thickness of more than 5 millimeters, I can say that. So this is the rest of the scapula. Yes, we can put in some other plates also, but it's not required. You fix whatever is required, and which is the lateral border, maintaining the glenopolar angle proper, as well as the intra-articular fractures. You can put in a small plate here at the base of the scapula, the lower part where the angle is, if you want to maintain the length as well. But we decided not to put it here. Now I am coming superiorly, trying to show you where exactly that suprascapular notch and the nerve is, which you need to protect. These Blengenbecks are reflecting the infraspinatus, and the suprascapular nerve, which is coming from that notch, is going and supplying this infraspinatus. Where my forceps and the pickup is going just as a groove, that was the place from where the suprascapular nerve comes out and the vessel. You need to be quite cautious there. Your retractors need to be not very tight and very causing excessive stretching. And now if you see here, this portion is the glenoid posterior part and the capsule region, because this is the fracture. So if your glenoid fracture is here, which is mostly the inferior tubercle of the glenoid which gets avulsed, you can put in a lag screw from here going towards the base of the coracoid, which also helps you to fix the intra-articular glenoid fractures from the same exposure. Lower down it may not be there, higher up you have to go. The lower incision may not be of requirement at that time. Right? क्या हो गया? बंद ही हो गया. कोई है, चलेगा सब. आप कर रहे हो? अरे हाँ, जस्ट द क्लोजर पार्ट. या 3 मिनट है डॉक्टर. नहीं, वीडियो अच्छा यहाँ नहीं आ रहा था इस समय, अभी खत्म नहीं हुआ था, अभी तो है 2:30 में भी. मेरे हाथ में क्यों नहीं आ रहा? अरे छोड़ो, नहीं आ रहा तुम्हारे इसमें. Then you need to close it. You can you start this in the last 5-10 seconds of that, or 15-20 seconds of that. That is once you have fixed that plate, you can see it under vision and under image intensifier also, and then you can look at it. You have maintained the fixations properly. Both the Y views and the AP views can be seen. The closure can be done you have not cut any muscle. If you see, we have just lifted up the deltoid, and we have this is the closure which we are showing. It is just a closure of the fascia and the muscles. We are just bringing them together. No muscle has been cut, plain between teres minor and infraspinatus, and lifting up of deltoid. Hence, as soon as you close these things, the patient has significant pain relief, and from very next day, you can start the mobilization, be it of intra-articular glenoid fracture or for an extra-articular scapular fracture as well. We normally tend to put in subcuticular skin sutures, because many a times these places have a lot of keloid formation and a big hypertrophic scar. So give some extra time and put in a very good, because the incision out here and the scarring might be not that good, which you find. So you can put in a subcuticular sort or make sure that you are putting in a good incision there, which is being put here. And after that, once we have done that, you can see that where our fixation was, we are going just high up on the glenoid, and where I was showing, you can put even the intra-articular glenoid lag screw fixations, which can be done for the patient, and the fixations can be there. This is this 2 weeks post-op. As I said, muscle and rehab can be done immediately from the very next day onwards because you have not cut any muscle. It's purely a muscle sparing approach. And 3 months post-op, you can see that it's having a good result.
Thank you, Vivek. I don't think there are any questions. Any questions to Vivek? No. Now, since we are running behind schedule by half an hour and Sushrut does not want you to cut down on your lunchtime interval, the remaining 2 surgeries will be shown tomorrow morning, if that is okay with the presenting authors, Ashok and Parag. So 8 o'clock, between 8 and 8:30, we'll have the rest of the live surgery sessions. And we break for lunch now to reassemble at 2 o'clock. Thank you, speakers, and thank you, everybody.
अरे दिख गए आज दिख गए पूरे जाके आज रात को ऑपरेट करके सुबह आ रहे हैं अच्छा चलना बोल ऐसा नहीं है कि बात इकडे पॅकेट टाकून देऊ
आएगा मैंने कहा था
म्यूट कर पूरे
Good afternoon, all. So we are starting with the interesting session on terrible triad. All the speakers are here, and it's a very interesting topic. Probably at the end, we'll generate a lot of information and discussion. May I invite first speaker who will speak on radial head fixation, Dr. Kashyap.
Good afternoon, all.
A chairperson doing his work.
My topic is fixation of radial head fractures. So I'll tell you the tale of. Hey, kuch.
It's working.
Tale of 4 different radial head fractures. So radial head fracture comes in variety and with quite a lot associated injuries. So I will take you through 4 cases and how we approached it for the fixation. So my treatment algorithm for radial head fracture is very simple. Preserve radial head whenever it is possible. If it is conservable, conserve it, or if it is fixable, then fix it. If it is not possible, if there are multiple fragments, then we can either replace it or in a very small number of cases now, we excise it. Approaching radial head, this is the Kaplan interval, this is a Coker interval, but what I usually use is a ED split one, which is in between both these approaches. And this is the first case, a valgus impacted kind of radial head fracture. There was small chip on the medial side, and if you look at the CT, it's divided into 2. So this was fixed this way. How that was done? Simple lateral ED split approach, and then initially the articular reduction done and fixed with the small headless screws, and then a tripod kind of a fixation. A little bit difference what I do here is a tripod screw actually goes from top to bottom, but sometimes we don't get a face of the opposite side of the radial head. So one of the screw I usually put in a retrograde manner. So at the end of fixation, I got 2 tripod kind of a screws and 1 intra-articular screw. So that's 3-month result of this patient, and we usually get a very good range if mobilization is initiated in early phase. Another case, a 2-part radial head fracture, but was very comminuted and very much displaced. But patient was young, somewhere 20 years boy, so decided to fix on that. So these are the displaced. This is the initial articular reduction, temporarily fixed with the K-wire. Then gradually headless screws are fixed. Then the tripod kind of a screws are fixed. So at the end, I have a 2 intra-articular screws and 2 tripod kind of a screw. So that's how we get a good reduction. When there is a very good quality of bone and less number of fragments, say a radial neck fracture or a 2-part radial head fracture, then it is very useful. So this was the end result of this patient. We can see the X-ray, a nice healing and a clinical result too. We go to little complex variety, wherein a radial head fracture is associated with elbow dislocation, what we know is a terrible triad. There are multiple talk on that. So I'll focus on the radial head. After reduction, the radial head piece was, separate. And so, the patient was again a young 25-year software engineer. So we decided to operate on him. This is again ED split approach, intra-articular reduction done, fixed with one of the headless screw, and then locking plate was fixed. So this is stitch removal time when the patient is almost, good range of movement already. He had this. So because it was a terrible triad, we fixed a lateral collateral with the anchor, and a lasso suture was already also fixed. Another, the case on which I am going to highlight the whole talk, because if we go through this case, then all the other cases are little easier than this. So this is a army man who fell down while doing duty in northeast India, was a native of our place, so he came because he was advised surgery. So this was a fracture. There is an intra-articular split, a displaced portion, and a big metaphyseal triangular piece there. So this is the approach. This is the ED split approach. This is Sugekawa paper, wherein he advocates, where this PIN is there. So almost at 3 finger breadth or a 5 centimeter is the usual distance wherein we get. So looking at the case which we had, see, this case has a long fracture, right? So in this case, I need to explore the PIN, right? Otherwise, which we usually don't need. So this was the case, and this was fixed like this. How I did this case, I will take you through the steps of the surgery. This is a lateral incision, and there is a ED split. And then once we separate the thing, then we find the supinator and a radial nerve going anteriorly into supinator. So because this case I had to fix it up to here, I dissected it, I identified PIN, and then I dissected the whole length of PIN through supinator. So once I know where my PIN is, then I am safe, right? So I visualize that under vision. While doing so, we can pronate the forearm so that our PIN stays away, and that's a 3 finger breadth rule wherein usually we get this. So once I identified that, then I started dissecting over radial head. See, I did not touch my radial head till I dissected PIN, because the PIN is a danger. So once, if you have any danger, just look at it first, right? So then gradually one piece was there, another piece was not found, another piece still not found after dissecting little bit of the capsule. Then with the dental hook, I could get that piece, retrieve that inside that. So many people say that they take the radial head out and fix it on table. Whenever possible, don't do that. Even a small flimsies of soft tissue is there, then try and reconstruct there only, because it carries some vascularity which is very helpful for the healing. So there I am only rotating there and trying to fix it there without actually taking it out. So this is a temporary fixation of the radial head split part with the K wires, one K wire there, one K wire here, one here. And then I started converting that into definitive fixation. I put a leg screw at the metaphyseal region, and then I put a headless screw for that intra-articular part, and then a temporary plate placement and checking under IIT whether things are right or wrong. Another concept is a safe zone of placement of implant, a surface implant over radial head. So there are two jargonic figures which we see. One is this and another is this. I would tell you a very simple way. When you finish off with your temporary fixation, you fully supinate your forearm. Then plus to ulna, you put your plate, because that's the maximum supination you are going to get. And then if you put your plate, say 1 or 2 mm away from that, and then you can pronate it, right? So it's very easy. Fully supinate, place your plate close to ulna, and then fix it. So that's your safe zone. These are the intraoperative features. These are intraoperative after fixation. Always check all the intra-articular fractures whenever in the body, that whether it is stable or not. Because in a postoperative period, you have to mobilize this patient, right? So that stability will allow you to mobilize in a postoperative period. So this is the PIN. This is my cut supinator, and this is my plate. Now I am closing it. I closed the same layers which I opened. See, this is a postoperative picture, and this is a 3-month result. Look at this. He's almost back to his army duties. this is not working, but he has got full supination and pronation as well. See this. Another case, very fragmented radial head. So this is probably not the case for fixation. So at the end of my talk, I would tell you that it is not that all the cases are to be fixed. You can do a radial head replacement, also get a very good result. So post-op management is early mobilization is key to good result like any other articular factors. Movements should be started earliest possible, looking at the intraoperative stability and fixation which you have got. A range of movement brace may be used in selected cases because sometime in a terrible triad cases typically what we do is we do not allow extension up to 30 degree, more than 30 degree, right? So we start mobilizing into the arc of 32 full and then gradually we start increasing the extension of patient. Complication, there are complications. The commonest one is the stiffness. There is a possibility of heterotopic ossification, radial, proximal radioulnar synostosis. I will take a lecture of arthrolysis in which these few of the complications are treated. A PIN palsy if you don't take care. So concluding, radial head is an important stabilizer of the elbow. In presence of elbow and forearm instability, the radial head should either be fixed or if it is not fixable, replaced. Thank you.
Thank you, Kashyap. May I invite Ashish Padnis? He is a current president, she is a current secretary of Bombay Orthopaedic Society, likely to be president in the future. Amit, you have a question. Come on the mic.
Last case in which you dissected the PIN and you had a very long spike of the radial metaphysis. Is that right?
Yes, correct.
So why you did a lag screw fixation? In this case, was the plate necessary? I think maybe a couple of more interfragmentary screws. And
no, sir. If you look at the images, there was a metaphyseal fragment as well as there was a radial head fragment. Absolutely. So only the part of the neck was attached to that. So if I do that only screw fixation, which I shown in a previous two cases, right? Then I am not confident of mobilizing that patient.
No. So you could have fixed the radial head with 2 screws at the rim and the rest of the metaphysis also with a couple of lag screws.
That is an option, but at the for that patient to mobilize early, I found that best. Thank you,
Dr. Kale?
No. Sir, in radial head fixation and radial head excision, do you find any difference between pronation especially? Because the videos you have shown with the fixation, the pronation seems to be restricted. And pronation nowadays, in this IT era, because what I am facing is that the patient are demanding more pronation when they sit on their laptop or computers.
That's correct. With the radial head fixation cases, there has to be subtle supination and pronation restriction is there. But if you look at the pronation is very well means compensated by little bit of a shoulder abduction. So the patient of restricted pronation are not that disabled as much as that of a supination, because the supination if they cannot do, then they have to twist like this. But pronation if they cannot do, then that can be well compensated with the shoulder abduction.
Do you find any difference between radial head excision pronation? Pronation in radial head excision and pronation in...
So I don't have any comparative experience or the data which I would look for, but nowadays I rarely do a radial head excision, sir. Thank you.
Ashish, can you start?
Yeah. So I'm presenting a case which, there are a lot of terrible triads in this. So there is a slight modification to this presentation. This is a 57-year-old right-hand dominant gentleman who has no other comorbidities, and it's like a swipe injury that he suffered. And it's a part of a polytrauma that he had chest injuries and head injuries, but no other limb injuries. So this is an isolated limb injury that we are looking at. He presented to us with an elbow dislocation. This elbow was reduced in the casualty under a block. There was no nerve involvement before reduction, and all the compartments look good. So once the elbow was reduced, we got a CT scan done. I'll just move to the next image. And what the CT showed is that the head had a small fragment. It was reduced well, and there was no fracture or bony chip of the coronoid that we could see. However, there was a comminuted fracture of the capitulum and even the lateral epicondyle. So apart from the bony injuries, the soft tissue injuries and the open injury was a cause of concern. And these were the intraoperative videos that were showing that the elbow was unstable at a certain degree of extension. So we decided to proceed with radical debridement, getting rid of all the contamination, taking out all the soft tissues that we could after the patient was stabilized, and trying to conserve and preserve all the articular fragments and the bony fragments that we could. Once this was done, initially we first focused on the cornoid, because as we could put our finger in the anterior part of the elbow joint, all the soft tissues were stripped over there, possibly as a result of the injury and the twisting injury. The cornoid was quite bare, so there is a suture anchor there, along with which we have got the anterior capsule and the anterior structures to be back on the cornoid. Once the radial head fragment, the loose fragment which was there, was excised and the rest of the radial head was preserved, we proceeded with sort of fixation of the rest of the bones, the capitulum, and also the intercondylar fracture. Provisional stabilization was done with the help of these K wires. And fixation of the capitular fragments were done with the help of these headless compression screws. For the lateral epicondyle, which was fractured, we decided to put a 4 mm cannulated cancellous screws using a washer, so that will sort of buttress the fragment back to where it is. And for the rest of the soft tissues, we decided to augment that repair with a lateral collateral ligament repair, and repairing all the soft tissues that could be there. This was the end result at the end of our fixation. I did not push it too much into extension or flexion, didn't do a very vigorous range of movement. So because I still felt that a capitular fixation could have been a little precarious, we didn't want to play with it too much because of the very flimsy fragments that we had. And this was a defect that was left with at the end of the surgery. Fortunately, our plastic surgeons decided to sort of proceed with a radial forearm free flap, which was done primarily. The patient was subsequently immobilized in an above elbow slab. Eventually, the flap went on to heal very well. These are the pictures of the follow-up. And gradually, we could start mobilization once the flap was sort of settled in about 15 days' time in a hinged elbow brace. Currently, this patient is still undergoing rehab. He's got a near full flexion. The extension is restricted. It is getting better, but we are not pushing him too much for the want of, for preventing any sort of, protecting our capitular fixation more than the fixation of the cornoid or repair of the ligaments. Would you want to take any questions at this? I just got one more slide.
You're finished?
Yeah, so basically what I wanted to highlight in this is more than the bony injury. This is a video I've taken from the AO Foundation website. And this highlights the importance of the soft tissues that we do not see often on the x-rays. In this video, what they have demonstrated is they're sequentially gone on sectioning a particular ligaments as they happen in a sort of an injury or as I say in a circle of four. Initially they section the lateral collateral ligament, and then the elbow becomes a little more unstable. So the bony stabilizers of the elbow will help in terminal flexion or extension. It is between 30 to 60 degrees of extension and flexion when the elbow is not locked and the bony restraints or bony contours are not stabilizing the elbow. That is when the ligaments become more sort of important. So as the injury progresses more onto the medial side, then the elbow starts becoming more and more unstable. So this is what we have to recognize apart from what we see on the X-rays and the CT scan, by fixing the bones and sort of not giving adequate importance to the soft tissues is not wise. So even if you feel that fixation is all good, is looking good, you still take some additional steps to sort of fix it. Sorry.
Excellent.
Thank you.
Any questions? You're finished, I believe.
Yeah.
Any questions? Now,
Avinash.
come on the mic, Avinash. Ashish, the classification of the capitulum fracture here is Duberle's 3 or 4, which by dictum requires a posterior plate.
Right. So the issue here, I mean, we didn't want we had done it primarily. It was an open injury.
So
we
is
decided to
that-
order it all in one stage.
Is
So I
that the
want-
open injury which restricted putting a plate posteriorly?
Yeah, so I
Because
wanted-
that is a large fragment which requires posterior buttress on which you build the capitulum.
Right. So if you see the flakes which were there, I don't think I would have got a hold of them from posterior side.
Apart from capitulum, it was also an entire condyle which was fractured.
Yeah.
Which you have fixed by a lag screw and a washer.
Yeah. So I would have to dissect it slightly more posteriorly and then put a plate on the posterior aspect. Considering the open injury, a little bit of contamination, the fact that we are operating within 24, 48 hours, and I just decided not to be so.
So this is not a standard fixation what one should recommend in such bony injuries.
No,
Ideally
isolated-
that requires a posterior plate.
Yeah.
Yeah.
If it's like a shear fracture, yeah.
See, what you showed the soft tissues which can get damaged from lateral to the medial side. So preoperatively in such
Can you speak
injuries-
louder?
Preoperatively in such injuries where you are expecting an extensive soft tissue damage, would you recommend a CT and MRI both for your operative planning?
Yeah, so see, basically CT we got it done anyways. MRI we didn't get it done because it's an open injury. It was reduced in our casualty, so we knew how easily or how difficult it was for us to put it back. And MRI wouldn't have addressed, if you follow that right intent classification or certain sequence of fixation, which is going to come in the next talk, MRI might not necessarily
Yeah,
have
I'm
changed my
checking
mind.
because if the MCL is gone, then your management.
No,
changes.
that
You need to
that will come in the
go
next talk.
medially and
Abhinav,
repair the MPL.
it's an open injury where everything is in front of you. After having fixed, probably then you can assess the medial side.
Yeah. Just a query. I mean, the radial head was intact.
Yeah.
And you didn't go medially.
No.
You approached the coronoid. How? I mean, just I was asking you how you did it. Just the buttonodal.
Right. So basically, it is possible to go anteriorly if you take out more fibers from, let's say, the common extensor region, put up your Hohmann's retractor, and the entire anterior surface of the distal humerus and the coronoid can be in vision. Even if the radial head in a slightly dislocated position, the coronoid comes beautifully into position. With anchors, it is very easy. Rather than a lasso stitch, is slightly more, a little more difficult.
But this
accessing coronoid
is
not a
then not a classical terrible triad.
Yeah.
No.
So the key is
But you
to
can
keep the elbow reduced and in flexion. Okay, so when you do that, okay, so your anterior things are relaxed. Okay, you have more space to work on the anterior side. So if you have, but here it was not unstable probably, but if your elbow is dislocating and if it's, then you are struggling anteriorly to get access to the coronoid. So it's possible, but anchor, you can put it into the thing, but only problem is the trajectory. You may not get the best possible trajectory for the anchor. So that's one concern.
I mean,
really have to turn your hand.
Even with the radial head intact, you can go and.
Yeah, you can.
You can go anteriorly.
So when we fix the radial head in a terrible triad situation, that's what we do, isn't it? So.
Thank you, Ashish.
Thank you very much.
May I call upon next speaker, Sumit Chaudhary, for his case on distal humerus fracture.
Good afternoon, Chairperson, sirs, and all the delegates in the hall. So I'm going to present a simple case, something similar to what Ashish has presented, but something unusual about it. So this is the injury films of a middle-aged male who sustained trauma to the left elbow. His right hand dominant. He presented with pain, swelling, and severely restricted range of motion, and there was no distal neurovascular deficit. So these are the injury films. So can I have any opinion of the house or the chair what we are dealing with?
Anybody in the house wants to comment on the X-ray? The nature of injury? Parag? You see a double contour sign.
So, I agree. There is a significant anterior shear. It looks like a EE4. It wasn't unstable to start with. So it's really an anterior shear involving the capitulum and the trochlea.
Yeah.
Need a good CT and then fix front to back.
Yeah, so you have a coronal shear fracture, but there is quite a bit of impaction as well on the medial, on the lateral trochlea. So CT and then so these-
Something above the radial head, you see some more shadow there, suggesting probably it is a comminuted capitulum.
Yeah, so what I would like to highlight is this is basically a coronal shear injuries, and like Dr. Munshi said, there is the double arc sign which indicates that this injury is involving not just the capitulum but it has some component of the trochlear fragmented also. So these are the CT images. Okay, so this is showing two fragments. There's one fragment which is on top of the radial head, that is the capitular fragment, and there is another one on top of the coronoid.
See, actually, like that's more to it. Actually, if you look at, okay, those two fragments are probably the easiest because you can get them together and reduce. If you look at the medial fragment, okay, so again, like you can see a fracture line there, and that is impacted as well. So this can kind of complicate your approach to it.
Right. Even the capitular fragment, it is split into two. So basically, we have three major fragments to deal with here. So how do we go ahead? What approach should be chosen?
Okay, for me, anything like goes beyond the lateral edge of the trochlea is difficult to do through a single approach. Sometimes I might, sometimes I may not. So there are two possibilities. One, you can do lateral and medial combined in supine, but somehow the access is quite restrictive, and like anything goes beyond the medial, it's quite difficult. So for me, the basis of doing this is to make the elbow more unstable. So unless you make them more unstable, you get very little access and you'll be struggling all day. So I'll be very, have a very low threshold of doing a olecranon osteotomy and a lateral epicondylar osteotomy.
Any other opinions?
So I would usually tackle these cases with the extensile lateral approach, wherein usually we get a trapdoor like an lateral epicondyle which is fractured. If it is not, then I definitely do either a release flush to bone, which later on I can fix with the anchor if there is a strong native bone there, or do an epicondylar osteotomy. But usually I can dislocate my elbow medially with the lateral extensile approach. In some of the cases, I can add olecranon osteotomy to it, but definitely a very good exposure is required for this.
Kashyap, if you want to dislocate the elbow, unless the medial side are given way, okay, you can't dislocate it through a pure lateral extensor. It's difficult.
I'll answer that.
There is a series of cases which I am doing with a lateral extensile. Some 14-15 cases are badly comminuted. Only 1 or 2 cases required olecranon osteotomy. But definitely I can hinge upon MCL. And there is a very nice webinar me, Sangeet sir, everybody did in a corona time on OrthoTV, distal humerus shear fracture. It's a very, I would tell you it's a reference webinar.
So here, see it is not a terrible triad where there is a avulsion of lateral ligament complex.
Yeah.
So if it is there, then it is easy to access right up to the medial end of the trochlea. Now here, what you can do, as he is suggesting, you can erase the common extensors and the LCL from the lateral epicondyle, and you have to suture it back. So with that, what happens is, what is remaining is a medial collateral ligament. On that, you can get access to reach up to the trochlea. Otherwise, you can take a second anterior approach or a medial approach if you are not sure about the reduction of the trochlea. And out of all, whenever you are reconstructing, now the medial stability is given by there is a groove where the trochlea ends. So unless you have reduced that, you will not be able to get a good stability on the medial side.
I agree. So another thing I wanted to highlight here is you should, the classical Duberly classification divides type 1, 2, 3 into A and B depending on the presence of or absence of a posterior comminution. But more often the comminution is in the inferior aspect and not the posterior aspect. And if there is a posterior aspect comminution as was there in Ashish's case, then obviously you need to go from the back and then do a posterior plate fixation. So this patient basically had a Duberly type 3A coronal shear fracture of the distal humerus. That as has been already told, basically 3 approaches are commonly used. The lateral extensile approach, where you need to take down the lateral soft tissues. Sometimes you may need to dislocate the elbow to get access to the medial part. Second is the dual approach, where you take a lateral and an additional medial or an anteromedial approach. And many surgeons prefer to choose the posterior approach with olecranon osteotomy because it gives you a much more global exposure. The only point is that you are creating another skeletal injury there. So when I was preparing for this case, I came across this article from Betancourt in which they described the anterior-limited approach to the elbow for the treatment of this kind of injuries. It's a limited approach, but I found it appealing and I decided to do this case with this approach. So for this approach, the patient is in a supine position with the elbow extended. You mark the biceps tendon that acts like a lighthouse. The incision is a transverse incision into the elbow crease. You need to expose the neurovascular structures, and then through three different windows, like we did a triple end window approach to the pelvis, you can expose the trochlea through the medial window between the median nerve and the brachial artery. Then there's a middle window between the neurovascular structures and the brachialis, through which you can expose the middle part of the capitulum, and through the lateral window between the your biceps tendon and the brachioradialis, you can approach the lateral part of the capitulum. So this is a short video. So transverse incision into the elbow crease, that's the biceps tendon. You need to cut the laceratus fibers to expose the biceps. Just medial to that will be your brachial artery and the median nerve. So that's the median nerve, that's the brachial artery. Okay, so this is the medial window between the median nerve and the brachial artery. You can see the trochlea can be very well exposed through this. This is the medial window between the neurovascular structures and the biceps tendon, through which you can expose the capitular part. And this is the lateral window of that exposure. So I could reduce and fix this fracture using multiple headless compression screws. This is the clinical picture of the patient. The surgical wound healed even uninterruptedly. These are the X-rays at 6 months, shows a fracture which has well healed with good function. Any inputs?
Very nicely done. Very nicely.
So the advantages of this approach I found that since the patient is positioned in a supine position, the elbow is in full extension, and this itself actually aids the reduction of the fracture. Another thing is when you are doing it from approaching this kind of injuries from a lateral approach, your trajectory of fixation is usually not perpendicular to the fracture site. You start from the lateral and go more towards the medial side. However, here the fracture surfaces are bang in front of you. So you can place your guide wires or definitive fixation in an anteroposterior direction and at a plane which is perpendicular to the fracture, which gives it a much more better biomechanical advantage. And there is no need to release the lateral ligaments and other soft tissue structures to approach these injuries. Associated radial head and coronoid fractures, if there are any, can be dealt with through the same approach. However, this is not an extensile approach, and visualization of the distal part of the fracture is difficult. You have to rely on the proximal fracture line to judge your reduction. And in dually type B fractures with posterior comminution, this approach is not at all useful, and you need to use the posterior transolecron approach. So anterior triple window approach to the elbow is a technically demanding, but it may be a valid alternative in complex lesions of the elbow in which access via classical routes is limited. Thank you.
Thank you. Excellent. So the only drawback of this approach is you are seeing only one surface of the fracture.
Right,
The
right.
other surface is
Yes.
inside the greater sigmoid notch
Yes.
of the trochlea
Yes,
part.
yes.
So that is not visualized.
Right. So it is extremely important to see your CT and ensure that there is no posterior as well as inferior comminution.
Yeah.
Because if you have an inferior comminution, if you try to approach this, then you will push the fragments into extension.
So if you have distal involvement and posterior involvement, this is like completely.
Exactly. Yes.
It can be a window in those situations to see the medial side, whether your reduction is perfect or not. The good part is you get a direct trajectory to your screws, headless screws.
Yeah. Your screws are going directly perpendicular to the fracture site.
Can I just?
Yeah, I mean, again, the same stupid question. I was just wondering, since it's an anterior approach, can we put a screw through the coronoid process if there's a fracture?
Yes, it is
You,
recommended.
you can actually plate it as well through this approach.
Yeah.
Abhijit?
So just one quick point. We always find that the posterior introitious nerve it branches off is always at a risk while retracting.
So in the lateral
Can you
window,
turn the mic?
yes. So
So
you
can
need
you
to be
turn the mic?
careful
Yes.
when you are dealing with the lateral window, because between the biceps and your brachioradialis, you will have the branches of the
So
radial nerve and the
we
PN.
always isolate that nerve and protect
Yes,
it.
I
And
agree.
we have made a modification to this approach wherein we split the brachialis. So the medial visualization is much easier than retracting the entire biceps So when you split the brachialis, then approach to the coronoid, the medial aspect of the trochlea becomes easier rather than trying to retract the brachialis also at the same time.
Another thing I would like to emphasize here is in the medial window, you should make the medial window between the median nerve and the brachial artery. Don't go medial to the median nerve because the branches to the flexor pronator mass are going from the medial side of the median nerve.
Thank you, Sumit.
Thank
May I call upon Abhijit again to speak on terrible triad. Let us see how different he suggests the surgery for terrible triad.
Thank you. Well, the surgery is not very different, Chairman, sirs, and audience. It is just the philosophy of treatment. We have this 30-year-old male who was treated elsewhere for an elbow dislocation, came to us with elbow pain and swelling about a week to 10 days post-injury. This was his initial X-ray, which was reduced, and then he was referred to us. I won't belabor too much on the stabilizer of the elbow, neither the circle of Hori, which we are all familiar with. This is the mechanism of injury, the pathomechanics. But what we need to understand is what's so terrible about the terrible triad. It's an extremely unstable injury. We have fragments that are usually quite small and which are quite difficult to fix, and they usually do not do well. That's the reason why there is this suggestion of calling it as the terrible triad. And then these are the components of the terrible triad. Again, we won't spend too much of time on this. Literature says that you first go lateral, then you do your lateral stabilization, perhaps an anterior stabilization. Then you check for medial instability, and if at all it is unstable, you go ahead on the medial side, and then you would repair your medial collateral complex. We always believe that decompressing the ulnar nerve and also transposing it is a better thing to do rather than allowing it to settle in wherever it is, because we always find the ulnar nerve to be entrapped in a hematoma, which will resolve, or rather which will settle down over a period of time and cause fibrosis, therefore compromising the gliding of the ulnar nerve. And decompressing that hematoma, releasing the ulnar nerve, repairing your medial complex makes it much better. Not only that, in cases wherever the radial head has to be fixed, the window that you have to approach the coronoid or the capsule from the lateral side is very limited. You have to resort to these ACL jigs and so on and so forth, but it just makes life a little bit more difficult, and therefore we always begin with the medial approach, do our repairs, then go on to the lateral side. So that's how we deal with it. We begin with the medial approach. We address the medial, the ulnar nerve. We also release the median nerve so as to put it out of harm's way. And then you can use either the Hotchkiss over the top of approach, wherein you want to plate a larger fragment of the coronoid, or you can do your pull-out sutures. We'll just see that in a bit from the medial side. Then we put in a suture anchors, either repair or reconstruct the medial collateral ligament. Then we go on to the lateral side, either fix or replace the radial head, do your LUCL repairs or reconstruction, and then we close. And we always find that doing a pull-out of the capsule is a far more robust way of repairing the anterior capsule rather than putting in sutures wherein you're trying to push the knot down, and that really does not give you a robust repair vis-a-vis trying to pull that capsule down onto the coronoid as seen in the schematic diagram here. So this is the patient wherein we first use the medial approach. I think you all will appreciate how unstable that elbow is. That's the anterior capsule along with a small chip of coronoid that remains attached to the capsule. Note the amount of soft tissue damage that's present here, and then we is this video not playing? Yeah, there you go. So you can see the combination on the medial, that's the medial collateral ligament that's avulsed off the medial aspect of the humerus. Very unstable elbow, tremendous amount of soft tissue stripping. A lot of times you do not even have to find your planes. It's just you go through the injury planes and you can reach those soft tissue structures. The humerus is rotated and dislocated, the so-called posterior pivot sign that we see, pivot shift test, and see it's just with a thumb, I'm able to reduce and dislocate that elbow so very easily. That's the base of the coronoid. That's the bed that we will prepare for our transosseous sutures, pull-out sutures, to go from anterior to dorsal or posterior to dorsal, right? So we use a K wire of about 1.2, 1.5 millimeter size. We make two parallel tunnels into the base of the coronoid and then bring that thing out dorsally. And now we have the sutures into the capsule and the coronoid brought out dorsally, right? And then as you pull on those sutures, you can really tug on it hard because this is a very strong braided non-absorbable suture. We use a number 2 fiber wire here, and see how beautifully the anterior soft tissue and the restraint to the anterior stability is restored. So you just tie it. You may use an endo button if you would like to, or you could just tie it over the bone because there's quite a bit of soft tissue out there and it does not cause any soft knot irritation. Once that's done and you have put in your suture anchor also to repair your medial collateral, you would turn your attention to the lateral aspect. Now here, if your radial head permits fixation, so be it. Or if it has to be replaced, you should be prepared. So thinking ahead in time and planning your inventory is extremely important. You should have radial head plates. You should have headless compression screw if you have to use a tripod method of fixation of the radial head, and different sizes of plates as well as your replacement options. And what's very important is, can anyone tell me what these two lines indicate here, the ones that you see? Oops, maybe I'll just use the pointer. So the two lines that I have drawn, what does that? One of our junior colleagues, perhaps, what am I trying to look for here in the anterior? So that's the delta wave sign. It's very important to see this because if you have overstuffed in your radial head replacement, you would see on the medial aspect an opening out or an incongruity of those parallel lines. And if you have understuffed, which both are bad in the long run, if you have understuffed, there will be continued valgus instability. And if you have overstuffed, it will lead to chondromalacia of the capitellum. So that's very important. And this is especially true in trauma because for radial head replacements, you do not have a jig or you eyeball. You look at the lesser sigmoid notch, and that's where your radial head should fit ideally. And then you should not undercut or overcut the radius to cause either overstuffing or understuffing the radiocapital joint. So we have a radial head. This is a hydroxyapatite coated stem along with a suture anchor for your lateral collateral ligament as well. We have our pull-out sutures in place, and at around 1 year down the line, this is the same young guy with good function and a good outcome. Post-operatively, it is extremely important to avoid physiotherapy against gravity. So we like to tell the patient to do overhead range of motion exercises so as to prevent any varus valgus stresses on the elbow joint. So there is nothing kind of new in terms of the surgical steps. It's just that the philosophy of treatment is a little bit different from what's described in literature. So with that, I thank you for your attention. Any questions?
Just hold on. I have a question.
There are going to be many.
So what is the basis one? Okay, of
I beg your pardon?
No, what is the basis of this? Okay, the sense like we know the what is published, okay, and what is your rationale behind doing it from the medial side first and then the lateral side, and especially with the current literature which shows like a lot of these type 1 coronoids in a terrible triad can be actually neglected. They don't have to be repaired. Okay,
Right.
Just to add.
Absolutely right.
Just to add. So this is not a classical terrible triad. The reason is the MCL was avulsed from the medial epicondyle. So classically, the third element, the LCL, the radial head, and the coronoid. When you have a terrible triad, the coronoid has to avulse from the base where the MCL, the anterior band, is attached. So that was intact here. So you cannot classify this ideally into terrible triad.
True.
So probably the kind of injuries or this particular case, what you received demanded this. That is a different thing. But this is not a classical.
True. Granted, but like I said, so before we incise, like you rightly said, type 1 tip fractures, obviously we conserve them. We always like to examine these patients under anesthesia. We look for the O'Driscoll pivot shift test under anesthesia. We look for varus valgus stress test. And that is the only way wherein you can determine the extent and the direction of the instability pattern. And once that's established, that's when we resort to the knife. Now, I just had videos to show for this particular case. That's why I included this case, but I do concede that this is not the classical.
So is this a case-based thing, your approach, or like, so you would approach, kind of like have a case-based approach to the problems?
Yes. So majority of time, if at all we have to open up, we always like to go medially. Simply, the second question that you asked me, there is compelling evidence that is out of Mayo Clinic and Johns Hopkins by O'Driscoll and I think Oaklander, Mary Oaklander, wherein they have shown that the stiffness of the elbow is akin to CRPS of the hand. And it is usually due to the ulnar nerve which gets entrapped in the fibrosis and loses the gliding adipose tissue around the nerve. So if anyways you're going to go medially, decompress the nerve and either transpose it or not, it also gives you a window for, so I saw Gawale sir shaking his head. It's just because
we disagree to what you have said and what is your approach. The literature, the evidence till yesterday doesn't follow, or
True.
there is no literature which quotes your approach. That is the reason I'm
hopefully will, sir. We are in the
You,
process
you
of
are
publishing
an
this.
expert, but lot of people here actually need to go easier way, right? An easier and the more standard way, which has been advocated all over. So maybe you may prove yourself right in forthcoming future. But as of now, what is a current standard that also you should tell so that the delegate would benefit?
So that's
wherein
exactly-
MCL is usually left alone. See, most of the time these all have a posterolateral rotatory dislocation, and the medial plate which you said about a coronoid is only in a posteromedial rotary, wherein you need to go on the middle aspect. Because we all have a quite number of cases wherein we have been using a lateral approach, a standard protocol, and things are reasonably well.
So the fallacy here is, if you have replaced or fixed the radial head from the lateral side and then you're doing a medial stress test, it may be fallacious and will not give you the true extent of the medial collateral ligament injury. So therefore, preoperatively, even before you're done or exposed on the lateral side, preoperatively, if you find that there is a medial opening, that is our indication to go in on the medial aspect as well.
No, but again, like,
I beg your pardon? True. So that's exactly the point. So you look at the pivot shift test. The lateral side, the LUCL, the test for establishing the instability pattern besides the varus stress test or the valgus stress test is to look at the pivot shift test. If you do not have a tracking of the ulna in the over the coronoid and the trochlea, that would give you. So you do a stress test. And you're like, and the fallacy, that's exactly what I'm saying. If you have replaced or fixed the radial head from the lateral side, that also would compromise your ability to assess the medial stability. And therefore, preoperatively, if you have an instability on both sides, we go in on the medial side.
Thank you, Abhijit.
Right?
Yeah.
Thank you.
We have a re-live surgery, and a lot of misunderstanding will be cleared by Ashok.
okay, so
Hope you don't increase.
So I'll show you some of the established, current techniques that we use for repairing the individual structures from the lateral side in a terrible triad injury. So as you might be aware, like all these things, so most often you get a tip fracture in the coronoid according to the O'Driscoll classification, where you will most likely rely on suture fixation. As I said, like there is some evidence, recent evidence that these can be left alone, but I still kind of like put a couple of sutures there, doesn't take much time. And then if you have a basal kind of a fracture, not often, then you can go ahead and use screws, like this. So if you have a big chunk of coronoid, like what you have seen there, then you can kind of like, so then you can use retrograde screws from there, And for the radial head, as already Kashyap beautifully showed, like we can use screws. Sometimes if you only the anterolateral quadrant is involved, screws simple. If you have a neck fracture, not too much of impaction, then tripod screws work very well. But if you have some impaction, I kind of like prefer to plate it if I'm not going to replace it. So replacement, obviously, whenever in doubt, like, okay, more than 3-4 fragments, whatever, not reconstructable, especially in a terrible triad situation, don't waste much time on thinking about putting these pieces together. I would be have a very low threshold to replace them. For the lateral collateral ligament complex, again, like my go-to technique is to use transosseous technique by using bone tunnels as isometric point. You can use suture anchors as well. I used to use them, but now I most often use transosseous techniques, and sometimes I use anchor with an internal brace. So this is the case that I'm going to show. Okay, so a terrible triad in a 44-year-old male. You can see the coronoid on the CT image, reasonably big enough, but I wasn't sure how much depth is got to get a screw. Okay, so my plan would be to either use a screw if possible or use sutures. And Ed probably is going to get replaced. So okay, the incision again, like this is a slightly older one. I currently use a posterior incision and then take flaps. Okay, but no harm in that. Okay, so you can use either a lateral incision or a posterior midline incision and then flaps. Okay, so you can go lateral, and if required, you can go medial as well through the same incision. So once I've gone through the skin and subcutaneous tissue, then is to find the right plane. There are different planes where you can go through. Okay, you can go through the cocker, you can go through the EDC split. Okay, so this is something that I do because like it's very difficult to retract the skin at this point. So like these sutures come in handy. So elbow is like very difficult to retract. So few sutures to hold the skin flap in place. Okay, so there's some of the planes that I can. So you can use the cocker. You can use the EDC split by Arch kits, or you can use the couplant between the ECRB and the EDC. But I used to do the EDC split before for these injuries for the fact that I thought it will be more easy to go anteriorly. But I have kind of shifted back to the cocker because I get much easier to the lateral collateral ligament complex, and it is not difficult to go anteriorly. Okay, as I said, like if you have the elbow reduced in flexion, you can actually get a very nice approach to the coronoid, even with the radial head intact there. So this is taking the common extensor muscles from the anterior. You make sure that you kind of like stay anterior to the equator of the lateral epicondyle. Okay, of course, this is a terrible triad. I know the lateral collateral ligament going to be disrupted here. So that's the cocker. So raise the ECU. And then like you can go through the capsule and the annular ligament. You can see the bare area, no ligament on the distal humerus, and then split the supinator as well. Okay, if you are going more distal, you have to identify the pin. Again, with the cocker, you are more posterior. So you are more and more anterior. You have to be very careful about the pin. Okay, because the nerve goes from proximal to distal, anterior to posterior. So the more proximal you are and anteriorly, you have to be very careful about it. Again, like somehow release to gain access medially. Okay, so these are the broken pieces of the radial head. Okay, now that's the coronoid that I'm holding in. So it doesn't come into the vision still. Okay, yeah, so that's it. So that's the coronoid. Okay, so I felt it was reasonable. It had reasonable bone there. Okay, you can see that now. So reasonable depth of bone. So I thought I could use a couple of screws there, 2 or 2.4 mm. So I decided to replace the radial head, just a freshening cut. Okay, just to kind of like make sure my height of the head matches to what is removed. So you can, at this point, like your sequence can be this way or that way. So I'm just preparing the radial at first. So I size it to the minor diameter. Okay, so if you are going to err on the smaller side. Okay. You can use cemented or cementless components. Most of the time that I use are short cemented ones. Okay. So at this point, like I'm assessing my elbow stability. As you can see, this is not a type 1 coronoid exactly, but like elbow is like reasonably good. So this is why they say like you can neglect some of those type 1 coronoids. So if you keep your elbow flexed, you can get a lot of great access to the anteromedial side. Okay, so if I'm going to take coronoid sutures, I would have done at this point, but like here, I know I'm going to fix it with a couple of screws. Because like why I delay the coronoid fixation is like once you fix the coronoid, you don't get the play, okay, to get the radial head out and do all these things. So keep the elbow unstable till you get everything. So I'm not committing to coronoid. If I'm taking coronoid sutures, I would have taken it at this point, but not tied them. But here I'm going to put screws. So again, bone tunnels, isometric point, anterior and posterior drill holes. So I take a number 2 fiber wire, take multiple crack holes in the common extensors anteriorly, and then another suture posteriorly onto my ligament. I don't take the ligament separately. I take the ligament and then incorporate the repair in the common extensors posteriorly as well. Okay, so that like it gives you, that's a ligament, but I don't take the ligament alone. I take multiple crack holes, including the muscle as well. So go distally probably around a couple of centimeters and then come back proximally. So that gives you a very robust repair. So now my sutures are done. Okay, now I can kind of like start focusing on the coronoid because like so again, that's just a 4-5 Weber clamp. Okay, you don't need any jigs. Okay, you get beautiful exposure, especially when you don't have the radial aid. Okay, so I'm keeping a dental hook as well. So just freehand your wires or drill bits. And then in this case, I think I used 2 or 3 2.4 millimeter fully threaded Cortex screws. So again, so the screws are somewhere between 30 to 40 mm. So if you are using a 2 mm, most often you don't get such long ones. So 2.4 is the smallest screw that I get for those kind of lengths. So you can see the coronoid there, fixed well, and that's, you can see one screw tip just proximal to the coronoid, so that's the third screw. Okay, this was site of a kind of a like pretty wide fragment, so I thought I had space to get in another one. So now you can see the anterior buttress restored, and this is another case where I just show the technique of suture fixation. So like the type 1 coronoid, again, like you can get good access with the elbow flexed. So take 2 sutures, 2 number 2 fiber wires, one laterally and one medially. And then like again, like this is a slightly older case. Now I would have used a midline incision. So drill holes, again, freehand, it's not difficult. Okay, just see through the main window where you are exiting. So once you are done, you can use any shuttling device. Okay, you can use a suture shuttler. You can use the bead pin like I showed here. I most often use just a needle right now with a prolin and then shuttle my sutures. So once you have got your sutures posteriorly across the bridge, okay, so around a centimeter of bone bridge there, you can see. I think this is a slightly more difficult way of doing it, and honestly, like this was my slightly older one. So a needle is much more easy to shuttle. So once I kind of get them and I tie them with the elbow in flexion, okay, so before I kind of repair the lateral collateral ligament. Okay, so once the coronoid is done back to the original case, I can go ahead, replace the head here. As I said, like I use a small quantity of cement, even though these implants can be put in without the need for cement. Again, you can see the lesser sigmoid notch there. Okay, so reference for your radial height. So make sure you don't overstuff. Okay, so if your elbow is not too tight, okay, you won't be overstuffing at this point. So you can see like my coronoid fixation is already there, not much of a force. Okay, I'm just like titrating my height, so keeping it a little bit thing so that like I'm not understuffed. Okay, just filling cement. So this is a case like where I show how to fix your radial head. Okay, so this one was a impacted comminuted radial head. Okay, so where we chose to plate it again like lag screws to start with, and then for impaction this is something that we used, a shelf plate. Okay, so I disimpact and then bend the plate, a 2.4 plate or 2, and then put it there and tension it. Okay, though that effectively acts like a raft so that it doesn't allow the plate fragment to collapse again. And this is not going to impinge on anything, okay, because this is not articulating with the radial head at all. So unlike the regular plating techniques that we use, I put it into the fracture site there, okay, and that is going to keep my head elevated and not lose my reduction. Okay, so that's something I use, and some more screws, and then I kind of complete it with I use a mini small fragment plate, okay, a 2 or a 2.4. I mark the safe zone. I don't like the Synthes, the radial head plates. They are too bulky for me. Invariably, I won't be able to close the annular ligament because it starts kind of like irritating, and a lot of patients do lose rotations as well, especially supination. So I use the mini fragment plates. This is 2 mm, I think. Yeah, 2 mm. And that plate is 2.4 mm, the green one. Okay, so this would be my kind of like a go-to fixation. If I have a comminuted segment, I'm going to fix with impaction. Okay, so I showed you fixation and replacement. And then finally, the lateral collateral ligament complex. Again, those the sutures are shuttle, both the anterior and the posterior sutures. And then like once everything is done, I tie them with the elbow in flexion and pronation. Done? Yep. So that would be it. Sorry. So and then like I just have a 1 minute thing on lateral collateral ligament anchor. Again, anchor very simple. Put an anchor in, crack hose, and then tie them on.
Thank you, Ashok.
Any question?
There's no time for the questions. We'll take it at the end. Please be seated, sir. We have a lot of complications related to stiffness of the elbow following this injury, and how to address that, particularly the stiffness. Dr. Kashyap is going to speak about the surgery for stiff elbow arthrolysis.
So whether I do radial head or Ashok does a terrible triad or Sumit does that distal humerus fracture. See, many of these patients might, end up in having a stiff elbow. So this is a common complication. So all of we, spoke about fixing it, but at the end, this might be required. So this is a clinical case also. This is a usual scenario. Many of our patients, elbow articular fractures, they get a limitation of motion, and which is a very disabling to them. So this is, I start with the case. 40-year male is working in Africa. He fell down there, and he got this surgery done there, and then it was a coronal shear kind of a fracture. But then he had this much limitation of motion, which is really a disabling situation, right? And then he came to a native place wherein they consulted, and he had only a 1 month holidays to go back to Africa. I told that we will do your surgery and let us see what we could achieve. So this was implants were removed, and this was immediate post-op, and this was at the stitch removal. And just last week I called him from Africa. He gave me this all these things, and he blessed me a lot. He said, "Oh sir, I am doing a lot of my duties. I lost the hope and all that." That's not by myself about, but that's the procedure which can help in releasing it. Another case, a lady had a loss of extension after a SCIC fracture distal humerus, and by removing implant and doing release, we almost could get her full extension, right? Another case, my own operated proximal
a forearm fracture, transolecranon kind of an injury. He got a reasonably good result for a flexion extension, but he lost his supination and pronation. Almost he was not having any supination and pronation because the radial ulna were almost fused there. So this case I also operated a posterior incision, implants removed, took a fat graft from above side of the incision, and then I removed all these implants, put a bone wax from the bone surface which was raw, and then put this cement, this fat as a graft, and you can see that almost a full supination and pronation even at the end of 1 year post surgery. So these are the cases just to stimulate you that we can get a good result. Now I'll tell you how do we do that, right? So this is a boy, 17-year boy, had a minimal elbow injury, was put on a slab for 15 days, and then the over enthusiastic parents and all that went to physiotherapists where he was passively manipulated. Patient came at 2 months to me, wherein we can see there is a fluffy callus there. So that's a myositis which is in the process. In an MRI, we can see a brachialis which is quite an inflamed. So I, explained the patient regarding the course of the treatment which you'll do. I told them to wait, do only active exercise, let the stiffness be there. And at the 1 year, they again, they were in regular follow-up. They came at 1 year to get the surgery done. So this was under anesthesia also. His movements were only this much. And after surgery, this is also again pre-op motion, and this is the intra-op picture. And these are the steps, or this is the technique, which is a very useful technique. This is by David Ring and Jupiter, wherein these are all the steps which will go through. And this is a very nice pictorial article wherein you get medial, lateral, and all this. So very useful to have a reference. What is the sequence of release? If there is a loss of flexion, the bony release anteriorly and soft tissue release posteriorly. So anteriorly what we do is we excise the tip of the coronoid, we clear coronoid fossa. Some people release the septum, they do one special procedure is there wherein they remove the septum, and we can remove the implant if fractures are healed, and for a release on the posterior. So if there is a loss of flexion, the bone is abutting over it, so bony release over here and the soft tissue or the posterior aspect. So we release all the muscle in the line of incision, medially between ulnar nerve and the joint space, and laterally between anconeus and tricep, release the capsule completely. If there is a loss of flexion and we are doing this surgery, then I usually transpose my ulnar nerve, right? If there is a loss of extension, the patient is not having, up to 20 or sometimes a 30 degree of FFD in elbow is quite tolerated. But if we are, more than that, then we do surgery for release, Bony release is posteriorly here, where we excise the tip of olecranon, we clear the olecranon fossa, remove the septum, excise the osteophytes and remove implants if it is feasible and coming in the way and fracture is united. And we do soft tissue release anteriorly, where we laterally release between ECRB and EDC, and medially we release a flexor pronator mass anterior to medial epicondyle and release a complete capsule from both the sides. How did we do in this case? This is a lateral incision. Typically AD split which I usually take, and this is how I am going inside, and these are the pictures from that article. There in where we find the flare of the distal humerus, and along with that we start incising it. Then we incise there, we cut the capsule and everything there, and then in this it was not there, but the posterior aspect also, a second incision on the lateral aspect, we need to take a posterior incision going between anconeus and tricep and release the capsule and everything from there. Then we turn the patient's arm into extra rotation. That's the medial side of the arm, which is a medial epicondyle. I am centered over that, and this is my flexor pronator mass is released from the anterior part of the medial epicondyle. Ulnar nerve is identified, and usually it is transposed. All the capsules released throughout from the medial side also. So at the end of surgery, you can actually literally pass your finger or your instrument. You can actually see through the medial to lateral, right? And then the posterior capsule is also released. What we do checklist at the end, we take the elbow through achieved range of movement. If it is not adequate, then we can gently manipulate it. If inadequate, again, we go through all the steps which we have gone for release. If something is missing, then if movements are inadequate, we release. They say that's not a described in this article, but I usually do. I release both the side collaterals with a pie crusting method, not releasing it completely. There are some people who release it completely also, but when you do pie crusting, they get little bit of lengthening. Then you gently manipulate so that stretching of the ligament would occur, and then we accept the final range of movement. Another thing which I do, I don't know if anybody is doing, I inject diluted steroid and local anesthetic into the tissues which I have released. So that will give a very good anti-inflammatory action in the early postoperative period, and we get a very fast movements. Once the patient gets the movement within a week, then they are very much motivated. So that's also a very useful. So this patient had this much good movement at the end of the surgery. Elbow was stable. This is early postoperative period wherein we can see that the patient is very motivated and to do all the exercises, almost full flexion and full extension with the stitches on. And postoperative protocol is early range of motion, indomethacin, sometime a steroid to back slab only if it is required, a repeated follow-up, direct observation of operating surgeon, not to send this patient to physio, right? Because this is, again, if they go to a passive physiotherapy, then again the chances of re-stiffness with the stiff elbow, which is even stiffer than the previous, right? So this was final result for this. He was very fond of playing drum, and he sent me the clips wherein he is doing his regular, school and then the drum activity. This is almost a full movement to this boy. Another, my case, last case, transolecranon fracture, a very complex injury. We can see almost, fragment of everything in olecranon and radial head. And this I operated using this method wherein olecranon was plated and the radial head was replaced. If you look at the intraoperative picture of the primary surgery, there are cartilage damage, there is a coronoid which is gone, there are flimsy bony things, so many things were fixed with the only sutures. So even though this patient did a very good physiotherapy, active physiotherapy under my guidance, wherein he got almost a useful range of flexion extension. But again, if you look here, he has lost his supination and pronation. Here also, if we see, there is a bone formation which is not allowing a pronosupination. So again, I did the same, the case which I shown. Sorry for this video. I removed this implant and removed all these things, but radial head I did not remove. My few cases of the radial head replacement for isolated radial head or other indications, but at the time of release I don't remove my radial head because that's a good stabilizer, because we are removing all the tissues and the capsule. If radial head is not there, the chances of instability is going to be there. Again, a fat graft harvested from here was put inside, and whenever you excise the bony fixation between radius and ulna or the synostosis, then that surface is actually a very eager to make a new bone formation. So what we do is we put a bone wax, apply the bone wax inside, and then over and above to it we do a fat graft. This was a very early postoperative. We can see he gained his supination percent much then, because it was almost zero when he was doing. He is appearing for some forest exam, so he sent me all these pictures, which is usually not a thing which we advise to our patient. Sorry for these two videos, wherein he is doing pull-up and rope climbing, and he did these push-ups in my hospital, right? So for rope climbing, he need for this pull-ups he need a supination. For this he needs full pronation, right? So almost back to he is preparing for some forest exams. So take home of my talk are elbow arthrolysis is very rewarding surgery. Wait for elbow to cool down from any inflammation, which usually takes 9 to 12 months. Never do passive physio in fresh or revision cases. Surgeons should directly observe patient in postoperative period and not to give it to any of even second consultant in the hospital to hypnotize the patient from the start of the treatment, from the pre-op through the full recovery, because you have to make your patient on your page. You have to explain everything, what we are doing, what are going to be the problems, what are going to be the difficulties if you don't do that. So if patient is on your page, relatives are on your page, then only you will get a good recovery. Balance expectations and discuss the possibility of worse re-stiffness and never lose off. Thank you.
Thank you, Kashyap.
एक बच्चे को बैंड बजवा दिया, दूसरों को फौजी बना दिया. Amit, for his talk on only a case. And that means he comes from Varanasi. So we are not supposed to ask any questions.
All right. So this is a very simple case. Elbow injury, young athlete. It's a 26-year-old male, fell while catching a cricket ball. Comes from a very poor family. May I take the opportunity of asking our panelists, what more do you find anything wrong here in the X-rays, and what would you plan to do further?
It's a kind of a proximal forearm or a transolecranon kind of an injury. There is a radial head injury, there is a flexion injury of the ulna. Definitely we need to have a CT for this.
Okay. So one of the problems was, where is the radial head? And the AP view, the radial head is there, and the lateral view, it is there. It's just stuck to the back. It is completely fractured. So CT, that's what the CT looks like. Got a big coronoid fragment. We've got multifragmentary olecranon, and we've got a radial head which is plastered at the back. And it is a complete intact radial head. It does not look fractured, but it is a neck fracture. So what is our operative plan then? So what we planned was to find out the fracture components, what has to be fixed, the order of fixation, and how do you go about it? May I know how our panelists would go
I think this is a posterior olecranon fracture dislocation, typical. So you can go posteriorly and then build it up. Okay, the radial head, okay, you can reduce it, use the void interval. So once you reduce it, you can probably fix it with a couple of screws if you can, or else prepare for replacement. So that would be step one.
Yeah.
And then like you flip the olecranon, okay, and then get access to the coronoid. You can develop a medial window and you can go as anteriorly as possible. So these are big basal coronoids, large ones. So unless you get them, you are not going to make the elbow stable. So
Absolutely.
if you can, this is big, so probably you will be able to do it from back as well. So once you reduce them, few lakh screws
So
should be possible. Clamp
Ashok,
it and then.
exactly what I did. So that's the varus and valgus stress testing for this patient pre-operatively. We did a posterior approach and we opened everything from the back. Got first coronoid medial facet and tip reduced, and then finally the rest of the proximal ulnar fragments reduced and fixed with lag screws, and then neutralized with a olecranon locking plate. We can see that later on. But what are you going to do to the radial head? Now, I was operating this patient in a very charity hospital. There are no implants available for the radial head.
Yeah,
So how
see
are you go
this,
about it?
this elbow is not dislocated, right? So once you fix your ulna, you can very well excise it, which I don't do. I usually fix it or replace it.
Yeah,
But
but you saw-
there are people
Yeah,
who
but you-
excise this,
Yeah.
and that can be a reasonable option in this case.
Yeah,
But if it is fixable, that has to be fixed, or either I would replace it. But if both the options are not there, then you can excise because there is
Right.
elbow is not unstable.
See, this is predominantly an axial loading pattern. So as Kashyap said, like you can excise the edge sometimes, and a lot of times in fact, but like there is increasing evidence to suggest that these fractures do have ligamentous component as well. So make sure on the lateral side, if you're going to excise it, the lateral collateral ligament complex is intact, and then yeah, you can do that.
Yeah, so that's so we used a, what do you do for the radial head, which is lying here? So that's what we did done, and whether this is going to this thing. So it's going to act as a spacer only, that's what my thought was. So we have a reasonably good olecranon reduction and fixation, but we do not have anything for the radial head.
See, there is one more option for the radial head. If such situation be there, you can simply pass a multiple rust nails from down, which can just go and hold. At least two rust nails going differently, so we'll make it little rotationally stable.
I did not
Metasio kind of a
I
thing.
did not plan for rush nails, but I did plan for K-wires. But when I actually reposed the radial head and got the correct rotation, it was nice and stable without any fixation. So I just left it there, just like that. So, okay, so radial head importance is there, buttress to the proximal migration and valgus stability. So we must make an effort. So this is what it looked like on the post-operative X-rays. Looks fairly all right. And we just repositioned the radial head. Lateral side capsule we nicely repaired. And on table, there was no significant valgus instability because MCL was basically intact and elbow joint was stable. So this is the immediate post-op X-rays. We gave a back slap to this patient because we had not done anything to the radial head. And after 2 weeks, we started mobilizing. That's what it looked like after 1 month. And I was surprised to see actually the radial head uniting with the rest of the shaft. And that's the, at 1 month, this is the flexion. And that's the pronation and supination. He still hasn't got very good supination, but he's got reasonably good pronation. And that's what it looked like at the end of 2 months post-op. He's still continuing rehab.
Yeah, and
Thank you.
Thank you.
For me to get a best range of movement, the window period is 2 to 3 weeks.
Yeah, I know.
So if we get a movement in 20 days, then there is a best possibility of having good functional recovery on the range of movement kind. So that can only be assured when we fix the thing stably, right? At least something, if would have input, then you probably would have been more confident of mobilizing that.
Exactly.
Otherwise, there is very nicely done things, and that's no issue about it.
Thank you.
Any questions to any of the speakers? Amit, you're very curious.
In this case, Amit, this was a flexion type of an injury. To look at the ulnar fracture in the lateral view, it's into flexion. So generally, and there is another extension type of in Bados type too. So whenever there's a flexion type of an injury on the lateral view to the ulnar, it is in flexion. That's a V. Then generally you don't have any lateral ligament injury. You just have to. What you did was right. If the ulnar fracture is comminuted and into extension, then most of the times the lateral ligament complex is gone.
No, I differ. Okay, if you look at the trans or posterior olecranon fracture dislocation injury, this is a posterior olecranon fracture dislocation injury. So these ones compared to the rotatory injuries, the posterolateral and the posteromedial, okay, the ligamentous injuries are slightly lesser. But like it's not as less as we tend to think previously. And if you look at current evidence, the highest incidence is in the posterior fracture dislocation injuries. So you have to be careful.
Yeah, exactly. And here also,
We can take only 3 questions.
Loading injury.
There is one more talk to conclude. Yeah.
Just 2 minutes.
Yes.
Was this posterior approach in the olecranon, how safe it is to go to the radial side just to fix the radial head with the same incision?
Right. Okay. So it's fairly safe if you know what is the course of your PIN. That is the only thing which you will actually injure. So don't go too much. I didn't have to go down too much because see, my fracture was actually at the radial neck, so it was not really distal.
Sir, sorry. There is no risk of PIN with the posterior. Okay, only thing is if you want to access it, one is the Boyd interval. Okay, go there. Okay, or the better way to visualize would be to raise an anconius flap. Okay, from distal to proximal. Okay, so you get brilliant visualization of the entire lateral side. You can go ahead and.
So another one small question. I mean, terrible triad injury we are fixing.
He is waiting. He is waiting before you. We have to conclude in 3 minutes. Yes.
In continuation to Abhijit's statement, so sir said if we fix the lateral side and we assess, we can get a fallacy. But under anesthesia, if we assess, is it really a fallacy or is the joint stable?
So one thing first, we do not, once we fix the lateral side, we don't do a varus valgus instability and assess whether the medial side has to be repaired. We assess longitudinal stability and then take a call on whether to go on the medial side or not. So I think there is a difference of opinion, but that is how we look at it.
Thank you, sir.
So I have to conclude the session with what is the evidence in the literature. So I'll start stepwise. First is the coronoid process. You have seen a live surgery where he has tried to repair that small coronoid fragment, and Ashok has shown that, and Amit fixing a large fragment of coronoid. Now, is it really important to fix it anatomically? If we have a small fragment like what Ashok has shown in his film, you don't require to chase and anatomically reduce. Why? Because what does it have attachment? It has only a capsular attachment. The brachialis is about half a centimeter to a centimeter distal, which in Dr. Amit's case is mandatory, and it is also the medial collateral ligament. So hence it is mandatory to reduce those large fragments anatomically to get a more stability of the elbow. And whether you rotate it, you have to just pull the coronoid fragment on its footprint. That is all what required you have when you have a small coronoid process fracture. Usually they involve the anterolateral side. Very rarely they involve the anteromedial side. So if it is a large anteromedial fragment which is involving the base of the coronoid, then you have to fix it. Now, second is coming to the sequence of fixation. So always it has to be from radial head, take the sutures for the coronoid, then suture the coronoid and come to the LCL reattachment. Radial head fractures, whenever you get a radial head fracture, isolated radial head fracture, don't consider that as a simple radius fracture. Evaluate them by whatever investigations or intra-op, by consider that as a part of terrible triad, because you will be missing some of the coronoid which will be picked up either in the CT or MRI in those cases. And whenever you are excising, prepare on the table to find out something different where the elbow will dislocate as soon as you excise. So prepare for a surgery of terrible triad whenever you're doing a simple radius fracture. Plating, excision, both have been covered. There is nothing more to advise. Excision probably is too risky at this stage when we have so much of implants available. Coming to why do we get stiffness? Stiffness is only because you have left behind some residual instability or you have not mobilized them. To beat the fibrosis, you have only 3 months as per the literature. And whatever you want to do, you have to do it within 3 months. Beyond 3 months, the chances that a stiff elbow is going to improve is very, very less. So for that, again, coming back to the fixation, it should be stable enough. On table, you should get complete flexion and extension. And the brace which was shown by Kashyap is the one which is recommended, where you have a guarded flexion and extension to begin with, but you have to start them as early as possible. And usually they are unstable in complete extension, so do not allow a complete extension on day one on that brace after the surgery. And lastly, when you have a ipsilateral humerus fracture, shaft humerus or wrist fractures, these are the one where you have to be extra careful, because the chances of stiffness of the elbow have been found in the literature to be very high. So this is what is the current literature at present. Anything you want to add?
Yeah, I think pretty much summed up. So
we have last 4 minutes.
Any questions?
Routinely use 2 plates to fix the radial head? Or that was
no,
a standalone?
No, it's that in cases with radial head, you have an intraarticular fracture, and then you have an impacted fracture at the neck, okay, which you disimpact. Okay, in that case, like if I have to use a plate, I just use a small plate to kind of like hold it like a shelf.
And you said that you are using a mini fragment, but mini fragment is a straight plate. If you use only a mini fragment plate, then you are lateralizing the shaft, unless until you bend it in a Z.
Contour them, mini fragment, easy to contour.
But you showed it was
No, actually, I couldn't show the post-op because I was kind of shunted out for time.
Thank you.
I just got one small question.
Yeah.
This terrible triad injury, when you're exposing the radial head and going for a bigger incision, I mean, keeping the forearm pronated and using the 3-finger breadth rule, I mean, are we very sure that we are away from the PIN?
No, if you are going to replace the head, okay, you are always free, you are away from the PIN, definitely, okay? If you are going to plate it, and if you are going to use a slightly longer plate, you definitely don't risk it, expose it. Okay, because like see, you are splitting the supinator. If you are using a more anterior interval like the Kaplan, you have to be really careful because the nerve comes from anterior to posterior like that. So if your interval is cocker, then you are going to see the nerve only at the distal part. You understand? Okay, but if you go more anterior, then you get more and more closer to the nerve from the proximal side. So if you go down, just split the supinator, use a scissors, blunt it, you will see the nerve going down, nothing much.
If you pronate it, it is in the supinator mass, which is far away, and 5 centimeters is a critical zone from the head of the radius. Beyond that, the chances and the risk is too high. So thank you very much. We have to close. The next session is to start here. Thank you.
So we come to the next session, which is complex forearm fractures. So I request Dr. Kashyap to start with his case of dorsolateral Thompson approach to radial shaft.
This is, after a complex session on a complex elbow injury, this is like, resident's lecture. Like, how do we do a radial shaft exposure with the dorsal? See, we frequently find this forearm fracture in our day-to-day trauma practice, and we usually fix it with the plates in adults, right? So there are two common approaches which we do. One is interior Henry approach, and another is a dorsolateral Thompson approach. And this is individualized. People can use both the approaches for full length of the radius, but in a very distal third fracture, we usually, avoid dorsolateral so that the dorsal tendons are not irritated with the implant. So I'm going to take you through how do we do a dorsolateral Thompson approach for radial shaft fractures. So this was a case where a radius shaft was very much proximal fourth, right? So that we fix with the plate. So that's an usual fear by all when operating on this case. How do we handle PI and how do we, dissect it out? And so I selected the case wherein we fix in a proximal forearm. So this is my skin incision. We can mark a line between a Lister's tubercle and lateral epicondyle, and then we can use the part of the incision as per our requirement. As we cut the, see, in deliberately, I have taken a little bigger exposure so as to, make a good presentation so that other patient can be benefited. So once we, go through the skin and subcu, we find this interval. This small, flake of, say, fat tissue, which is between ECRB and extensor digitorum. So if we cannot, find that, what we can do is, if we move our fingers, then extensor digitorum will move. If we move our wrist, then ECRB would move. So that's one thing also which can be, helpful in identifying the interval. So then, once we split that part, we find a supinator mass, which is a big mass there, right? And then, while, identifying PIN, everybody, has a fear, where will the PIN be, where will the PIN be? What you do is simply roll with the finger over the supinator. Because a supinator fibers are in this direction, while the PIN is in this direction. So if you roll over at in the line of the fibers of supination, you will definitely feel something which is moving underneath your finger. So then you are sure that the PIN is there. Then you can directly actually incise over your supinator muscle fascia, and then you find it out, dissect. So that's one easy way of finding it out. So that's what we did. We found the posterior introsus now. We cut the fascia and released the muscles around that and preserved as much as branches of the posterior introsus now as much as possible. So then we reached up to the fracture.
And see, these branches are superficial branches are also kept as it is while doing this surgery. So then we fix that with the plate. We put a plate underneath the PIN. So usually we don't find that much proximal fracture. Then what we can do is we simply, while doing radius plating where we are worried about proximity of the PIN, then we supinate the forearm. While supinating forearm, this will, be away from our field. While working proximal to PIN, we need to pronate the forearm. So like, when we are fixing a radialate plate and we are worried about PIN, we pronate the forearm while we do supination of the forearm when we are fixing distal to PIN. So another case, a distal fracture, wherein which is usual, this is not a Galeazzi, but we find a Galeazzi fracture, this pattern, wherein this also approach through the dorsolateral Thompson approach, skin, subcu, and the fascia. We find the thumb muscles, abductor muscles, then we find the fracture there by cutting the fascia over the radius, which is a teres, and above if we go, then it's a supinator fascia. We gradually find the fracture hematoma, and then the distal shaft. See, while doing this dissection, we usually, use a knife and see that whatever muscles attachments in the periosteum, we don't erase from that. So we don't do a stripping of the periosteum from the bone ends, and that's how, while holding with the clamp, you look at here, see the fracture ends, the tissue is not detached, both the ends. See, what I do is go 2 centimeter away from the fracture end, put an incision with the knife, and then pass my clamps little bit distal to it. So this, all the area of the fracture which needs a healing potential is not devoid of the soft tissues around there. And that has to be pictured. That should not be a bare bone scene when we fix it. That's how it is reduced, and then it was plated sequentially. We can, see on the both the sides of the abductor muscles of the thumb, and we fix it. The problem with a distal third fracture, a dorsal plating, they often get irritation of this thumb movement and irritation, and some of the patients of distal third fracture radius comes for implant removal for irritation with the implant. And that was the case of the for the distal. And then if there is a proximal fracture, this was the case in the previous talks of those people who are there, might be a repetition. So we take this approach for a very proximal part, that's an ED split. We find the posterior introosseous now entering a radial now, becoming a posterior introosseous now there, and then we find it out, and then we pronate the arm so that it doesn't come in the way. Then we dissect out the supinator underneath, and then we find out the radial head, and that's how radial head was fixed. So what I've taken you through whole length of the radius from the radial head to the distal third. We can use this approach, a dorsolateral approach, which is a very common approach. So this was the movement for this radial head fracture. So it's a very useful approach for fixing wall length of radius. To use a Henry approach or to use a dorsolateral is an individualized choice. But yes, I use dorsolateral Thompson for most of my cases, except for a very distal fracture where I use a Henry approach. It's not a difficult approach when learned. We need to have a knowledge of the anatomy, and the care of the PIN is very much required. Thank you.
Thank you, sir. Any questions?
Yes, should I say?
So next we move on to the next presentation on fixator assisted nailing of radial and ulnar shaft by Dr. Alexander.
Dear Chairman, dear colleagues, let me share our experience in the treatment of radial ulnar shaft fractures in adults. Usually we get accustomed to use plates, but there is an alternative approach which I suppose it deserves some attention. There are some anatomical features of radius ulnar we should restore. So we have to reach the good restoration of length of shape of the bones. Important also the rotational alignment of the radius, and we have to provide enough fixation to immediate use of the arm. And as much as possible, we should avoid additional soft tissue injury. In AO online manual, we can find this description of the techniques. It looks very, very simple, but in practice, it's not so simple. We use in our practice few sorts of nail. The last time interlocked nails. Previous period was some kind of rectangular titanium nails. And the technique includes next steps. We have to apply a small wire temporary destructor, proximal ulnar and distal radius. And very important step is rotational alignment. This is done against orthopedic principles. We do reduction of proximal fragment according to distal. So we insert some kind of joystick wire into the proximal fragment. The distal part is secured in neutral rotation, and we have to rotate the proximal fragment to full supination and to go back 90 degrees, and we are in the same point of rotation as distal fragment. After that, we should apply destruction only after that step, not to mix, not to be confused with resistance of the tensioned soft tissue when we do some rotational trick. How can it be visible that we do something with rotation? After that, we perform ulnar nailing. This is straightforward. We make some canal, and sometimes we use flexible reamers or hand reamers. I usually use straight nail, despite some authors recommend to do some bending. And radial nailing, usually we use the nail which requires point of insertion, something like Lister's tubercle. There are some nails with radial styloid point of insertion. And after final length check, we perform locking. We don't see any huge incision. It's very anatomical and very low invasive. Some cases, Monteja formed ulnar nailing with some bend of the nail to perform some tension on interosseal membrane to get fixed in the position the radial head. You can see the postoperative X-rays and the result in 1 year. Elderly man, open fracture, nailing. Good anatomical result and full functional recovery. After this visit, he didn't return to us again. All elderly men, we can see the rotation and result in 1 year. Ulnar non-union after plating, straightforward nailing without any grafting, and good result immediately. It's a complicated case of infected plating. After some period of traction in the Ilizara frame, nailing was performed, and we get a good functional result, immediate, but we have symptomatic non-union after 1 year. And the patient refused to any other surgery, so finally it was healed. In last case, the patient was referred to us from another unit after radial lengthening without any bone formation. So we replaced external fixator with internal splint, and the patient successfully healed after few years. So we recommend to use fixator-assisted nailing in neutral position. The important step of reduction of rotational alignment of the radius, and we don't have to lock the nail also proximally distally, only in cases of very comminuted fractures and in cases we are not reached a good three-point fixation. Thank you for your attention. If you have any questions, please.
Yeah, Ilizaro is still a very good option for complex forearm fractures. And in spite of all the advances in nailing, plating, etc., still Ilizaro has a place in our armamentarium. What are your exact indications for these cases? What are your exact indications for using the Ilizaro and then going?
To my view, any radial ulnar shaft fracture is indication for nailing. Only for plating, open reductions, articular cases, periarticular cases with comminution of radial head, something like this. I wanted to add some words. In the industrial exhibition, I didn't see any radial biulnar nail and any kind of circular frame.
So, are you using fixator-assisted nailing in each and every radial and ulnar shaft cases?
Yes, yes, it's much easier because I had some observation of surgery without external fixator, which were done with my colleagues. It was really difficult. Many attempts to insert the nail in closed way, and every time you feel it a bit displaced, and it will be good. And in two cases, it resulted with open reduction, and in 2 cases, it resulted with application of external fixator and reduction in few minutes.
Very wonderful paper, sir. The reason why you didn't find any of the nailing systems on the stalls is possibly we do not have an access to interlocking nailings of the radius as well as ulna, number 1. Number 2, we have come up with a nail which is like, which has got a screw at one end. It's not a locked nail, but it locks at one end where you pass it from the radius as well as from the proximal ulna. We usually give a period of an above elbow plaster cast for say around 4 weeks till the fracture starts gumming up. So far as I do a lot of nailings, Dr. Gadigone, who will be speaking about it, will also be sharing his experience. We have never used an Ilizaro frame, though it's a wonderful thing what Dr. Kulkarni said. It's a wonderful armamentarium what we have right now. We have devised a table wherein, or in your regular table, you have an attachment where you can have a counter pressure and you can make small incisions. So from conventional square nailing of the radius as well as ulna, we have now a screw nail which locks at one end and it provides some sort of stability and prevents against the migration. Thank you. I appreciate it.
Yeah, but you have so many very good manufacturers here. So it looks not a big problem to establish the production of interlocked nails for radius ulna.
Hello. Yeah, one question, please. Any comment regarding the entry point of the radius nailing through the stellate process of the radius? You always go with the Lister's tubercle, making the palm of flexion. Why don't you go with the stellate process? Or just about that?
It's a good question. We have experience with such nailing, but it requires a different kind of implant.
No, we use simple.
I didn't present it because of limitation of time, but it's a different type of implant because for nail, you could see now the track of the nail is the arc. And if you insert this nail through the styloid, you immediately push the ulnar cortex of the radius.
Yeah. So we use the soft nail that's for there's a tense nail, and that takes shapes of its own and maintain the arc of the. I never use more than 2.5 mm for the radius, and now of course you go for 3.5 about that, and that maintains both the things. But I never found any problem in that about that.
I agree that there is a lot of ways to skin the cat, and we can use any nail. Our goal to provide alignment, good rotation, and stability.
And 3-point fixation also.
3-point fixation or rigid fixation, any kind. If you use this kind of implant and this kind of fracture allows you, sometimes you have only distal part and a proximal part and totally comminuted midshaft part. So you don't have a medial point, internal point of fixation. And you use locking screws on both sides. There is a lot of ways.
And one very important maneuver when you do the radius nail in this the proximal part, just supinate the forearm to get the muscle alignment and all that.
I completely disagree because I get accustomed to do any fracture of radial ulnar shaft regardless of this level in mid position. And you never have a problem with rotation. You do this trick, full supination, 90 degrees back, and you are sure that you have a rotational alignment perfectly.
Yes, sir. Thank you.
Last question.
Yeah. What do you do if you have a very narrow medullary canal and in pediatric fractures?
Yeah, it's sometimes it is difficult because there is no set ready with any needed instrument. So you have to be equipped with flexible reamer, the first part. In the second case, if you don't have any canal at all, you have prepared hand reamer. You can do it in your operating theater. You can take any K-wire, 2.5, 3 millimeter. You can put it on your hammer, and after few hammer blows on the tip, you have some kind of hand reamer which you can use it, and you can prepare fully obliterated medullary cavity.
Thank you.
Thank you. Now I invite Dr. Vikas Agashe for his talk on open and comminuted fractures of forearm.
So this was a young boy who presented 10 hours post-injury. You can see that the radius has a segmental comminuted fracture, ulna is a segmental comminuted fracture. He was treated elsewhere, and he carried a note at that time saying that he had a compound fracture ulna with closed comminuted radius with compartment syndrome, and they have done a debridement and fasciotomy. So this is how he presented, with a wound on the ulnar side which was partially sutured, and a forearm which was skin was contused and which was significantly swollen and tense on the volar side with no sensations and just about some movements. So here we are. I have a markedly comminuted radius ulna fracture with tense forearm, and on the ulnar side I have a large wound, partially sutured, practically no movements and no sensations. So this is where we are. What do I do? Any opinion? What all should we do on day one, and what all in what sequence?
Asim.
My radius seems to be length stable beside the standard things, antibiotic, Dabrima, wash, extending the incision and releasing all compartments. Forearm was tense on the volar side. I will probably use a nail for the radius. It looks length stable, so that will help ulna quite a bit. Ulna, I might span with a X-fix, which is kept temporarily, and my goal will be to have a clean wound by the end of 3-4 days, 5 days, second Dabrima. That second Dabrima, you can take a call either on the same day or in first 5 days, I need a cover, either with a split skin graft or if need be, something more. By that time, second or maybe by day 5, third OT, everything is very obvious. So much muscle has died, so much bone pieces, they have to be removed. Whether it creates a gap, I'm not bothered. I think here, radius being in comparatively good shape will help me a lot. I can bridge any ulnar gap maybe
Later.
at 2 months, 3 months. That will be the rough plan.
Thinking.
And in the meantime, a lot will depend on what's happening to his neurovascular, and, whether he's showing. But he came to you in 10 hours, that's very good.
Yes. So the question was, obviously we need to do debridement, we need to do compartment release, we need to stabilize radius and ulna. Question was, how do we and in what sequence? We thought that doing an external fixator for radius as well as ulna would not be worthwhile because it is markedly comminuted and segmental. So debridement is a absolute urgency. Stabilization is necessity in this case. So ulna appeared to be distinctly contaminated. So our thought process was like this. This is of course published much later than this, but then we decided that we will excise this wound and extend this wound. And this is what is in this book. I suggest all of you read this book. And they say that take out the word debridement. There is nothing like debridement because it doesn't tell you what to do. They say that it has to be replaced with wound excision, and for successful separation of the tissues that are contaminated and non-viable from those which are healthy, you need a surgical excision of the contaminated tissue. For that, to get access, you should have extension of that wound on both sides. So that is exactly what we did. We excised and extended. I could not really put it down on paper any time, but this is something what we have been doing for a lot of time, long time. Most important, we realized that the ulna is contaminated. Number one, there is no point in cleaning that ulna. Just take out that ulna. Number one. Number two, ulna is markedly comminuted. We need stabilization. So shorten the ulna and appropriately shorten the radius. So the first step was, of course, debridement. Though the compartment release is important, it is far more important to debride well. Now, after that, we realized that the construct was extremely unstable. And we were really scared that by opening on the volar side, the whole thing, anterior and posterior, both the wounds, the forearm would be very, very unstable. So we decided that we will slide a plate, trying to keep as much tissue attachments, and slided a plate on ulna. Here, as you notice, that the debridement had to be extremely good. I mean, it has to be, there was nothing like debridement, it was just excision of the tissues. And then we shortened it so that there was those comminuted pieces were overlapping, and this was followed by a compartment release with volar zigzag incision, and the same approach was used for fixation of the radius. So that is the volar fasciotomy that we did. Interestingly, he also had an anterior capsular tear of the elbow, which we repaired. We realized after we did a fasciotomy, we realized that there is something there. The anterior aspect of the humerus could be seen. So we repaired that. We also shortened the radius. Because we have shortened the ulna, we shortened the radius also. And that's the fixation, that's the ulna. As you can see, we have shortened, and therefore there was a lot of overlap of bones, and radius was stable. So this is ulnar shortening improved the contact area, radial shortening improved the bone-to-bone contact. Ulnar wound was closed. Fasciotomy we kept open because it was covering the radial implant. So there was no hurry to cover it. Today I would probably do a hack to decrease the size of the split thickness graft, but here the sensations recovered by 24 hours. By 10th day, the muscle started moving except flexor pollicis, and that's the large graft that we had to put. Today, as I said, VAC would definitely decrease the size of the graft. Maybe we'll use the shoelace technique, etc. But essentially, the idea was good cover for all the implants. On the ulnar side, we could cover primarily. On the radial side, we had all the muscles. So that way, no implant or fracture site was exposed. On the volar side, we did a split thickness graft, that is at 4 months. You can see all the fractures have healed. That's his function, and that's his range of movement. So it was a sort of, we were working against time because 10 hours were already lost. Rather, I mean, he came after 10 hours, but that's the usual story in any of our patients. But then we had to work, take very quick decisions. So debridement, think of excision and extension. Stabilization, of course, helps. Upper limb, the plates are definitely better. Most importantly, must get cover for implants and fracture. Compartment is an emergency, obviously, but debridement deserves priority. And lastly, of course, there are many different ways of managing this patient. There are many ways to reach Mumbai. Thank you.
Good case. The lesson learned is, even if they open fracture, you must think of compartment syndrome. The open fracture doesn't mean that there is no compartment. And the loss of sensation was due to compartment syndrome. Yes. Any questions? Comments?
Here we could. Yes. So essentially, we decided on the contamination. Especially in this case, or any open fracture, especially when the small ulnar spike comes out and goes back, and we need some stabilization. I always exercise that spike. When you are already stabilizing with a plate, that spike does not matter. And it regrows, whether in a child or adult, it would form.
Would you have used Ilitharo?
Probably. I would start with external fixator with Elizarov to get alignment and do some fasciotomy, and then after period of soft tissue closure, we would proceed with internal fixation of any kind. My logic would be a bit different.
Who had debrided very well, and we know that your debridement would be the best. Any other implant you thought instead of a plate? You got good results over a nail or something else?
So the nail would not give this kind of stability. It needed good stability. And another important thing was we could just slide it under the soft tissues. We got a very good cover for the ulnar plate. See, I felt that putting a nail would be
You had thought about it.
Sorry? Yeah, we had kept everything ready. We had external fixator ready. We had everything ready. But we thought that here our stability is very, very important. And if we, at the end of the everything, if we land up with an unstable situation, then the chances of infection would be very, very high.
Or could be a combo type of a radius plating and a ulnar nailing, because ulnar was segmental. Too many segments there. नहीं कोई थे
नहीं
अच्छा नहीं radial plate with ulna nail as a combination.
So here, the ulna was markedly comminuted.
Yeah.
With nail, it would not really give good support. So that is why we put a long plate which covered everything. 3 screws proximally. In between, we didn't put many screws, any screw. Distally, we had 3 screws. About 10, 11 hole, I think, or maybe 12 hole plate we have used. Like a bridge plate. Correct. Lens tip.
Only one concern is in open fracture, long plating would give more infection or other?
Long in the sense, here we had a middle segment which was over 3 holes. So without doing a long plate, we would not have any adequate stability. We needed at least 3 screws on each side. Then only we would get stability. Otherwise, we would not get stability. And without stability, I think this would not have got any. I mean, we needed good stability.
Right. Amit.
Sir, I wanted to add a point.
Yeah.
So I would not bother about the sensory loss at this stage. I would have done a plating and a groin flap. At primary stage, I would do good debridement, which you, sir, have done, and we all saw, sir. So, I mean, good result also. But then we would have put in a groin flap. The reason being, sir, the tendons and everything, I mean, gliding, we get a lot of hand stiffness, sir, in such injuries, because then our focus is mainly on the forearm union. So later, if there is some sensory loss persisting in after 3 months or after 6 months, and then there is some stiffness in the fingers or hand, he needs a lateral tenolysis, then doing a flap would be a better choice, sir, if any procedure needs to be planned in future. Just
So
only
you
fix and
mean
flap. Yes, sir.
you would do a primary microvascular flap?
No, sir, groin flap.
Groin flap, meaning you hold it like, keep it like.
Debridement, first stage debridement, probably a vac and fixation. Then once the tissue settles in 2-3 days, then we'll put in a flap, sir. And then we may do a future, once a sensory loss.
I mean, we just felt that we should tide over the crisis.
Correct.
Most important, just tide over the crisis. Yeah. Thank you.
Helpal. Ashutosh, trouble again.
So now we invite Dr. Amit Ajgaonkar for his talk on non-union Montagia.
This is a 12-year-old female. 12 years or 13 years is the borderline wherein, you can correct or you can get better results if you correct your deformities or if you miss out on something. So here you see, any opinions on this X-ray? Yes, sir.
The plastic
That is, yeah, exactly.
Which has to be in straight line, which is not there. And then that is what has pushed the head radius.
Now retrograde because I am presenting it. But then first time if the patient comes to you, most of us may miss it. Yeah, so look at this. So it was dislocated and there was exactly what Dr. Agache said. It was a plastic deformation. So never miss this and always keep in mind that your ulna can give a problem to you, and generally you always have to see to it that you immobilize it properly, and if not, you get a CT scan done. So at 6 weeks, this was the case post-injury. What we did was, we went ahead. In such cases, generally, if the patient comes to you in the first 2-3 months, it is said that the first year results are good if you operate. You cannot do without an osteotomy. You have to get an osteotomy done. Here we went, it's an ulnar flexion and a distraction osteotomy. Now this patient is young and around 11-12 years. So results are better at this age. If the one more case I'm going to show you, which the patient has followed with me for around 20 years, from a child to a grown-up adult. Here we did the osteotomy, and look, you have to hold like joysticks the two ends of the ulna and then distract it. Once you distract it, give slight flexion, and if your radius comes back, it's good. If your radius does not come back, you have to open the radiocapitular space. Open it, you have to remove the fibrous tissue over there, get it down. If not, even otherwise, then you have to reconstruct it by a triceps flap or a extensor carpi ulnaris flap. You have to do that. That's a must. But here, fortunately, at this is 1 month follow-up, the radius got reduced, and here this is the patient. Yeah. So now I go to another case. This is a 7-year-old boy. My case, my failure, and here, look what I did. It was an ulnar fracture. X-rays were not proper, probably. Yes. And I just plated it. I plated it with the hope that that radial head will go in. But probably the reduction, this is a very old case. Now you will come back, I'll get you newer X-rays also because the patient has grown up and my practice also grown up later. So here, this was in around 2007 or 8. And the patient came to me in 2015. By that time, he was around 17-year-old. Now look at this. 17 years, nearly an adult. How will you get it back? I did another mistake. And this, you should not do what I'm doing. I did a radial head osteotomy, radial head excision. I did a radial head excision. Even then, surprisingly, what happened is, unfortunately, I don't have that radial head excision X-ray, but the radial head regrew. It regrew in the opposite direction. And I thought I'd done it. I thought I had done it, but then the patient, look, this is at 20 years. His age was around 20 years. He came back. He came back to me after a few months with a gross valgus deformity. And he was a young adult. And it was purely a cosmetic deformity, purely a cosmetic deformity. His main problem was he could not wear half shirts. Short sleeves, half shirts. He always has to wear a full sleeve, full shirt to just cover up his deformity. And this was a very gross deformity. Yes, sir. Sir, mic. Sagana kar de.
They try to get up from chair, taking support, then they find it very, very difficult. Otherwise, they have no deformity, no problem. So that is functional.
Yeah, exactly. That is not the problem. I told you the problem was cosmesis. So he was very, very unhappy. But he came back to me only. I said, what to do now? I did a very, very unfortunate that I've lost a few slides here. I did a CT scan. I did a 3D bone model. I sent him to Mangal Pariyar. Mangal said, 3D kar le. After doing the 3D, I sent it back to Mangal. Then he said, it's very difficult. You can't do an osteotomy and a flexion osteotomy here. We'll have to study it. Then we both studied the X-rays, the 3D model, and then we decided that he will require an extension osteotomy here. And we did the osteotomy. I did the osteotomy on the model, on the 3D model. And surprisingly, his varus was corrected and his movements were relatively okay. I primed him a lot of times. He literally has come to me as an adult of 20-21 years for around 10-15 times. I told him that, look, you may not get the full range of movements. We are doing this for a cosmetic effect to correct your valgus. And the full range of movements may not be there. I am not going to reduce the the radial head dislocation. So then what I did was this. This was an extension osteotomy of the proximal end of the ulna. Here. By that time, he had grown a year. And then he came back to me later. After 1 more year, he asked me, I don't want the implants removed. Yes, I removed the implants. And this is the final follow-up. This is he has grown up to a 25-26-year-old man from a 7-year-old child. And he's happy with whatever he has. It's a straight hand. He's working in a bank and he's happily going to get married.
Good.
Thank you.
You should have shown the 3D.
I know.
3D.
I really am sorry. In the 3D
That would have
bone models I've got.
bone
There is a lot
model.
of facility over here, at least, to get, once you do a CT scan, you can get 3D bone models. And on a 3D bone model, such cases, we need to study and we need to know. We need to operate first on the 3D model and see how you can correct your deformities.
It's
On the, yes, I had old plates. I had old plates in the OT. Implant removal plates you keep in the OT, na? So I used the plates on the model.
Now, what I want to know is before this surgery.
Before this surgery
did
only.
you bend a plate which you are going to use so that that becomes a mold?
No. I used an old plate on the bone model. I bent it. I saw the movements, range of movements. And then inside the theater, I knew how much I had to bend.
That was the template.
Yeah, that was a template.
Amit, you did
Sir.
the osteotomy in the first instance pretty lower down. It can be done about an inch above the level you did.
In the first case.
First time. This
Yeah,
was second.
yeah. It can be. Correct. Any more questions?
Yeah.
Yeah.
The case comes primarily to us, like we have missed the radial head, and then it comes. Many times we do the osteotomy, it comes intraoperative, and again post-operative it slips off.
Yeah.
It is a very stressful situation.
So-
The patient's parents will be like on us. Any, as in, do you do the opening of the radial head and doing some repair or a sling procedure?
Yes. After going back this experience throughout my life of operating, I think such cases should be followed radiologically very well, doing the x-rays properly. And if at all the radial head is slipping out, you have to correct it by debriding that radiocapillary joint and if need be, a sling from the triceps or from the extensor carpialis.
Can I answer that? I have done quite a few of them.
Yes.
Yeah.
Sir.
So,
थोड़ा mic के पास आइए sir.
you ought to achieve stability on table. What he is describing is that surgeon failed on the table. So that means your angulation is not enough, your distraction is not enough. And on the top of that, what you are saying that if it is required, then you have to open
Probably
remove
that-
the superior radioulnar joint.
Yeah.
And
My,
stabilize.
in this last second case, probably I thought my reduction and plating was not good enough. And that's the reason. And I missed that radial head dislocation.
And
And
general
patient also did
tendency
not follow
of
up.
most people, if it's popping out, is to keep it reduced with the thumb and pass a capituloradial wire. That is the worst thing you can do because the moment you take out the wire, it will
Go back.
So just as a piece of information, this was published in CRR by Dr. S.D. Mehta almost 42 years ago. And that time there were no plates. So he had used a bone graft as a stability and of course plaster, but had fantastic results. So I think please, how to do an osteotomy, where to do osteotomy was given very well.
Sure. Thank you.
Yeah, 1 minute.
And the Ganga people, they have published a Z osteotomy. They stabilize it with a interfrag screw.
Yeah.
Correct. Thank you so much.
3D construction is a very good method of this.
Absolutely.
It is not very costly. All complex
It is not
fractures,
costly.
dislocations should be done 3D constructions.
Yeah.
It is not costly. The machine itself costs about 2 to 3 lakhs rupees, and the patient costs hardly 5 or 600 rupees. That's the only thing. So it's a very good method, and we should use it. I have one, and since then it has given me a lot of help. All complex fractures should be 3D construction should be done. Yes.
Put on the first slide. Yeah.
Go ahead.
It's quite interesting. He is pretty young patient, almost 130 kg. Sardarji, grade 3 compound side swipe injury. We don't see them very often nowadays with AC cars. 3 days old, primarily supposedly washed at a district place at another hospital. And this is the type of stitch wound he initially came to me. Everybody will get a CT scan. You think it will give some information?
Yes, sir.
How do we go about it? Agasha sir, your baby. Yes.
Yes, yes.
So, those stitch wounds have to be excised, explored. It is quite likely that many pieces would be loose. Whatever is loose comes off. Whatever is loose comes off. The articular surfaces which are intact or even loose. I am talking about metaphyseal pieces and articular.
This is the CT.
Yeah.
Here is the
So
CT.
the articular
He
pieces
came
we
with.
should try and salvage, but the metaphyseal pieces we should take out. We should think about what is likely to happen or what we are going to do for next at least 7-8 days. So the first step, of course, would be a very, very thorough debridement. And maybe if it is far too unstable, I would put a humerus and distal ulna
My next question. This is the X-ray. You will do the humerus shaft first, or you will handle the elbow and leave the humerus for?
My thinking would be the open wound has to be addressed first. Humerus is closed.
Yeah.
Sorry, I will not bother about humerus first. I will first debride the wound very well, take out whatever is infected, and then I'll try and have a construct for humerus, one part, with 2 pins above, 2 pins below, with a connected by a rod to rod clamp, and distally ulna with 2 pins, so that I have a construct like this.
Okay. I agree that humerus being closed, but my fear was that if I want to do anything, I need a stable proximal segment. And if it was delayed for 3 hours, 3 days, 2 hours more doesn't make a difference. So, and this was a very, very long surgery, almost 13 hours of OT time, done under continuous brachial. We handled the shaft first, supine position at deltopectoral, standard thing, fracture reduced and plated with a fairly long plate, keeping in mind that I had to get my implant for the distal humerus also. Then we flipped the patient, posterior approach, and we now was just sitting there. And these were the many pieces Dr. Agashe was talking about. All this chura was there everywhere, intraarticular as well as the metaphyseal. So, how do we proceed now? You want to save the joint? Okay. One important tip is that in this patient, you will have to start reconstructing distal to proximal now. So, start at the ulnar metaphysis, go on building up, and you will have to reconstruct the coronoid first. Because if you don't do that, once you do anything to distal humerus, you will not be able to see anything. So, this is how we started building up, and now you are seeing some semblance of superior radioulnar joint there, and olecranon, of course, was fractured, so there was a natural olecranon osteotomy there, plenty of thin K wires there, and then we started reconstructing the joint. So, this is how we went about putting back the articular pieces. You are seeing more sanity there now. You can see the ulnar notch, superior radioulnar joint, head radius sitting nicely in its place. Fortunately, that wasn't fractured, and that is when we brought in the first plates. Ji sir, there are 4-5 people, it's like Rubik cube, telling me trochlea can go like this can go like this, capitulum, of course, the lateral column looks fine. Basic idea is you get the trochlear, this thing, I'm doing that. Joystick here, something here, trying to match the surface so that I can have Damru there.
what his point was,
Yeah.
was humorous को अल्लाह में नहीं लाना और अल्लाह को humorous में.
देखो देखो अभी जादू. I have got a 3-year follow-up. So, with lot of courage, I did not throw away all these loose pieces, even though they were metaphysical. Some of them are quite big, and I just cleaned them and put them back. So, here I am. This is my first plate, comparatively less comminuted column. I restored the length, rotation, and used that as further foundation for my more hardware, and then came the medial plate. So now you can see that there are lots of K-wires and 2 plates, and you can see the nice good trochlear reconstruction, and it looks fairly decent. It looks like a normal, though there is some void here. Fine. These are the various pictures. You can see nice congruous joint there. Superior radial nerve looks fine. And day 1 post-op. So I got the X-ray in the department and I panicked. Now what do I do? This certainly doesn't look good. No, sir. I did not sleep over it. So this is how my wound was, anterior, posterior. Day 3, I knew that I'll do that. So second day I got the X-ray, but unless you extend the elbow, you cannot get a good CT scan. So I told him that we'll do a CT scan and then shift you. We'll give you a brachial, do a CT scan department, format the images there and there only, and shift to OT for secondary debridement. So here is the CT. So there is lot of good news. My ulnar doesn't look bad. This congruity looks good. Here I am okay. This is metaphysical piece, sort of medial condyle column, which has rotated. It's not held by anything. Or it slipped. I don't know. On table, I felt that I have got purchase in this. So everything was kept ready. These are the 3D images. Probably this piece I could hold with some screws initially, but then finally it gave way. So at the time of second debridement, we rotated it. Joint is good. So we brought in another anteromedial type of plate there. Clamped it and then legged it. So here I am, comparatively far better position. And here also, I am absolutely ruthless in mobilizing them. With this type of injury, I am just giving him moral support, and he could do almost 10 to 90 on day 5. And his wounds, they looked all okay. Good pronosupination. Day 10, his ulnar tip, elbow tip, that wound showed some serosanguinous discharge. Dressing was getting soaked. I wasn't happy. So I told him, look, we have to debride it again. We sent the culture. Fortunately, I grew, I think, MSSA. Vancomycin was used along with, stimulant was used with vancomycin. Oral antibiotics continued for almost 6 weeks after 10 days of IV. That is day 30 X-ray. 2 months, here I am. 3 months, I asked Dr. Tanna also, how do I assess union in this? He said that hardware will start failing at some stage, that will tell you. So I never wanted to wait till that time. So he became a friend by that time. So at some stage I convinced him that boss isko graft karne ka. So 9 months post-op, he was back to job, action required. So at some stage we convinced him, 11 months. This grafting for the humerus shaft as well as, because he used to complain of pain there. I was very confident that humerus at least will unite. But he used to complain. So we took a long posterior approach, which Dr. Trikha was teaching us other day, and grafted humerus as well as the distal humerus as well as the shaft humerus, both. I thought that ab jaan chhoot jayega. 14 months. And he used to complain of some pain and discomfort. So I was not happy. Again cajoled him. And this time, After around say nearly 2 years, just before 2 years, I removed part of the hardware because those things had completely healed. And once I removed that anteromedial plate, I could find out the gap which was not healing actually because there was so much of plate. So 2 years, second bone grafting. This is, I think, after 3 months of the second bone grafting, you can still see that fracture is not united. He comes at 3 to 6 months interval. This is 3 years. That is his range of motion. Now, probably the fracture is united. His pain is gone away. He doesn't need any back to job. And this is the type of range he has got. Same 10 to almost 90, 95, full pronosupination. Chalvai. Or back to, he can lift weights and do almost everything. So, no neurovascular.
Good.
Yes, sir.
Good, good.
Yes.
Good work.
Thank you.
Very nice.
Actually, sir, I cheated when you showed, Agasha sir, when you showed me, Agasha sir, when you showed your patient, I am extremely passionate about putting plate in compound fractures. I don't use nail at all. But I think that was a further.
So just a suggestion, anytime you have tried to salvage an implant with infection, when you go in, you realize there is infection, you give a wash and then you want to retain it, especially with staphylococci, use of rifampicin is very good.
Yes.
So that is a biofilm active antibiotic. So rifampicin.
Rifa and Cipro. These are two.
Cipro for negative and
Yeah.
rifampicin for positive. To be started only after 10 days.
Yeah, when bacterial load is comparatively less.
Sorry, I missed the beginning of the case, so I apologize for that. But I still don't understand how you missed the medial condyle altogether.
No, it wasn't missed, sir. On table, it was held, but at some stage when I started mobilizing, because the grip was not
But
good.
even the immediate post-op X-ray shows it
Probably.
off the medial epicondyle.
Probably.
Yeah.
You can understand, 12, 13 hours of torture.
Okay. Yeah.
5, 6 people working.
I missed how much, what else?
And patient is like this. He is still like this.
Karan, come.
So, sir, Vikas sir, we do the same wound excision as debridement, but sir, we use loop magnification. So we have debrided like few pelviacetabular cases where there was a lot of infection, 5-6 plates inside, sir. So we are like mentally prepared, 3-4 hours ka job hai, and then we go there. We do repeatedly, like even a single molecule is not left. Like we do so like meticulous, and at the end then we take photographs and everything, and then by antibiotic cover we can salvage the implants, or we have salvaged implants.
Yes. Rifampicin is a biofilm active antibiotic, and once you decide to salvage the implant with staphylococci, then rifampicin is useful. With a gram-negative bug, ciprofloxacin is useful. So, you have already decided to salvage the implant.
Sir, regarding this case, actually, regarding the metaphyseal comminution, so actually there is a technique we can do a shortening osteotomy of distal humerus and create a fossa, olecranon fossa. That can be done in this case because you had a metaphyseal void and the fragments are very small and they are all avascular.
No, they were not small. The metaphyseal
In the sense,
pieces were
very, 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 very small, and they tried to pack it up back.
the smaller ones were probably not used. The larger ones where I could put a leg screw. There were 2 mm and 2.7 multiple leg screws to build up that. And there is a limit to shortening. I have done shortening in cold cases when treating non-unions. But those are different situations. Here, if you start shortening, you will not be able to match anything. Yeah.
Last question.
Yeah, Dr. Negi, it was a very wonderful case.
Thank you, sir.
Just as you learned many things, we learned many things. We found a remarkable similarity whenever we have an ipsilateral shaft as well as proximal femur fracture. The same way this also seems to have been behaving, because you had to use a bone grafting for 2 sides. The humerus
and I take them from posterior acrus. I don't take them from. I've forgotten to take graft from the anterior acrus.
Yes.
Finish.
You need plenty of grafts, so posterior is the best. Thank you.
Vasudev.
First one was 9 months, around 9 months. and the second bone grafting was just before 2 years.
But with the plates there, you just put a graft over there.
None.
Or shingling or SOPM.
पैराट्रांसपीटल से खोल करके और फिर जगह ढूंढ करके जहाँ वो करा था lot of
You just put the graft inside.
yeah scrap and pack it with cancellous graft from posterior lattice कटोरा भर करके. But first grafting wasn't probably enough because the plate was obstructing my view. So when I went second time, I took out one plate and then I could see कि क्यों पेन होता रहता है इसको और क्यों ये आगे पीछे फेल हो जाता. And that time I removed lots of plates which were not required anymore.
Negi, one question. Yeah. So in the first surgery, why did you go anterior for the humerus? Couldn't you go posteriorly?
Yeah, we could go, but I knew that I got very long, tedious surgery, so I wanted to do a quick job on something which I am very familiar rather than doing a Garvin type of thing which I will do once in 5 years. So,
Thank you.
Yeah.
Thank you, sir. Now I invite Dr. Vasudev Gadigone for relive surgery on forearm nailing.
Kneeling in adult forearm fractures. For forearm fractures, intramedullary fixation was proposed by many authors. Nail provides relative stability, micromotion between bone and implant which result into union with callus formation. A new concept in the treatment of forearm fracture with screw intramedullary nail. And these are the instrumentation: straight owl, curved owl, 3.5 mm screwdriver. These are the screw intramedullary nail of various length and sizes. And this is the screw intramedullary nail holder. So these are the only basic instruments required. Now this is the example, a displaced forearm fracture in a 40-year male. Such unstable fracture, anybody will think of doing a plating or as a guest suggested, a interlocking nailing of a radiation ulna. So I will try to tell you how simplified intramedullary nailing can be done in a such a unstable diaphyseal fracture of the forearm. Assessment of the length and diameter is most important before you start surgery, because that is the crux. Otherwise, we may fail in negotiating the nail and fracture propagation may occur. So length and diameter is most important. These are the methods. You can use a forearm distractor or a manual traction to reduce the fracture. Close reduction by manual traction are used by longitudinal traction and direct pressure at the fracture site. I use elbow counter post, which keeps our arm and forearm in a 90 degrees so that I can easily pass a ulna nail. We can do supination and pronation to align the fracture fragment and manual pressure over the displaced fragment. We can also separate the interosseous space by putting a thumb between the ulna and radius. This maneuver majority of the time reduces the fracture. In majority, manual traction is successful, but sometimes you can use a percutaneous K-wire assisted reduction, and it aligns the fracture fragment, and it's mostly the successful method to bring back the fragment together. However, 10 to 15% may require a mini open reduction to reduce the fracture. Ulna nail entry at the tip of the olecranon with the help of a Steinmann pin or a bone. I use first a 4 mm Steinmann pin, and then the entry point is dilated with a straight hole for ulna so that it will accommodate the screw portion of the intramedullary nail. Reaming of the canal of the ulna and is done. Usually for ulna, you must have at least a 3 mm screw intramedullary male. If you pass 2.5 or 2 mm, probably the bending and breakage of the nail may occur and it will produce an unstable construct. Insert the nail near the fracture site and manipulate the reduction under fluoroscopic control. Again, you can take the help of the K-wire as here to align the fracture fragment and rotational movement to bring back the bony surfaces. Screw nail is inserted. The last thread of the spiral should be located 3 to 4 spirals want to make the implant removal easier because we should be able to identify the entry point of the nail. Nail should be in the subchondral bone of both radius and ulna so that it maintains the length of the radius. Unless you put the nail inside in the subchondral solid bone, in the medullary canal, if there is a short nail, you will have a rotational movement and also a segmental compression, or you can say there will be a shortening can occur. Radius nail entry, it is at the window through the radial styloid between the tendon of extensor carpi radialis longus and extensor pollicis brevis. A small incision is given up near about half a centimeter dorsoradial side of the distal radius. Incision is dilated till bone to prevent injury to the radial nerve, because that your dilatation of that incision should go by a artery process till you reach to the bone. And curved bone hole is inserted so that that space is occupied by a radius nail. And we must be aware of during this insertion of the nail, an injury to the radial nerve may occur. And therefore, a constant awareness of the course of the radial nerve is most important. Radius nail bending is done to match the curvature of the radius. Unless you give a bending is done of a nailing of a radius, after putting the nail from the radial styloid, it will hit opposite to the radialis cortex and probably will not be able to negotiate the nail. Therefore, till it reaches to the fracture site, you have to pass a bend nail. So reduction, sometime isthmus rimming of radius is required. You will find the canal is sufficient in diaphysis, but in the radius isthmus, probably you may get a narrowest portion. Therefore, you must do a rimming of the radius, not always, but sometime. Insertion of the nail. Nail was advanced with a smooth oscillating movement until the tip reaches in the subchondral bone. Rimmed nail in ulna and mostly a unribbed nail in radius. Traction release. Nail forwarding. The tip of the nail should be situated distal to the radial head without penetrating the joint. The last thread of the spiral should be located outside the bone to make the removal of the implant easier. And if there is some distraction remains, that the fracture should be compressed by manual compression, and you must check elbow and wrist for prominence of your nail. Above elbow slab is given for 4 to 6 weeks depending on the stability of your construct. This is a fracture of the mid diaphysis with a oblique unstable type of a fracture. I don't disagree that the plating is the gold standard teaching in the forearm fracture of such an unstable nature. I did a close intramedullary nailing with a K-wire assisted reduction, traction, reduction, reamed nailing of ulna first. And then you can see as soon as I reduced the fracture and put a ulna nail, restoration of a length. So naturally there was an alignment of the radius with a restoration of a radial bone. But after inserting a nail, fracture, especially in a distal third, because of the mismatch in the canal, you will find there is a translation of the fracture fragment. And that translation can be corrected very smartly by putting a smaller size nail, and you can see how the translation is corrected, and that nail will obliterate the canal of the radius, and it will have a stable fixation with a perfect anatomical restoration. A final picture of the same patient, you can see all parameters on an unstable fracture like this are restored, final fixation, minimal invasive surgery. This is a case example, a follow-up X-ray of the same patient, and you can see subsequent follow-up minimal invasive surgery, and this is the X-ray of a removal of a above elbow cast after 4 weeks. There is a complete restoration of a radial bow and also the parameters which are responsible for the inferior radioulnar joint restriction. This is an unstable fracture with a very wide medullary canal. Disparity in a canal, stack nailing is advised. You can use it for radius, for ulna, or both. And in this case, you can see here, for radius, there is a stack nailing with a smaller size nail and diameter, and restoration of the radial bow, minimal invasive surgery. In osteoporotic wide canal in an old lady, if more than 3 mm nail is required, how to obtain a stability? Stack nailing is the answer, and how the stack nailing produces a stability, and you can see on this video, it is going along with the principal nail, achieves a correction of the translation and stable fixation. Entry lateral to the Lister tubercle is also described. The second tunnel with the help of a bone wall you can try. This is an example, but I practice a styloid process entry point, but I have no objection if somebody is doing it.
Sir? Time is over.
Yes, sir. Okay. So this is an segmental fracture. You can see done by closed method. Implant stress sharing behavior which lead to secondary periosteal college formation and prevents refracture. Such a distal comminuted fracture. In a comminuted fractures also, there is no contraindication to the nailing which is described in the books. If you maintain the length, rotation, and stability. Plaster causes permanent cyst is a myth. Uninjured joint never gets stiff if immobilized up to 6 weeks in any form of a splint or plaster, and this is a general observation. Some terminal range may be a loss spatially supination of forearm, but the majority work which can be performed without a full supination over a period of time that compensates. How compensation occurs, that is how it is at the elbow and at the shoulder. This is depicted in the model, and therefore some restricted movement never complained by the patient. So in conclusion, intramedullary nailing of adult forearm diaphyseal fracture appears to be a good alternative to the plate osteosynthesis with shorter operation time, lower complication rate as compared to the ORIF. Very few articles are published because people are very apprehensive about nailing. But I feel you make a decision tomorrow to do a fracture both bone forearm by intramedullary nailing. Thank you very much.
Thank you, sir. Now we move on to the next talk by Dr. Arshad Argid.
I have a case, and Amit, probably it's just an extension of what you showed. You landed up with a reasonably good result. I did not. So it's a complication which happened when I did this kind of case. It's probably a twin of what patient had come to you. So this guy had a Monteggia dislocation when he was 17 years old. Ulna was plated. I don't know what happened to the Monteggia. We have no records of that. 2 years after the surgery, he had a fall and some deformity in the forearm, but he was functionally okay, so he carried on. And after 12 years, he decided that his forearm was giving him more trouble. He had some kind of difficulty in his daily activities, so he decided to come to Cooper Hospital, where I work. He's a driver by profession. For the last 12 years, he's been driving with some restriction of movement of the elbow, but reasonably good. So this is the picture he came to us with. Now he's 12 years post-injury. He's got a broken implant. He's got a radial head which is way out of place. And he's got a deformity. And he wants a correction. I can show you the relevant CTs, but I think the X-rays are informative enough. The CTs won't add much to my knowledge as to what is to be done. The case is open to the esteemed panel for discussion. Amit, what would you have done for this? Because this is more or less like the case which you had showed us. Only now it's 12 years old and he's been ignored. I mean, he has ignored himself for the last 12 years.
The particular case where I had also done the 3D models. I think you should do the...
We are short of time. Yeah, we are...
Go ahead. All right. So my issues were very obvious. The radial head is completely off. It is large in size, plus he's got a broken implant and a deformed Monteggia. And the ulna is not only deformed, it is kind of plastic deformed. There is no normal anatomy. Even if I, put everything back in place, I know I'm going to have trouble as far as putting the ulna in shape. Plus, in order to get the radial head down, I would have to put a distractor and gap at the ulna. And getting it all down is not going to be easy. And I was, of course, worried about the posterior interosseous nerve palsy, which is very likely because this is a 12-year-old shortened forearm. And that's the CT, again, not very relevant. He had reasonable function, but he still wanted something to be done. And I sent him back 3 or 4 times, but he came back again and again with, get something done for me. So I was brave enough and I did what I could do. I did the posterior subcutaneous approach for the ulna, and the radius I opened with a separate Cocker's approach, and try as I might, I just couldn't get the radial head down. I put a distractor, I distracted the fracture site, I excised the radial head finally, just in order to get it back in place. I used that as a spacer for my ulna, but again it wouldn't stay because the ulna was so badly deformed that getting anatomic reduction was nearly impossible. At the end of the day, I landed up in this kind of a situation where the radial head, the radius is not perfectly back in place. The ulna is reasonably good, and my worst fear is that his radial, this posterior interosseous nerve has palsy now. Though the nerve was nowhere in my surgical field, probably it's just the traction which was giving rise to this kind of issue. So anybody having experience with this case? Yes. So we need some opinions on this. Yeah. Please. All right. So
shorten both, and then only you will be able to.
Yeah. So
don't worry about the length.
So
Gradual distraction before
of the ulna. So remove the implant, distract it, and then the
pre-operatively, and then do shortening of both.
All right. So left alone, this is what happens over a period of time. The lateral side get resolved, and as Amit has shown, the elbow does go into valgus. This is the only case where I could get some internet reference as to what happens in an untreated adult Monteggia. We all know what is to be done in children. but there are no reports of an adult old unreduced dislocated Montegia which I could find. Neglected Montegia in adult when he has an injury in an adult is known, but not when he has an injury in the pediatric case. Distraction is a good option. Shortening, I couldn't find references of shortening for radius, but they were shortening, distraction of the ulna and getting the radial head back in place. I couldn't find references for excision of the radial head and shortening of the radius also. Thank you very much.
Yeah, thank you.
So good evening. To end this session, let's summarize the clinical evidence related to the forearm fractures. So forearm fractures. So when we talk about forearm fractures, we need to know about the type and type of injury, mechanism, force, and they are treated as articular fractures. And as we know, it needs anatomical reduction to avoid angular and rotational malunions. So there are also, you have to assess a lot of associated injuries, and immediate post-op rehab is very important to achieve range of motion, and it needs rigid fixation to allow this. So good preoperative planning is required. So when we talk about fixator assisted nailing, so we have seen it's a minimally invasive procedure, a simple procedure, and probably a very easily reproducible technique. But it is mainly used as per literature in fractures like segmental fractures where there is a soft tissue soft tissue injuries there. So it's a good technique to be used in cases where you need to stabilize the intercalary fragment to prevent the axial rotation and minimize the damage to the periosteum. So fixator assisted nailing is an option when you think of segmental fractures with soft tissue injuries. In cases of open and comminuted fractures, initial management, as Dr. Agashi has mentioned again and again, that is irrigation and debridement. And in cases of all type 3 fractures, it is better you do it in 24 hours. And in all type 3B and 3C fractures, it should be done in less than 12 hours. So thorough debridement of devitalized tissues and removal of bone fragments without soft tissue attachments is the critical in the result. So as soon as you get early soft tissue coverage, that is very critical, and then you have to handle the critical bone loss. It can be handled by using the masculine technique or using some bone flaps or bone transfers and distraction osteogenesis, and as the last option you can even think of shortening. Now, one of the commonly used technique nowadays is VAC assisted closures. It helps you in stabilizing the wound, reduces the edema and bacterial load, and also gives you good angiogenesis. So it improves the possibility of primary closure of the wounds. So in cases of, again, we have discussed Montegia fracture non-unions. So Montegia fractures are almost 1 or 2% of all forearm fractures, and they are considered very unstable fractures and they require intervention. And operative management is, in almost all cases, is very crucial. And it has a more higher rate of non-union as compared to other forearm fractures. So Montegia fractures to be taken care of very critically, you have to plan it well, because the non-unions are usually atrophic type of non-unions, and they are usually associated with following factors. Either the patient is non-compliant, inadequate surgical techniques or inadequate surgical plannings, some complex injury patterns, and if you are dealing with a posterior Montegia fracture, then probably you have more rates of non-unions. And in cases of posterior Montegia fractures, the inadequate preoperative planning, like medial or lateral plates, inadequate screws in the proximal fragments, and ignored radial head dislocations or fractures are the major causes of posterior Montegia non-union. So it is very important when you are dealing with a posterior Montegia fracture dislocation is to debride the fracture site and use contoured olecranon plates on the posterior surface. Achieving a good bone contact is very crucial, and orthogonal screws in the proximal fragment can give you a better fixation. And if in some cases, if you find their distal fragments are very small, you can even excise it and meticulously reconstruct the triceps tendon. And in such Montegia non-unions in elderly patients or in osteoporotic patients, you can even think of an option of total elbow replacement, or in cases of radial head fractures, you can think of radial head replacements also. And one of the case that we discussed with a floating elbow injury, which is a very complex and rare injury with a unpredictable outcome. And these are the fractures where you have concomitant humeral as well as forearm shaft fractures, and it needs surgical stabilization as soon as possible. So if you see the prognostic classification of DITSOIs, so type 3 fractures are usually prognostically very bad and have very poor outcomes. When there are poor functional outcomes, when there is an intra-articular involvement on the both sides of the fracture, if you have any neurological injuries, and if you rarely when you think of any non-operative management in such fractures. So in floating elbow injuries, usually you have associated soft tissue problems as well. So you have to plan the soft tissue management it's a very crucial part of management of floating elbows, and open reduction and internal fixation should be undertaken. It is very crucial and it should be done as soon as possible according to the appropriate time of fixation. Thank you. So we come to the end of this session. Now we move on to the next session. Distal radius and wrist controversies. So I invite Dr. John Mukhopadhyay, Abhijit Vaigaonkar and Dr. Warrior to the stage.
So we're going to start with the last session of the day, and I think I can see Sudhir just walking into the hall. And the first speaker is going to be Dr. Ashutosh Apte. He's going to show a real-life surgery, volar approach for distal radius. So over to you, Ashutosh.
Yeah. Thank you, sir. And I speaking over here in front of Dr. Sudhir Warrior is like teaching Dr. Kohli and Tendulkar how to bat. So please excuse me for anything which happens over here, but that's my way. So let's move ahead. I'll just proceed. Before starting, what I usually do is I usually do it in Bayer's block or a supraclavicular block. Before starting, I mark the FCR tendon, I mark the radial artery, and then I proceed ahead. This is an incision supposedly to be on FCR tendon. In lean and thin patients, it is usually correct. Sometimes it just deviates. That is the FCR tendon which you can see. That is the FCR tendon which you can see over there. There is a fascia just above the FCR tendon. We need to incise that fascia. As we incise that, we are able to open the FCR tendon. Yeah, that is the FCR tendon. Just besides it is the palmaris longus on the ulnar side of it, and on the radial side of it is the radial artery. Yeah, there you can see the FCR tendon. This is the palmaris longus, which I am just placing it or retracting it by my retractor. You can be tempted to go in between the two, but there is a nerve in between. So it is always better to go in between FCR and the radial artery. As we proceed ahead, this particular thing, usually I am in a habit of poking my finger over there proximally so that I can just separate out the muscle over there. This is a deep fascia just underneath the FCR tendon. As I incise this fascia, I'll be able to see the quadratus, pronator quadratus over there. That is the proximal end from where I just begin my approach. There's a small accessory nerve you can see over there. Underneath my finger, you'll be able to see as I remove my finger over there, I retracted it. That's it. That's a small accessory nerve. I just retracted it and went ahead. That's it. And it was away from my sight now. That is the pronator quadratus. Warrior sir, I am sorry for any misdeeds over there. Huh? You and please excuse me for that.
I'll pull you up, don't worry.
Yeah. That is the pronator quadratus, which I have exposed now. I am going towards the watershed line. This is the crab bandage, that is the hand part. There somewhere is the watershed line. There. Now I'll use a sponge or a artery just to separate out the soft tissue and to have a clear look of the pronator quadratus over here. Now that's the pronator quadratus. You can very well appreciate that. I'll give a L-shaped incision over there, a vertical limb and a horizontal limb. Horizontal limb at or just proximal to the watershed line. I am usually in a habit of using 2 digits while doing that so that my incision should not deviate here and there. That's my habit. That's a vertical limb of the incision which I am cutting the pronator quadratus. That is the junction of the vertical and the horizontal limb. I'll just separate it out. Now the best way out is to use a sponge in an artery or covering the periosteum elevator with the sponge. I try and expose the fracture site and the radius. I'll just rub it over there a bit so that you'll be able to see the bone clearly. That is the fracture site and that's that horizontal limb over there. You will be able to see it after a bit, after some time. Yeah, that's the fracture line. Prior to giving an incision, I had reduced the fracture. It's not removing the periosteum, it is just clearing the bone of the soft tissues so that I can glide my plate submuscularly over the bone underneath the muscle. Or else I usually have, that's my story, that I usually struggle if I don't make a space of creating a space over there proximally as well as distally. Especially on the radial side, the limb of the plate goes on the radial side. I need to fix the styloid, so I need to have a space over there. There are 2 different types of plates over there. A titanium plate usually is a very good plate. It is thin, but sometimes we need to go in with a stainless steel plate, which are somewhat shabby. Indian stainless steel plates, they are really shabby using it. Here I had to use that only. So whenever you feel that I need to proceed further, just let me know.
You have
Indian
a-
plates are shabby, you talked about.
They're very thick,
We-
basically, rather than shabby.
They make lovely copies.
Yeah, yeah, but the thinness, yeah.
Amit, you're making them?
So while you're still presenting the paper, the video, just a quick question: do you always prefer to sit in the axilla of the patient or towards the head and the end of the patient? I would like to ask the same question to John sir as well as Sudhir sir. Sir.
I usually, so from my habit is, I usually, no, I say, stand on the head side of the patient. That's my habit. I'm more comfortable with that.
Right, because so this is the head side or is it the axilla? Say in this video here.
It is usually, there are two things. On the right, if at all I am on the left side, I usually stand on the head side. If at all it is on the right side, I go on the axillary
Axillary
side.
side.
Say, being a right hander, that becomes easier for me. And I'm always worried about the nerve over there and the radial artery over there.
The reason I ask this question is because you're retracting everything ulnawards.
Yeah.
The proximal fragment is usually pronated.
Correct.
So to correct that rotational deformity of the proximal fragment, as well as to be able to better visualize the ulnar corner of the radius, I always find whether it's the left or the right side to be at the head end of the patient. Just a question. So at the head
On
end.
the radial side, so
Yeah.
that's automatically the head.
So visualization becomes a little
Correct.
easier.
I'll just move it a bit forward. Is end of it now. Regarding the plate, if at all it is an extra articular fracture, I'm usually in a habit of putting, while using a locking plate, I'm in a habit of putting or using a kickstand screw. I use a 12 millimeter screw, fix it on a plate outside the body of the patient, fix it towards the most proximal hole of the plate. That reduction I have already achieved. Any remnant reduction, usually the thing is, we usually get a reduction which is a neutral reduction rather than getting a 10 degree volar tilt. So this particular screw of 12 millimeters acts as a kickstand. I fix, if at all the bone is better, I fix the distal fragment first with all 3 or 4 locking screws, and then placing the plate exactly on the bone, I remove that, I drill the oblong hole over there first, put a screw, then I don't thread it completely. I remove the 12 millimeter screw which I have used as a kickstand screw. I drill a hole into that, and then alternately I go on tightening both the screws so I can achieve the remaining 10% angulation over there. That's usually a habit, but that is in extra articular fractures only. Here you won't be able to see that. Pardon me?
Distal radius do you think?
Yeah, mostly. I'll just proceed further.
So what would you do differently, Amit?
An extended Henry's. An extended Henry's. Because here if I have to plate the radial plate on the radial side, it's very difficult to do a radial plating from here. It's very difficult to do a brachioradialis release. I would do an extended Henry's. All fractures.
So
Get a better exposure.
Brachioradialis release as such is a very easy procedure by this approach. This was taught to us by Dr. Vayagorkar himself in a cadaveric course. What he mentioned is the same approach. We need not release the complete thing. There are multiple attachments of brachioradialis. You can very well expose those.
I have not done this, but I'm just asking you. Can you plate the put a radial plate also on that?
Pardon me?
Radial styloid plate.
Yeah, no,
Can you do
I
it
can
with this
go with this
incision?
approach, but I have not done it in this case. The topic was
not
just
in
a
this
volar
case.
approach. Yeah.
Whenever it's needed.
Yeah.
With this approach, is it easy?
Yes, it goes.
And I think one more thing, that transient fibrous zone should be removed because you have to see that watershed line.
Right. That's the plate. Then after doing that, usually I take 3 X-rays. This is the AP view, a dead lateral view with 10 degree of flexion or lifting it 10 degrees away from the table, and third is a tangential view. I need to confirm whether my screws have gone dorsally or not, whether they are coming out on the dorsal aspect. So I go ahead with a tangential view. No, they should not. So basically keeping the hand in flexed position. I'll show it in the C-arm. It is there. It is the last picture which is there. Yeah, this is the tangential view. Basically, you can see the screws over there, not coming out from the dorsal aspect. And this is the position in which I get it. The C-arm is from the top, elbow is flexed, wrist is flexed, and I can see that.
So just for the audience, it's also called as a Hoya view or the Donick view. The true lateral view is at around 20 degrees of elevation with the elbow supported. Quick question to the audience. How many of you close the pronator quadratus back on again? Show of hands. Oh, wonderful. I love this.
So I have the laptop onto it.
Right.
And it's a controversial thing.
It's a controversial thing.
I'll discuss it with that.
Please, not a problem. Thank you. Thank you.
Okay, great. So next speaker is Abhijit. I think we have run out of time here. So yeah, you can do it while he's going up.
No, this regarding the exposure, I released the radial septum also. The radial septum first extensor. So that, slightly dorsally also you can just see what is happening over there.
Right. So my talk is on comminuted distal radius fracture. And it's going to be, I'm going to lay set the ball rolling and set the tone for Warrior Sir's talk, because I think we're talking on the same premise. So this is a 63-year-old male who had a motor vehicle accident and a polytrauma. He had an acetabular fracture also that was treated by a colleague of mine. And I was called in to treat this fracture. So you all will appreciate if you use the column classification here, all three columns and as well as all components of the intermediate column are involved. How would you treat this fracture? Sorry? Traction view, I don't think I have one. We got it on table, but I don't have it to share here. But the CT scan shows that free intraarticular fragment. You have a metaphyseal void. You have dorsal lip, dorsal column fracture. You have a volar column fracture as well as an ulnar column fracture. So very quick, how many of you would use ligamentaxis for this? All right. What if I open in Pandora's box and say that the concept of ligamentaxis itself is erroneous? Yeah, there are no ligaments here to stretch, right? It's very controversial, but then think about it. You're relying on the tension in the tendons, not in the ligaments, right? So for once, let us all set that concept aside. Second, I think the most important part about ligamentaxis, if you were to use that term, is you're able to correct the deformity only in the plane in which you're applying that fixator distractor. What happens to the displacements and deformities in the other planes, right? So then comes in the role maybe pins and ligamentaxis. Show of hands. All right. Plate and ligamentaxis. More people. How many of you would plate this? All right. What plate, what approach? Sir, please.
So here comes the role of exactly of CT scan. Here comes the role of a corner concept of CT scan classification.
Correct.
Here comes the role of a key corner concept of CT-based classification.
Correct.
The displacement of lunate or the carpus, you may say, is towards which side is to be seen. If at all it appears, it is 95 or 98% of the times I am correct in that. If at all the lunate or the carpus gets displaced on the volar side, I'll go in with a volar approach. That will be my approach then.
Right. So, right. So, just as a rule of the thumb, volar cortex intact, dorsal comminution, dorsal approach. Volar cortex is comminuted, dorsal is intact, usually dorsal volar approach. Now, if both cortices are comminuted and fractured, at times you may have to use a dual approach and a sandwich plating for that matter, perhaps. Now, the lunate is the keystone. The lunate fossa, especially the volar teardrop, is kind of the calcar. There is a very good and a very nice study by Greg Bain wherein he has shown that the fault lines in distal radius fractures are between the ligamentous attachments of the radiocarpal ligament. So usually the attachment of the radioscapholunate and the long and short radiolunate on the volar aspect, the interspace between these ligaments is usually wherein the fracture lines will run through. So like Aptes rightly said, if you look at this and use the column classification, which was proposed by Reckley and Regazzoni, you are very easily able to look at all the fragments in no matter which projection, axial, sagittal as well as coronal. And then you're also minimizing the inter and the intra-observer variability, right? So I think we all agree, especially in the axial view, which is important to show the involvement of the dorsal as well as the ulnar corner fragments, volar ulnar corner fragments. So this is important because it's involving the radiocarpal as well as the distal radioulnar joint. So what are our options out here? So since this was so comminuted, we plan to use the bridge plating, which was described by David Roosh out of the US. It's a very neat and a very handy way of dealing with these fractures. You use a specially designed plate, which is even available with some of our Indian manufacturers, which is very cost effective. And you use that as a bridge plate. And you can use it in conjunction with other plates as well to address the other fragments. So we used a dorsal approach. We reduced this fracture to the best of our ability, used a provisional K-wire to get that large chunk of the radial column or the radial styloid back on again. The ulnar head was also fixed. And I understand he is an elderly patient with a pelvic trauma. We knew that he wouldn't be ambulating with crutches or whatever for a long time. He would be bedridden. So we used that to our advantage by using some provisional fixation with K-wires and then using this this dorsal spanning plate and fixing the fracture of, buttressing the ulnar column of the dorsal aspect of the radius. You can use a single midline approach wherein you exteriorize the EPL, or you can use a staggered incision, but you have to be extremely careful to not impinge any of the tendons. So you slide your plate in and then you get your provisional C-arm images to make sure. So understand what we saw on the previous lateral view was the ulnar column dorsal aspect, which was left unaddressed as we could have seen in the previous use. But here the joint line is reasonably well reconstructed, and then we go ahead and we fix it. We usually remove the implant at 3 months out, and this was at 3 months after removal, and we use that anesthesia to our advantage to very gently mobilize the wrist joint at the same time. And this is him at 1 year post-op with a reasonably good range of movement and function, wherein he's gone back to driving as well as using his hand in a more meaningful manner. So pronation supination is good, flexion extension is good, grip strength is also good. So this was just kind of a prelude to what I think Sudhir Warrior sir will be talking in a little bit of more detail. Thank you so much. Any questions? I'll be happy to answer.
Yeah.
Yes, sir.
Amit.
Abhijit, what I feel is just an opinion. I would have done a traction view because
we had one.
Look at the way it got reduced. No matter how much combination is there in the distal radius, immediately on the arrival of the patient, if you just give it a little bit traction, everything falls back in its place.
True.
And you can just have a nice jigsaw puzzle solved.
True.
And then you can decide. But then what was the reason for that? Because it's a comminuted, you put a distraction plate.
Correct.
You could, you could have primarily plated it dorsally.
It was very comminuted. Very comminuted.
Okay.
So
if you decide of doing a dorsal and volar plate, which plate first? What and how
great question. So we first reconstruct the volar aspect. We expose both sides simultaneously. We reconstruct the volar surface, and then you reduce the dorsal over the volar. And we have a very low threshold for using bone grafts in the subchondral area. So use the dorsal comminution as a trapdoor. You elevate the intraarticular fragments, reconstruct the joint. We at times do not hesitate to bring the scope in to ensure our joint congruity, put in bone grafts, and then buttress the dorsal aspect.
Grafts?
Sorry?
You put grafts?
Yes. And at times, the very, very distal fragments, which are attached to the capsule, we put in braided non-absorbable stitches and hook it onto the plate.
And if at all a radial styloid plate is also required?
Yes.
Then you put it last.
Yes.
And what is the criteria for radial styloid? You can also put wires over there.
So a split in the in this correct coronal split in the styloid is usually one of the indications, because your K-wires then are insufficient.
Metaphyseal extension.
Correct.
And do you always do a brachioradialis release?
Yes. It's a game changer. It just makes your life so easy. So a lot of people ask whether we should be suturing the brachioradialis back again. No, because it has got extensive adhesions along the length of the radius. So you can just leave it scars down. So releasing the brachioradialis is a game changer, because the reduction and restoration of length of the radius becomes a cinch. 2, it gives you that that access or that space wherein you can put in your radial styloid plate. And at the same time, you could use this release of the brachioradialis. You can perform it either via a volar approach or a dorsal approach, doesn't matter.
So Abhijit, so yes, you can use the radial styloid plate, but if your styloid is one piece, do you use the wire at all, or you always would put it as a plate?
No, we use a wire, sir.
Okay, great.
And then we do not remove it.
Yeah.
You know that compulsion or the instinct that
So
we
you
have.
put it in all the
we
way so that you
bury
don't
it.
have to
We
remove
bury
it.
it. We do
Brilliant.
not remove it at all.
Okay,
Because
great.
a lot of times we find that early removal leads to that late collapse as well. So just leave it in there.
Great. Thanks a lot.
Thank you, sir.
Abhijit.
Thank you.
Is Ashish Fadnis here? Yeah, sure. Otherwise, the next speaker is going to be Dr. Sudhir Warrior, because Kashyap is busy on the other side, and he's going to talk to us about how do I cross this bridge, non-fixable distal radius fracture.
I'm glad to see Abhijit leave the hall. I'm going to rip apart his paper. Abhijit, bye. Okay, so I'm going to speak about bridging the unfixables, and here I think some of us thought maybe we could fix that. Maybe thoda shanagiri jada hai, but really you need to think about that. Yeah. So when I was given this topic, I looked up the internet, and it said on PubMed, it said there are 72 papers from 1992. And there was a review, a meta-analysis kind of review by Fairs, Nestle and Dunn, which quotes 206 studies of dorsal bridge plating. And that study I followed, and I read the whole paper, and I looked at their example. There's one example where they have used 895 patients where bridge plating was done. And the only case that they came up with, which they wanted to show as their showcase, was a case I think many of us in this hall would fix without bridging it. Yes or no? Yeah. So you see that after all that, they haven't reduced it completely. The DRUJ is not reduced. The result is going to be not so great. If that was their best, why should I believe the rest of that paper? I am not going to believe that paper. Then I looked at the external fixator case. I would fix this. This is osteoporotic, I agree. There is comminution, I agree. But look at the large volar chunk saying, come, I'm here. Use the plate and fix me down and I'll give you a good result. And yet that was the only one that was shown in this with not so great a reduction. Then I looked at what they looked at to say what was good results and not so good results and things like that, and looked at all the parameters, and I'm missing range of motion and pain. Can you imagine results without range of... That's the only bloody thing the patient wants. And they haven't looked at it in that paper. So I'm going to show you cases where I think you need to bridge it. Young lady driving a car in Goa, she lives in Goa, had this injury, immediately called up, went to the local hospital, got an external fixator done by a surgeon there in a hurry. Half of the foreign bodies are still within. The fixator isn't in a good position. There's something happening on the radial side. There is bone loss. She said, Doc, I'm coming to Bombay. And this was some years ago. And I started scratching my head and thinking, what implant am I going to put for this patient? Standard bridge plates then were not available from imported companies or the Indian companies. So what I did was I drew an imaginary plate based on what I have seen and in brochures and handled abroad. And I called up an Indian manufacturer. I called Mr. Girish Gangan of Uma Surgicals, and I said, you know, I'm getting in a patient from Goa who's on the flight right now, and tomorrow morning I need to operate her. This was 2 o'clock in the afternoon, and I'm sitting in Khar Hinduja Hospital, and on a piece of paper I draw this and I tell him, kya kar sakta hai yaar? And he said, sir, let me see. At 6 p.m., he sends me a computer drawing. And he says, is this what you want? And I said, add a couple of holes here, do this, do that, do the other. At 8 p.m., he shows me the plate. He has already made a plate within the 6 to 8 hours. He's got a plate machined and ready, not finished yet, not plated yet. They do electropolishing, they do a lot of other procedures, not done yet. He says, is this what you're looking for? And I said, yes. Patient is admitted at midnight under my care, posted for surgery at 8 a.m. Plate delivered at midnight, accompanied by a certificate of custom implant, which is necessary when you're making something different. You must have an implant, custom implant certificate from the manufacturer with your prescription and the need for customization. Then it can be accepted because it's a known company, it's a certified company, he's using correct material and he's going through processes which he uses for all his other plates, and therefore you can use a customized implant. Not just mere ko ye bana ke de types. So this was delivered. Next morning, we put a bridging plate. I had my plastic surgery colleagues come in and give me a lovely graft, which is something that Marco Godina spoke years and years ago, a Slovenian surgeon who unfortunately died in a car accident at the age, I think, around 43 or 44. And he revolutionized the treatment of compound fractures. So I must thank Girish and Samir and Leena. And that was the result. And there's the lady at the time of stitch removal. She now resides abroad, and I don't have a follow-up beyond this. But the idea to get across was that who needed a bridge plate. Here's a 35-year-old patient, and look at the dorsal comminution. That is really bad. Nothing is going to hold that. But there is a nice large radial styloid piece, and it says, you want to fix me, but what are you going to do about the rest? Dr. Apte mentioned, where is the lunate? Where is the carpus? It's all gone back with a lot of small fragments which may be unfixable. So therefore, we all do this. We get a 3D CT scan, and I'm looking, can I put a volar plate? No. Can I put a dorsal plate? All small fragments. Can I put an ulnar-sided plate? Definitely not. The only thing that allows me something is a radial plate. Now here's one which is a true indication for a bridge plate. But my friend who was operating this decided to put a fixator. And the fixator wasn't great. There are CT scans of the fixator which I won't get into, but the thing was, here's a destroyed joint. Unless you bridged it properly, you wouldn't be able to get those fragments back in. It wasn't possible. So when I visited that city recently, I told him, I'm sorry, I don't think we can do anything now. What we need to do is to bridge, but not across, just to the proximal carpal row. So this is a radio-carpal fusion. So now you've taken out that bad joint, but you maintained the joint beyond. The mid-carpal joint is maintained. This is something that I did a few weeks ago, just 2 weeks ago. So I will show you a result of something that I've done similarly and presented on this forum earlier. And that's another patient that I had done a similar surgery on, and that's her function. So you can bridge it, but you don't need to go all the way to the metacarpal. If you've decided that this joint is not reconstructable, there's not enough cartilage, and I can then bridge the radiocarpal joint and fuse it. And Dr. Tanna speaks about one medical student on which I failed 3 times, and he succeeded by doing exactly this procedure. And my third case is this lady who is 60 years old, extremely active, a foodie and a blogger and whatever else. She's very, very active. She used to be a TV presenter, and she had 2 malunions with a horribly shaped wrist with which she functioned and lived her life for 30 years. And then she again had her 3rd injury. And that's when she came to me and said, make my hand straight. Because I've been referred to you and they said you can do anything. Well, I started believing her. So I didn't know what to do for her. And I looked at her CT scan. There's just futile looking at those because you don't know which bone, what position was it before. You can't compare it to the normal side. And therefore, I called Girish Gangan again and I said, now that you have good bridging plates, he's got lovely bridging plates of different sizes, and I get it customized to whatever I want. Here, this one was one that I had to trim off. And if you can see the X-ray there, I've trimmed this off because it's too long, as John was pointing out, and that long plates are not really necessary. And unlike brave Abhijit, I open and I exteriorize and I put my plate inside. And that's the lady after the plate removal. And what can you expect? Now her hand is much straighter. She's extremely happy. And what function can you expect? Fairly good function to be able to do almost everything that she wants to do. Far better to look at from what she had before she had the fracture, and far more functional, she tells me, and much stronger, she tells me. But then, of course, that is just to keep me happy, I think. So I just showed you a radiocarpal fusion. And then on this one, I go and bridge this. Why should I not have done a radiocarpal fusion for this one? Because in my history taking, she had laudable function in that radiocarpal joint, which was malunited. Why should I rob that function? So I decided to maintain that function and therefore use the bridge plate. So let's be fair, let's look at bridge plating alone. Here's a paper that talks about a systematic review, 394 cases in 11 articles, which means an average of 35 cases of bridge plating in each article. I think there are incompetent surgeons in this. They could have plated many of those. The range of movement that bridge plating gives is 46, 48, 68, 67. That's different ranges. But bad intra-articular fractures, few papers, but better ranges. So why do you want to not give them better ranges by doing a plating rather than bridging it? The message I would like to give out is bridge plating gives good outcomes, but use it only for true indications, the truly non-fixables. Otherwise, you are robbing your patients of a significant arc of their range of movements. Thank you very much.
Thanks a lot, sir. Sudhir, any questions? We still have a minute.
Can I make a quick comment? I think that was a fantastic presentation. 2 slides which are worth 1,000,000 words. One was that external fixator, exactly the point that I was trying to make while I was presenting the talk. Second was your last summary, wherein you do not use it left, right, center. And just to kind of open a Pandora's box and food for thought, this is an anecdotal kind of a, on the WhatsApp group, Dr. Parag Shah from Ahmedabad, he uses a similar bridge plating on the volar aspect. He uses the T plate for the very unfixable volar rim fractures, and he opens up the carpal tunnel, releases the carpal, and goes distally right up to the scaphoid and the lunate to buttress that entire aspect, and then removes it around 2 to 3 months with very good outcomes in his hands. I haven't had the gall to do it so far, but just, kind of to let you know that even on the volar aspect. Yeah. Thank you.
So the next one is going to be me on pediatric distal radius with gaps.
Thanks, John. I should have announced that.
But they've already loaded my presentation, so I'll go ahead. And so this was a 15-year-old boy who fell off a tree, and he had an open right distal forearm fracture, which was treated elsewhere. The first available X-ray we have is this, which is in a cast with a ulnar nail. And you can see the distal, the radial shaft fracture there. And this is when he presented to us at 3 months with discharging sinus above the wrist on the radial side, gross stiffness of the wrist and fingers, and those X-rays at that stage. So any reading of this X-ray, Abhijit?
Yes, sir. So I see that there is the ulna which seems to have healed with some loss of the radial bow. I'm not sure if that is a non-union that we are seeing at the mid shaft of the radius, a little distal to the mid shaft, and then some kind of erosions out there. I don't know what. No skin and infection. No infection.
No, there's
nothing.
infection.
There is infection. Okay.
So actually, if you look at this very carefully, this entire part of the radius has actually sequestrated. And so that's what, when we went in and debrided, that's what we found. So we ended up excising that entire segment of the distal radius. We left the ulnar nail because on the ulnar side, there wasn't any infection, although the ulnar is not great. And we then used an antibiotic coated cement block, so just like a mascale technique, and we left the ulnar nail in situ. So the wounds and sinuses healed well. We came at 8 weeks. ESR and CRP were normal, and there were no local signs of inflammation. So then we went and planned the next stage, which is removal of the cement block. So we had to figure out what to fix this with, because you have a very short distal segment and you have this long gap here. Okay, so what we did was, so one of the things about the mascale is you don't scrape off this membrane that is formed there. So you get a membrane which is formed as a reaction to the cement, which has osteogenic potential. So you want to leave that there. I was not happy with just putting cancellous graft. I wanted some strut support. So we actually used a long iliac crest and then added cancellous graft on top of that. And then we used this long plate from the distal radius LCP set. Okay, so this was the 2.7 screws. And we also did a sleeve resection of the distal ulna because of the overgrowth of the ulna. So this is him 2 months post-op. This was him 3 years post-op. So he's got back a reasonable range of motion. And you can see how beautifully the entire gap has reformed with the bone graft and the mascale technique. So interestingly, a few years later, we had another child. This was an 11-year-old boy who had a distal radius fracture, open fracture, which was treated elsewhere. I'll run through the x-rays. That was the original x-ray that he had. And so this is one of the things that with these distal pediatric radial fractures, there have been papers which say you don't need to open and debride. But I think that's a dangerous thing, because just because it's an inside-out injury, very often there's a lot of soft tissue which is damaged there. And it's always better to extend the wound and look in and clean everything out. And so this was him. They just put in a KY, I think. That was the cast. This is the subsequent X-ray. And this is what gradually you can see that an area of the distal radius is sequestrating. This was him when he came to us at 3 months. By now, that entire distal radius, except for the last bit.
John, can I just interrupt? Can you go back on the first X-ray? Is there an inkling of that large fragment?
If you, so it didn't seem like you can't see it here, okay? But so this is the X-ray after without the cast. Yes, with the cast, so it's difficult to tell. But you can't see anything there. So it's just avascular bone. So probably this fragment came right out and they just went back in, and then they pulled it and just put in wires, rather than doing a thorough debridement at that stage. And then it got infected, and then that area got totally sequestrated. So you can see that it's happening gradually. Here you can see it. And then by now you can see it more clearly. And by the time he comes to us, it's very clear, okay? So, and there's no involucrum. So unlike in chronic osteomyelitis in children where you get this nice involucrum, you don't get it in these post-traumatic cases where the entire periosteum has probably got ripped off in the injury. So again, this was how he came to us. So you can see the draining sinus here, the inflammation here. Again, you can see that. And again, he had clawing of his fingers because of all the fibrous tissue that had formed as a result of the infection. So again, we did the same thing, excised the distal radius, put in the antibiotic cement block, kept him in a cast. This is when he came back. Again, you can see how by now the sinuses had healed, his ESR, CRP had settled. And then we went back for the second stage. That's the cement block. We took out the cement block, and you can see that membrane that's nicely formed there. Again, we did the same thing, same graft, same plate, and again, resection of a distal end of the radius so that he could get back some pronation and supination because the ulna had overgrown. And you can see how the distal ulna reforms over time, and especially in children, and how this bone is now going on to heal And this is his final follow-up at 1.5 years, final follow-up that he came to us with again, everything healed. So we want to take these implants out usually in children, but he's got to come back for that. So he again went on to heal. He's got some restriction of pronation, but otherwise a fairly good range of motion. So we actually published these two cases as in the injury case reports section with a muscular technique for infected distal radius fractures with gaps in pediatric age group patients. So to take home, I think muscular technique is fairly well established in adults, but the use in the pediatric age group is still uncommon. Is there a controversy? I think the question is, would these gaps fill up on their own considering they are children? And we don't have an answer to that because in osteomyelitis, we've seen a lot of presentations where huge gaps are filled up in children over time, but I think this is slightly different because it's a traumatic event and very often the entire periosteum is ripped off and so maybe it will not reform again. Okay, so that's a controversy we don't know the answer for. Yeah, so any question?
Yes, sir, please. Yes, Kulkarni, sir.
John, we had a similar case and we treated with muscular technique. Instead of using iliac crest, we used a fibular graft subperiosteally, and then you take about 5 mm larger than the cap so that you distract and put it there in the muscular membrane and it heals well.
Yeah, absolutely. So I think I'm just, because it was an infected situation earlier, I was a little reluctant to use non-vascularized fibula. So you use the strut iliac crest because I could get a straight enough, long enough strut of iliac crest graft in the child, because you take off the iliac crest and then you take the cartilage part you take off and then you take off the bone part, and as long as you can. So if it's a larger gap, probably you can't do the iliac crest and you may have to do fibula. But fibula is a cortical bone and this is cancellous bone, so I would prefer that to a cortical bone. Yeah.
Any tips on how do you manage a bone which has come out, stripped off these in the primary to prevent this complication?
So I think the important thing is debridement, okay, because infection is what makes it a complete sequestrum. So if in the initial part you have done a thorough debridement and you've been able to avoid infection, the chances are this fracture will go on to heal without a problem, okay? So the problem in both these cases were they were probably just reduced and fixed without doing a proper debridement, and they were both open fractures.
Debridement is you give a wash, right, of the bone. But
So
would you like to put drill holes in the bone so that they just come out so that to revascularize the bone?
So yes, if the bone looks avascular at that time, maybe I'll make drill holes, but I would really look into the bone, okay? So that's the most important thing, is to actually see what has happened, because there was no fracture in this, so there's no reason why it should not heal if it doesn't get infected. Okay, so that's what. So because probably that entire bone came out, but it was still intact. Okay, if that was a separate piece, that's a different situation altogether. Okay, but I mean, people have put back pieces of bone, extruded talus, extruded bits of distal femur, and got it to heal, but there'll always be you don't know what will happen down the line in a particular case. Okay, so it's worth trying, but what is important is your debridement again. So like every other thing, if you don't debride adequately, you're going to get infection and then you're going to get problems after that. Okay? So,
have you removed these plates anytime after the masculine?
Not yet, and they haven't come back for removal, and I'm worried about that because luckily, these are not the 3.5 screws. The 3.5 screws are the worst to remove. The 2.7 are a little easier normally, but yes, the locking screws can be difficult to remove.
No, I'm worried about the strength of the masculine bone formation, the new bone formation.
But it's now 2.5. One of them is 3 years down the line, so I don't think now the strength is a problem. Question.
Why did you say that 2.7 are easier than 3.5?
I've just found them easier to remove.
It's your experience, right?
Yeah. With lock screws, the 3.5 lock screws, after they've been in for some time, seem to be really difficult to remove. The 2.7 somehow are not that difficult. So even in the distal humerus, etc., when we've had to remove these, So we can get the 2.7 screws out relatively easily. The 3.5, if they've been there for a long time, I don't know if it's cold welding or what it is, whether it's cross threading, whether it's the fact that bone ingrowth is there, but removing them is a real challenge. And we spend more time sometimes removing these than actually putting them in.
Okay, so
Yeah.
In the muscular technique, whether when you will put the bone cement in the semi-solid state or after being solidified?
No, so you put the cement just as it's, you don't want, so you want to put it in just as it is setting because you don't want it to bond with the bone. Okay, you want it as a spacer. Second thing is as it's getting set, it's going to release heat. So keep irrigating at that time so that it doesn't heat up too much because you have structures not very far away. Vital structures. So the vessels are not very far away. The nerve is not very far away. So keep irrigating it copiously while it is setting the final 1 minute or so. But don't put it in till it's almost about to set so that you don't have trouble removing it because sometimes you can have problems actually removing the cement if it's bonded to the bone. Okay.
Thank you.
just a thought, John. Is it more difficult to remove a 3.5 screw because of the difference between the core diameter and the thread diameter? Because there's so much of thread that bone can form underneath those threads as opposed to a 2.7 where there's much lesser space.
Possibly one of, so the AO screws are designed in such a way, so even though you have more threads in the head, every alternate thread actually catches on to the plate. So it's the same pitch as the screw in
the
but the fact that you have more length and more bone and the quality. So yeah, I think it's something to do with that because but the 5.5 screws are much easier and they are longer. So they somehow come out without so much difficulty, but the 3.5 seem to have the biggest problem trying to remove. Yeah.
Okay. Great talk. Thank you so much. As I invite Dr. Kashyap Ardeshna, just a very quick piece of information that would interest you. We all talk about the masculate technique in orthopedic conferences for related to non-unions. He is much more well known in the hand and upper limb and plastic surgery. He's an orthopedic surgeon. He's an orthopedic surgeon. And no, I had the privilege of working with him. He is an orthopedic surgeon who is one of the most accomplished microvascular reconstructive surgeons in the world. So just so that you know. Thank you.
Thank you, Chairman, sirs. As my platform was already set by Abhijit sir and Sudhir sir. Sudhir sir shown many cases where people think that the breech plate should have been done, but he said that it can well be fixed. So I'll be showing you some cases which are really complex, but then I fixed it, right? So I'll run through the cases first. See, we get a variety of intra-articular fracture in distal radius. There are a variety of classification. The cases which I am going to speak about is a C3 variety of fractures only. So the ladder of management is from easiest, the plaster, to an augmented plate fixation. So these are the two things which we use in a complex fracture, the complex plate fixation, multiple plate fixation, and addition of bone graft. So I'll run through three cases first quickly. So it's a comminuted distal radius, intra-articular fracture, lots of comminution, articular fragmented. Young patient decided to fix on this. So that's how it was fixed, dorsal approach as well as volar approach and a graft. And this is a nice healing and nice radial inclination, everything joint space at the 6 month, right? And this is a 6 month function of this patient, which is reasonably well for the fracture which he had. Another case, 40-year-old household lady had this type of fracture. And also that was also fixed with the dorsal approach because there was a volar big fragment which can catch hold of my dorsal screws. That's how we do a dorsal capsulotomy. This is a scaphoid unit area, and this is how I can reduce under vision. And then the door is closed, and then the two plates are fixed, right? So that's again a post of this patient, a 9 month result and a good clinical result, right? Third case, a very comminuted elderly lady, 60-year. Probably these are the cases we might think of doing a breech plate, right? Even if we do breech plate, we need to wait for a very long time to heal. And sometimes even the late collapse also can happen after that. So I decided to fix it even though it was a very osteoporotic. Did a volar approach, did a volar ream plate and put hydroxyapatite granules and then closed some dorsal pieces which were there. And this is how I got the post-op picture. I was little confused what will happen in the future. But this is a 5-month result. See, almost all the parameters which were fixed were well maintained. And this is a reasonably good clinical result for this elderly lady. Right. With the setup that this type of complex fractures can be managed well with internal fixation, then I will take you through 2 cases wherein I go through the step by step how do I do that, right? So this is the classification which we follow for a complex distal radius intra-articular fractures. So that's a nice, 4 different pieces and undisplaced and 1 displaced and 2 displaced like that. Right. So this was 51-year-old male patient. It is this fracture. See this. If you look at this, there is a big volar piece. So if I fix it from a volar side, then that is fixed well, but these fragments cannot be fixed well. But if I fix from the dorsal, then this can have a catch hold of 2 or 3 screws, right? So I decided to do a dorsal fixation, but because this was incarcerated inside. See, reduction of this fragment was not easy, right? So I did a volar approach first, then I put a small periosteum, hand set periosteum, and then I could reduce that volar piece. That I didn't wanted to fix it, but I just kept it as it is and put a temporary wires from the volar aspect and fixed those pieces there. Then I went to my main area of interest where I wanted to work was in dorsal incision, where I find the EPL first, and then between the compartment we find and go to the fracture there, and then do a dorsal capsulotomy. There was a fragment which I flipped over, and I can see this is a lunate which is seen, and then I took a bone graft under local anesthesia from Gerdy's tubercle, and then I put a bone graft, packed it underneath, and then gradually closed the book and did a temporary fixation. So this is a technique of taking a bone graft from Gerdy's tubercle is one of the procedure which I used for 10 years, and the video is there in the studio. Very useful technique. It's a 10-minute job. We can do it under local anesthesia. I do it for last 10 years, and we find this much amount of the graft, very good quality graft in 10 minutes, and that video is there in the studio, TraumaCon studio. So then started fixing, that's a dorsal plate, and then this is the dorsal capsulotomy, and then the radial plate from the same approach, and we find some superficial branches over there which we need to take care. So that was my post-operative reconstruction. I can see the nice alignment of all the joints and everything. This is the post-operative X-ray. These are the wounds which are healed at stitch removal time, and this is a 6-week follow-up. Both the patients are fresh, so don't have a clinical follow-up, but I expect a good result like the previous cases which were there. See, because I put a bone graft, we can see an incorporation of the fracture and everything very nicely. So people say that we don't put a bone graft, no need to do that. But if there are some articular comminution, if you support it with the graft there, then your fixation becomes stable, and we don't have to worry about the loss of fixation. And the last case, very comminuted fracture, all column were fractured on the radius side, dorsal volar. This is a traction X-ray. Usually we take a traction X-ray first in an emergency, then we get a CT scan, so that these all things will actually help in planning of our surgery. So that was the case. Very bad, multiple comminuted pieces on the articular side, and then we started see all these cases, the comminuted cases. What I do is I put a 1-pin fixator, 1 pin into metacarpals and 1 into radius, so that during my surgery my assistant doesn't have to keep on giving a traction. So this is before I started the surgery. Then once I put my fixator, see, most of the things are started getting alignment, so I get a good sense of structural anatomy and all that. Again, a volar approach was used, and the fracture was exposed, and then started fixing from the volar approach, did some K-wire fixation from there. This is still a volar approach. Then went to a dorsal approach, find the EPL tendon, then went to through the fracture into the crater. There was a dorsal piece. See, this dorsal piece I used to open like a book, right? So this is a dorsal piece which is flipped over here. Then I can see the carpal bones there, right? And then I can, under vision, I can reconstruct my articulars, and then I can put a bone graft there, and then I close that piece again, and then started putting a dorsal plate first, then a radial styloid plate. Because this was very comminuted, then I put a volar plate too. See, these 2 mm and 2.7 mm implants which are available now are very good and very helpful in this type of complex articular fracture. So this is a postoperative picture of this patient. And so that was a very recently done case, so we don't have a much longer follow-up. So message I would like to give you is, we need to understand the fracture very well by sitting in front of the CT scan for quite a long time. We can sit for 10 minutes, 15 minutes. What I tell people is, it's a preoperative meditation which we need to do for all the complex articular fractures. We need to study all the images, everything, like, which fragment I will hold and what, so I will go from where to where, whether I take single approach or double approach. And I use X-fix in most of these complex cases. And I also extend that X-fix for say 4 to 6 weeks postoperative period. So because if that, X-fix is not there, the carpals will, crush all the press over the distal articular fragment, which are very comminuted. So if we give some time, then they start healing, keep options of implant ready. You need to have a plan A, B, and C. We need to preserve biology. However, we are dissecting, openly reducing it doesn't mean we are violating biology. We need to take care of the soft tissue, do as much as possible with the dissection with the knife. Do stable intra-articular fixation, stable DRUJ, so that we can mobilize them in time. We need to avoid tendon irritation by proper implant placement. Because these standard 2.7 plates which we used to use are still bulkier, but now if we go to the 2 mm and 2.7 mm plates, we are very low profile and very helpful in not irritating the soft tissue around. We need to fill the metaphyseal voids by the bone graft if it is required. We need to balance the rehab and the protection. Thank you.
Great talk. I just want to make a very quick point. When you mentioned, use a fixator to, unload the radiocarpal joint. One of the meetings I heard a German hand surgeon wherein he applies mild traction after the fixation, puts in a radiolunate wire to unload the radiocarpal joint or the radiolunate joint to be precise, till such time that the fracture becomes sticky, and then he just removes it.
I don't have that experience, but I definitely use that when there is a comminuted navicular fracture in a foot. What I do is, from the metatarsal I pass a wire with the distraction position.
Right.
So it's simply a wire will itself, keep it distracted.
Right.
But I've never thought of an
I found this to be
using
very
that in a wrist.
intriguing, very interesting. So we use it in a few cases. And this is especially reserved for cases wherein you have this free floating intra-articular fragments, your bone grafted, still it's a little dicey. And then you can use a radiolunate wire just to unload, pretty much like you would in the foot. So just a kind of a trick for you to know.
Yes, Amit.
Kashyap, you talked about ligamentotaxis just to cause the distraction and to prevent the collapse of the carpal bones.
Correct.
Would like to ask Sudhir and John.
So just to, before they actually answer, I would tell you, I will give maximum traction when I am doing surgery. But when I finish my surgery, if I keeping that fixator on, then I will not give it in a very much traction, because that will cause over distraction as well as the ulnar deviation.
So you give traction with the distractor.
Yeah, simple, a little bit of, so that my radiocarpal is not loaded. But during surgery, yes, I distract it a lot.
Okay, your opinions regarding this?
Yeah, so it's like an augmentation of fixation where in very comminuted fractures, you can keep the joint.
Yeah, I understand. But do the carpals really collapse down?
I
mean, hit the articular surface of the disc?
I think it depends on whether the cartilage is maintained and whether you've got a mantle of cartilage strong enough to support the carpus. If it's not, like he said, then maybe it's good to keep it distracted. The amount of distraction that you keep is not more than twice the size of any intercarpal joint. So you see the carpal bones and you can see the space that is there. You measure it off on your X-ray or your C-arm. More than twice that increases the carpalite index, causes CRPS, pain, and other problems. So you should keep it. You should keep it just more than the actual joint is there.
In certain papers, I think Randy has mentioned, in the distal and fresh fractures while you're fixing, you do a dorsal periosteal release to remove the dorsal hematoma. So, does it really obstruct your reduction? I want to ask you because you must be knowing this. Yeah.
So just look at this X-ray, sir. See, this is not in over distraction. That has to be taken care in a postoperative period. So that's one point which.
Okay, understood.
So I think we've. Sorry, you have to say.
Dorsal periosteal release.
No, I was going to call the next person. but
Okay,
if I have to
just
say-
one very thing. That's a question I wanted to ask him. Do you wait between the injury and the surgical, planning of the day?
Definitely
of surgery?
till I plan it, but if there are some abrasions and all that, then I wait for a few days, but not like the pylons and the calcaneum and proximal tibia. So this is reasonably, if there is no huge swelling, which amounting to the compartment, all that, we can definitely do surgery within 2-3
So
days.
we usually wait for about 10 days. By
Is
that
it?
time, yeah. Especially when we are contemplating a dual approach. That gives a lot of time for this edema and this periosteal, subperiosteal hematoma to settle down. You open it, everything is clean, it's not bleeding like crazy. You see your tissues and your structures very well. And this also gives you a lot of time to interact and counsel the patient multiple times regarding the outcomes and all that. It's a good idea in our practice. We have found it to be quite useful. Wait for about 10 days.
Yes, so
and
this
then-
how much time do we wait for such cases?
If I wait for too long, they'll go off to Abhijit.
Yeah, so I mean, it's interesting that you say that because most of us don't wait unless there's like swelling which you're worried about. So normal distal radius fractures we'd fix whenever they're ready for fixation. Basically, we wouldn't wait deliberately for 10 days. But that's interesting coming from you because it's
So
obviously been some
the
work
edema
on
that
it.
you're talking about when you are using these plates, yes, it's difficult. And when you take your stitches, especially, you'll see the stretch marks. If you see those stretch marks, then you must use additional steri strips, try and reduce the amount of stress there is, keep the hand elevated, take edema control measures very seriously, and see the wound within 48 hours to see that everything is settling down. Keep the fingers moving, and I think that helps.
Do you use a tourniquet or you don't use a tourniquet?
We do use a tourniquet,
Okay.
sir.
So that's another way of avoiding post-op
finish?
swelling is not using a tourniquet. Okay, so
One other tip that I would like to give is basically when you've done one side and you're going to the other side, then take stitches, interrupted 1 or 2 or 3 stitches to hold the skin edges together, then go to the other side. Then it becomes much easier to close when you come back to close it finally.
Okay, I think we're running out
Thank
of
you.
time there,
Thank you,
so
sir.
I will have Dr. Ashish Padnis talk to us about rim fractures of the distal radius.
So it's a case presentation. It's a simple case. So number 3. Number 3. Sorry, yeah. So the case I'm going to present is of a rim fracture of the distal end of the radius, and these fractures do come to us very often, not very often, but they are sort of rarely, but it's at least once or twice a year where in a busy practice you would get to see such fractures. So these can be a little innocuous looking injuries. Most of the time it is very apparent that there is a big problem, and these are the fractures which present with a lot of problems about fixation, getting a correct alignment, and there are a few soft tissue issues that come with these fractures which would sort of eventually give you some problem. So this was a fit gentleman who had just a fall on an outstretched hand in a swimming pool. He has no other comorbidities. This is an isolated injury that he has, and you can see that there's a fracture of the distal end of the radius, and there is hardly any distal fragment left in the radius for us to be fixing this. So should I go ahead with what I've done and things like that? We can come back. Or so in interest of time, I'll just go through what was done and we can always come back. So the options and the challenges we had was whether we use an external fixator, K-wire, whether there was actually a need to operate, get it in a good position and put him in a plaster, internal fixation, whatever. So metropolitan India, sort of high profile individual, wants to be very active, doesn't need to be in a plaster, doesn't want to be in a plaster, wants to get back to his activities very soon. So we decided to proceed with an internal fixation. So the challenge here is basically these rim fractures are special because they give attachment to two important ligaments. One is a sort of a radioscapho radioscaphocapitate ligament and the long radiolunate ligament. So these are the ligaments which give stability to the carpus. And if these are not fixed or these are not sorted, then there is a subluxation of the carpus, and there is a deformity that comes on later on, and it can also lead to some amount of carpal instability. So it is a standard volar approach by which we decided to approach this. We use a temporary fixation of the styloid just to maintain the length, just to get it a resemblance of some anatomy by a K-wire. And then we put stitches with non-absorbable stitches using ethibond or very thin fiber wire. In this case, in all the cases, we have been using thin ethibond to put sutures in the volar capsule, because that is going to be your main fixation. And as we do in a shoulder, like a parachute stitch, you sort of thread these threads through the holes which are there around the plate, around the rim plate, and then we use it in a buttress mode. So at the end of the surgery, so one of the first steps is you see where the plate sits. It has to sit perfectly on the rim. Get a lot of fluoroscopy images, good fluoroscopy images, and just make sure that this sits very perfectly. As you tie the knots and even fix it with one particular screw, the wrist becomes very stable, and then you can be confident of removing the wire if everything has fallen on in place. So this patient had a similar construct. We had space in the proximal row of the rim plate to put in 2 screws just to support it as like the pegs or to support the subchondral bone. And this was the post-operative picture. He went on to heal. He started resuming all his activities. He had a decent range. He was back to all his sporting activities, but within the first 5 to 6 months, he started complaining of pain. The pain was not very disabling, but what was nagging. He used to come back and say that, doctor, I'm fine, but this pain is there. I'm fine, but this always bothers me. So initially, yes, we thought that there could have been a problem. He could be starting to develop some kind of instability, arthritis or so. But I worked very closely with a hand surgeon colleague, and who immediately told me that this was a problem with these rim plates. So I was trying to buy time, and the problem was this plate is quite prominent on the teardrop. So there is this Sung's criterion. So what is Sung's criteria is basically there are certain, so Sung has described a classification based on the position of the volar plate, and based on the position where the plate is in relation to the highest peak of the bone, he is divided to grade 0, 1 and 2. What is interesting is that this has been predominantly described for volar plates, which are not the rim plates. So juxta-articular or periarticular plates. And if they are very prominent, or they are in, let's say, a grade 1 or a grade 2, then it's a problem. But the rim plate actually are meant to be fitted where this particular plate was fitted. And what we saw in this article that, in their series, they had 3 volar rim plates and all 3 of them had to be removed. So this Sung's grade 2 is a definite indication for a plate removal, because these are the patients who would land up with some kind of irritation of the tendon, irritation of the nerve, or irritation of the soft tissues. They have described a lot of tendon ruptures. They have described irritation of the nerve. If the periarticular or a juxta-articular plate is put in very distally and it is very prominent. But in this particular case, in the rim plate was meant to be put where it had to be. So eventually, after 7 or 8 months, we went back. This is the picture at the end of the year, because then this patient would not settle down. He was not very comfortable. The fracture had healed, and therefore I think this is coming close to about 1.5 years or so that we decided to remove the plate. This is at the pictures at the plate removal, where you can still see that the piece of ethibond, the ethibond stitch is still holding on to the particular capsule. And we saw the stability under the image intensification. The wrist was stable, the fracture had healed. And what was most astonishing was, I would never forget this. In the night of the surgery, he just said, doctor, my hand feels normal. The moment that plate was out, it was like he was a different person. I initially thought it is probably as, he could have some functional component that, he can't get so relieved so fast, so soon. But no, it was very definite, because since then he has not complained of any hand pain or wrist pain. Just to sort of illustrate another case example, this is still a younger gentleman. He is in his late 20s and he had a sort of a bike accident. This is the X-ray that he presented to us with. He also has a patellar injury. And this is the volar rim fracture that we are looking at. And this picture sort of clearly tells you the importance of this particular fragment, the teardrop fragment or the volar rim fragment, as what I think most of the hand surgeons would say, that this gives attachment to important ligaments and therefore there is a subluxation. This needs to be put back into place. So as you can see that there is a very thin rim of bone. There are fragment specific plates which are manufactured by some implant manufacturers which are available now. These were the CT scan images. So there is a component in the scaphoid fossa, the lunate fossa. And intraoperatively, even when you are starting the surgery, if you try to do a close reduction as well, it will fall back in position. So you know that the moment this fragment goes back, the wrist subluxation can be corrected. So the same procedure for this one as well, using a rim plate. This rim plate, we have not put it too distally. Get the same stitches, the parachute kind of stitches through the volar joint capsule. There is no need to put any screw through the distal fragment. You check the stability intraoperatively, whether you put the wrist through a complete range of movement and see if it is all stable. And this is the picture at healing. This patient is still under a follow-up. He has not complained of any pain, but I suppose someday he will come back to us for implant removal. So again, to reiterate that these particular fractures give attachment to the two important ligaments, the radioscaphocapitate ligament and the long radiolunate ligament. The take home for me in this particular 2-3 cases which we have treated over the last couple of years was, the 3-column concept is becoming more and more important. We saw in the last presentation the Rickley-Regazzoni classification. Combined fixation techniques or hybrid fixation techniques like using the stitch, the ethibond or the fiber wire, whatever you're comfortable with, along with this internal fixation, the modern plates or the fragment-specific plates could be useful tricks. And these sort of complex injuries will require sort of out-of-the-box thinking or maybe different multiple strategies like what we've seen in the last couple of cases too. Should I go back? Any?
Thank you, Ashish. Any questions?
I have a comment and a suggestion. I think that's an excellent presentation on very difficult fractures to deal with, Ashish. Congratulations. I learned a trick from Sanj Kakkar at the Mayo Clinic where he taught me how to prevent this plate and tendon irritation. And what Amit alluded to some time ago, the transient fibrous zone, which is just distal to the insertion or the watershed line of the pronator quadratus. So we elevate a flap, either distally based or an ulnar based flap, and you slide your plate right up to the rim of the volar rim of the radius, where it hugs the radius, and then you close that transient fibrous zone over the distal aspect of the plate, wherein you are preventing that direct contact. And of course, you close the pronator quadratus as well. So that was one trick that I learned. Second is that when you have these tendon irritations, do you use ultrasound to put into evidence any tenosynovitis? Do you auscultate the wrist to look for crepitus, to hear for crepitus, because that's one of the earliest signs of tenosynovitis?
Unfortunately, these fractures are so common, Abhijit, but in the Mayo Clinic, you can see that they use those wire forms. Those 2 wires and a screw and a plate over there. So they are that's the best implant for these 2 distal fracture instead of this volar rim plate, I think. But the Indian companies should start manufacturing these.
I think that's available with Arthrex, those tine plates.
I'm talking about the Indian companies. They need to copy and
But then isn't it too fiddly for us to put those tines in and then put I thought we will just, pierce and shatter those fragments which are there. Because I've never used them, I've seen them. Sorry?
Yeah. 2 pennies from my side. One is the very small hook plates are now available, which can actually fix there and can be fixed. And there are 1 or 2 cases wherein it was a very small rim, which cannot be fixed with anything. I put anchor inside and took a sutures from both the side, and that got a very nice stability. You just immobilize in little flexion, and then you can gradually mobilize. So only suture anchor would do a job in some very tiny cases.
So there's no need of a plate.
Would it be prudent in these cases to do a radiolunate temporary fixation?
Correct.
Distraction for distraction.
I would think so. And I think these are amazing examples wherein you can, use your imagination, your innovation and improvisation to deal with these fractures. Thank you.
One last question.
Adding to what you said, the plates are now available from Midats within France. They are FCR sparing. That's the reason you can put it very distally. If you're worried about putting screws, you can put some pegs. It's got an option of putting sutures as well. So that is something which is coming up. Keep an eye on it. The FCR sparing, and it's the option of putting a lunate fossa screw if you've got a problem with that. But that's something new, which probably might
Is this
be
a
there.
plate wherein you can put another plate on top of the?
No. It's similar like a normal volar locking plate. It's
Okay.
from Moderators.
Moderators.
I've been using it now.
Okay.
Just started using it. I don't know how it works, but the only thing is very distal. FCR tendon, which is there, is a worry about in the volar fixation. That's going to be taken care of. Whether it will work or not, God knows. Time will tell. But I think is excellent to talk to all of you. You've been an eye-opener. It's such a good word. But I think the audience should also be aware of the fracture distal radius committed are two different: osteoporotic fractures and young adult, high velocity. So don't go with an idea that all badly committed fractures should be treated with this in patient with 75 years. SWIFT trial, multi-center trial in UK has mentioned, at the end of it, whether you fix it well, again, low demand patient. I'm not talking about highly, if they've got reasonable length, don't worry about the tilt. Reasonable length, treat them with conservative. At the end of 1 year, they'll do the same.
Yeah, and I know there's a lot of evidence for that in some of the studies, but we still have one more talk to go. So I'd request Dr. Sudhir Warrior to talk about plate removal in distal radius fractures.
Well, the race to capture the rim amongst all the companies is on. Everyone's reaching more distal and more distal and more distal. So Ashish will soon be able to rest as soon as they find what's the best solution. So my brief is to discuss whether I should remove these plates. These are my disclosures. Sorry, this is the learning objectives. That slide is missing here. Well, we should know which plates need to be removed, when they need to be removed, and discuss the best time to remove it. It's very, very obvious when you look at some x-rays, some plates must just not stay in. There's just no question about these plates staying in, so there's no question about talking about that. And what about removing all of the plates, so we don't have any complications? Well, in between are those patients which Ashish was talking about. Actually, most of my lecture has already been alluded to. Patient who's healing very well. All the angles look very good, but he comes with persistent pain after a healing fracture shows, but then he can pinpoint the pain. There is a weakness in grip, so whenever he tries to hold his wrist in a good strong grip, he says, it just hurts me. I can't get, my golf swing, my cricket, my badminton, So whenever they're using the maximum force, if they're writing and they're carrying their computers and moving around, nothing. Power grip is where they lose. Pain is arising from improper hardware or improperly placed hardware. So hardware that's very thick. So if the plate is too thick, there's no space there. God never made any space there. We are pushing in a plate and saying, oh, it's a safe area. It isn't a safe area if you don't know how to use that area. So if you use a very thick implant, there you lose. And if you have proud and prominent screws, obviously something is going to get. So improper hardware, don't choose that. Choose to change from that. What about improperly placed hardware? There are 3 points that you need to look at. One is the watershed line. Much has been talked about it. Everyone opens it and says, this is the watershed line. I am yet to see the watershed line. There is no line. It's all in your mind. Remember, it's 2 millimeters or so from the ulnar side of the rim and about 1 centimeter from the tip of the radial styloid. Once you have some numbers in here, you will pay respect to that line, which is in there. So be careful about the watershed line. All books will show you lovely diagrams and things like that. You open it and say, nahi hai yaar, aisa kuch dikhta nahi. So this is a patient who a few months after came to me and said, you know what, doc, I was doing very well and then suddenly my thumb just doesn't go in, and he's a guy who's doing a lot of these synthesizer, this thing, and he's a DJ and stuff like that. And he said, doc, something's happened. It's my right hand. I don't know what's happened. And I sent him for an ultrasound, and the ultrasound said, yes, the plate is too prominent, and yes, the FPL is ruptured.
So surely rim plates are monsters. They are necessary monsters. You put them on and then you take care of them and they'll give you the result, and then you please remove them. Rim plates have to come off. They don't stay for life. When does the tendon rupture? 6 years later. 4.8 years later. These are two studies that I'm quoting. So it's not that 1 year later or 2 years later, they'll come. 6 years later, it'll come to haunt you. When you think, I'm safe, suddenly you'll have a bunch of FPLs looking at you. So be careful about monster plates like that. Because the Soong grades, what happens is, if you have a Soong grade, the chances for removal of a Soong grade 0 is almost nil. A Soong grade 1, 7 times the chances that you might require to remove it for symptoms, and 33 times if it's a Soong grade 2. So if you put a Soong grade 2, something is wrong. Be careful. So what are these Soong grades? A little more detailed than what Ashish just spoke. So that's the line that goes along the shaft of the radius. That's the teardrop line. And if your plate lies underneath the teardrop and within the teardrop line, that's a Soong grade 0. That's a safe, nice plate. As opposed to, and these are my cases, as opposed to this one where the teardrop line ke bahar hai, but it still lies under the teardrop. So that's a Soong grade 1. And then it's the Soong grade 2 and this monster plate there, which is not only right up at the joint level or distal to the joint level, and definitely outside of the red line that you see, that is the teardrop line. So the Soong grades are very, very easily understandable. So what you have to look for is pain, undue pain in an unusual spot, not in the radiocarpal area, not on the radial styloid area. You're finding pain more proximal. That is what you look at. And crepitus. How do you look for crepitus? Abhijit just mentioned you can use a stethoscope. How many of you own one? Two hands. Wow, you all are guys who are still sticking to that. Well, anyway, what you need to do is very simple. You need to hold the patient's wrist in full hyperextension as much as you can and ask him to flex his fingers and feel the rim of the plate. And if you can feel the crepitus, if you can feel kur, that's a bad one. You ask him to move his thumb, and if he does kur, that's a bad one. So crepitus can be heard. The sonologist can tell you, but the simplest thing is to hold it in dorsiflexion that pushes the tendons onto the plate, and then you ask him to move in power grip and you'll find it happening. So here's the one who had that, obviously Soong grade 2 almost, and you see the yellow arrow shows that his EPL is gone and his screws are all over the place. So we had to revise that and we got that to do well. So what's happening inside is this. Pretty obvious. See the amount of reaction there is. See those blood vessels there. Those things don't occur normally. This is happening because there's something irritating. There's something happening over a period of time. I take this wire and I rub it on this smooth surface today, and by the time you come for next TraumaCon, this wire will be 2 pieces. I'm not going to do that, don't worry. The hotel guys are looking at me. So here's another one where this is a rim plate, which is, you can see the FPL, it is just waiting to die. So important thing is, we did see some examples where there was a problem with the plate and bone contact. So when you look at an X-ray, especially the ones that you've done like this, you say, oh no, you know what, I should have slipped it a bit more under. And you say, well, you know, it's okay, it's not doing too bad and things like that. But what you realize is you haven't restored the volar tilt. The entire principle of an anatomical plate is that you should get the anatomy right, then that plate is safe. Otherwise, you're exposing this to a problem. So that is the problem. So now this is a case where I have just taken a cropping of that image and I've tilted it to where it should be, and see what happens. It's the same image. I haven't changed the plate. I have done nothing. All I've done is restored the volar tilt and my plate is safe and happy under the overhang of the teardrop. Therefore, that emphasizes the importance of restoring the volar tilt. Every paper talks about the volar tilt. Why? Because you're otherwise exposing them to this problem. It's a safety requirement. And when you're rehabbing these patients, beyond 60 degrees of dorsiflexion, the FPL goes and sits on the plate. And if that patient is getting pain at that point when he's moving his FPL, don't rehab him with the FPL when you're getting his range of movements. So you've got to separate the two. Don't allow him to use his thumb in more dorsiflexion than 60 degrees. That's when the plate goes, the FPL goes and sits on the plate. So be careful about this and tell your rehab person, yaar karne ke time pe be a little careful. If you get pain in the thumb, do not allow the patient to move the thumb. Okay? So now we've seen the volar side. Let's see the dorsal side. How many of us, the distal most screws, let it be, but how many of us look at the length of the proximal screws? Never, almost never. There's a surgeon, very well-known surgeon, who told me once when I pointed this out to him in the OR, I said, yaar, 4 millimeter to bhar hai. So he's saying 4 millimeters is allowed. So I said, please tell me who is this allower? Because then I need to get a list of things. I've been messing up too much. I want to know whether it falls within this allowance. Don't allow. The dorsal side are the extensor tendons. They are gliding up and down on that surface. You normally miss it because you're all bad surgeons. Therefore, your patients are happy. But when they are long and you have not missed it, that patient is going to complain of pain on the dorsal aspect. So be careful about that. Here's a patient who came with that. And there's also what I like to call the Lister's bluff. You know what a bluff is? A bluff is a small, soft mountain. I like to call the Lister's tubercular the Lister's bluff because when you're looking at the lateral view, the Lister's tubercle will cover. And how much can the Lister's tubercle be? It varies between 1.4 to 6.6 millimeters. Can you imagine your screws can be 6 millimeters more than they should be, and you still wouldn't know it because the Lister's is covering it. So therefore, there is this Lister's bluff that covers the vital structures. And here it is in all its glory, hiding away one screw which you would never make out except post-operatively. The ultrasound, of course, will prove which screws are bad and what they're causing. So here's a patient whose plating was done and looked quite okay. And if you look at the lateral view, every screw is there waiting for an extensor tendon to come close to it. And this is what we need to avoid. Because it's not very important to put bicortical screws. Even if your screw is 75% the width of the bone, there is a study which says statistically similar stiffness, not equal, similar, elastic limit and load to failure in your favor. If your screw is a little smaller, it's safe and it's not getting your construct any weaker, not too much weaker. So that's good enough because it's not a load-bearing joint. And of course, the view that we spoke about, which is the Hoya view, which you take like this. You can also take it like this, which is what I'm showing here. And you can see the rim of the distal radius. If it's comminuted, you'll see it in broken pieces. And you can see that all the screws are within that. Don't forget this view. Either this way or even this way. You need to increase the kV of your C-arm. And you need to get it directly tangential. So on the dorsal side, you don't have any surface, but on the volar side, you have the pronator cushion. So why not use the pronator cushion? Enjoy the cushion. Put back the pronator. That gives you one full layer of help. And the pronator can, in grade 1 and grade 2, can easily be put back. In grade 3, where there's a multiplane tear with a bad injury, obviously you can't put it back. Try, but you may fail. That doesn't matter. Finally, plating. Whether you should remove or not. So when plating started in Finland 1998, the number of platings just went up. You can see the graph on top. It just goes up and then it goes up and it goes up. And then the plate removals was slowly creeping there. And then the two snakes suddenly change position. And you find it plateauing off. What does this tell you? This tells you two things. Number one, as experience improves and hardware is refined, we may need lesser hardware removal procedures. Two very important things. So we don't look at all of this, we won't realize that. So I looked back and I said, now I must also draw my creeping graphs and things like that. I put in the last 7 months, I put in 41 plates and I removed 20. Some of them mine, many of them others. Surely we are not following the Finnish example. We need better surgical diligence. We need better hardware. There was this study where they emailed 596 surgeons out of 3,000, replied and said, in the last 1 year, I had 33% of them, 1/3 of them said I had an FPL rupture, and 36% said I had an extensor tendon rupture. Can you imagine? There is a 60% chance of rupturing something in America. We are better surgeons.
Sudhir, you need to finish.
I'm finishing. Where does that leave me? 8 surgeons don't remove their plates. 1 surgeon removes all plate, 1%. 91% of them removed symptomatic plates. Therefore, if you have well-reduced, well-stabilized fractures, screw lengths are okay, volar tilt is okay, and you sutured the PQ back on, and you find if it's a Soong 2, remove them. Soong 1, watch them. Soong 0, go to sleep. Thank you very much.
Thank you, Sudhir. I think the last talk is by Dr. Apte. So, yeah. And he's going to talk to us about the current evidence.
Yeah, I was the opening batsman. I'm there over here till as a last man, not out even now. I'll be as brief as possible, sir. The slide.
We'll sit on this one.
Yeah.
We'll disappear.
I'll be basically talking about distal radius, current concepts. I'll be talking on the touchstone of classification and treatment, bone gaps, and implant removal. Let's move ahead with classification. These were the older classifications which had many limitations, like they never tell about the prognosis of treatment, about the guide for the approach, or post-fracture stability assessment. To overcome these particular limitations, a CT-based classification, which was shown over here by, I suppose, by Ashish, a CT-based classification was put forward, but in 2015 by Rickley. It is based on 3-column concept. It divides in a transverse section. It divides the radius and the ulna, or the distal radius, into 4 quadrants, as are seen over here. In a sagittal view, if at all the carpus lies on the dorsal side, it guides us towards the approach. If the carpus lies in a sagittal view on the dorsal side, then you can go ahead with a dorsal approach. If the carpus or the lunate is on the volar side, you may go ahead with a volar approach. Then in 2024, a recent classification that is called as 1-2-3 classification. This divides the distal end radius into 3 zones: the distal part, the radius or the scaphoid fossa, and the volar fossa. This classification, it helps us. Basically, it's a theoretical and practical significance for selecting an incision and guiding the fracture block reduction and internal fixation. Usually it is said that conservative treatment or surgical treatment, the final result is the same in longer run. But a draft 2 analysis, draft 2 trial, it mentions that surgical fixation with wires leads to less dorsal angulation. This is for extra-articular fracture I am speaking. Less dorsal angulation on radiographs and at 6 weeks, and a better result. A distal comminuted fracture, the distal bridge plate is a good alternative to volar plating for complex distal fractures, but with due respect to Dr. Sudhir Warrior sir, wherever they are indicated. What he had mentioned absolutely perfectly. I'm not aware about this thing, I have not seen it, but there has been a World Journal of Orthopaedics report in 2024 which mentions hemiarthroplasty is a promising treatment for irreparable distal radius fracture in the elderly. Coming over to intra-articular fractures, volar intra-articular extended window approach has been mentioned in this particular article and says to have a good result. Arthroscopy people they believe that it is not just the distal radius, but it is the carpus along with the radius in intra-articular fractures, and then hence they recommend the use of arthroscopy and correct the carpus deformity as well. As we all know, rim fractures, it's entirely a different ball game. MacLean, he presented a classification divided into 5 classifications, and he rightly mentioned that normal volar plates which we have been using are not useful in treating this particular entity called as volar rim fractures. Then what is to be used? A plate which was shown right now by Ashish, that was one, or there are certain plates, we call them as hook plates, which was mentioned. Most of the hook plates, what we have, they are subarticular hook plates, but there are certain supraarticular hook plates. The limitation of this subarticular hook plate is it pierces the smaller fragment over here, which is likely to get shattered, and that's the reason they are recommending now to go in for a supraarticular pin type of plate. Interesting article, I got it in Journal of Cardiovascular Disease and Research. That's a different story. It's an orthopedic article, but in this particular journal, emphasizes basically on the use of volar rim plate for rim fracture. A lot has been said about MIPO, but in distal radius fracture, MIPO is not recommended. It is not considered to be of much use or much help. Resuturing of pronator quadratus, it is again controversial. Some persons, a school of thought, they believe that it prevents or it cushions the muscles against the plate. Others, they believe that if we resuture this particular thing, it leads to more fibrosis, leading to pronation and supination restriction. Vascularized bone grafts, yes, we have the pioneer over here, way back, Dr. John Mukhopadhyay. He had the original article which speaks about using masculase technique in bone loss. Based on that article, this article was presented, and one more article, forearm non-unions for masculase, using a masculase technique, and that is a technique which has been recommended now in cases of bone gap. Implant removal, as Dr. Warrior sir has rightly mentioned, there are two categories of people: those who sincerely or seriously they have a complaint, and those who are in a habit of just grumbling that I want a removal. So a meta-analysis was done. Those persons with serious complaints or genuine complaints, they recovered well after implant removal. Of course, what Dr. Warrior has mentioned, those were the proper indications and a genuine complaint that is helpful. Others, they keep on grumbling, and hence it is not required to go ahead with implant removal. I thank you for your patient listening. Thank you.
Thank you, Dr. Apte, for the very apt conclusion. And thank you all the audience for staying on till this late hour. I really appreciate that. Thank you very much. And of course, to my fellow chairs.
नहीं मैं तो बता